this is a very specific policy for cancer care which is available in the market. Accidental cover. Now accidental cover is also one of the cheapest cover which is available with us. Okay, say for example around 10 lakh cover for the whole family will only cost you 3,000 rupees a year, 3,500 rupees a year. But the interesting part is even in case of hospitalization in the hospital due to this any mishappening or accident, they even cover 40% of your medical expenses. That is inbuilt in the policy. And in case you go in for even the partial disability benefit, then 1% of the sum assured, that is if at all the policy is for 10 lakh rupees, so 1% would be around 10,000 rupees, right? So 10,000 rupees, 1% per week for 100 weeks can be given to the beneficiary in case he is not able to join office. Okay, and if he has suffered a partial disability, that means the person would get 40,000 rupees a month. Okay, so and that would be given for next 100 weeks. Okay, so these covers are also there which would actually keep you financially stable during the time of your need. Now replacement covers are also available in the market, wherein you can go in for these policies where they cover your appliances which are there at home. They also cover burglary and theft. They also cover electrical appliances. They even cover your furniture in case of fire. Okay, so in case of any mishappening, this policy comes into play, and this also gives a kind of a financial cushion in case need be. Apart from that, you also have for the house, you have the policy which takes care of your in case of any natural disasters or natural calamities, then earthquake covers are also available, which you can go in for at a very throwaway price, which covers the cost of construction of the flat, because land remains the same. Land ko kuch nahi hota hai. So the cover is only for the construction of the house in the event of any kind of mishappening, even earthquakes. So that, and this is also available at a price of say around 10,000 rupees for 10 years, which covers around 30 lakhs of where patients are suing the doctors. So and dentists are no different. So one is, and this is also very cheap cover which is available to us at a price of say there are many companies and there are many like you can go get a cover of 30 lakhs for a premium of 2,100 rupees, and it covers all your legal expenses, and it also covers your in the event of any kind of settlement outside court, that is also covered by the company. So as I said, professional risk coverage covers almost everything. There are companies which are present in the market which even cover your personal cases. They charge you a yearly subscription which is to be paid upfront, and they cover most of your legal side of it. Now, another thing, most of us go in for these home loan. Now, there is a debate that one can go for the new tax regime or even the old tax regime. One can stay with. So, in my opinion, in case if an individual is just starting his practice, he can go in for a new tax regime, because Now doctors come under 44 ADA also of the Income Tax Act. So nearly 14 lakhs of their income would be, or the gross receipts will be tax free in case somebody is starting the clinic. 14 lakhs is a very big amount. So they don't have to pay any tax on an income of 14 lakhs. Now coming to people like us who have who had home loans. Now home loans is an interesting thing which gives you a tax benefit of up to 2 lakhs. You should always take property in joint name, because both the borrowers can get the benefit of the interest rebate on home loans individually if they are earning and they are filing their returns. So both, in the case of a joint property, both will get a tax rebate of 2 lakhs each. In case if you are staying with your parents and if you have bought house for investment, then always rent it out, because if you rent out the property, then there is no limit. If your home loan interest is even more than 2 lakhs, 3 lakhs, 4 lakhs, 5 lakhs, everything is taken care of and it just gets strike off with your salary. Okay, so if at all you are getting a salary of 20 lakh rupees for an example, and if you have an interest on home loan of 5 lakh rupees, so apart from the investments what you do under 80C and 80D and also NPS, you also have 5 lakh cover. Immediately your gross income will become from 20 lakhs minus 5 lakhs, 15 lakhs. Okay, so if you come in 30% bracket, you are actually saving a tax of 1,50,000. And again, the rental income is very interesting, because in case of rental income, you also get a standard deduction of 30%. So if at all you are earning a rental income of 1 lakh rupees, so immediately 30,000 would be deducted as a standard deduction for repair and expenditures, and whatever the interest is paid on the housing loan is deducted from the rental income. So in case your interest from housing loan is 2 lakhs, 3 lakhs, 4 lakhs, 5 lakhs, it is immaterial. It will come into negative. So you don't have to pay any taxes. So you can use this as a tool to save your taxes. In case somebody has multiple house properties, then there is a problem, because it's good to have multiple properties, but then the second property would be considered as deemed rented, even if it is vacated, if it is in vacant form. So one has to be very careful, because if you have second property, you must rent it out. Otherwise, as per income tax laws 1965, it will be considered as deemed rental, and you will have to pay tax on the rent which you are not actually getting. It's called a notional rent. You will have to pay tax on the notional rent, even if it is in different locations in India, not necessarily in the same town. Now this is also very interesting. In case if you have anyone in your family, your parents, who can support you in when you are buying a house, then there is no, it's a very good thing, because you can have a home loan agreement with your parents, okay, on a notarized stamp paper, and you can pay them the interest what they will get in FD. Okay, fine. Suppose if the parent is getting 9% interest on FD, the same you can have a agreement with your father or mother, and you can take money from them as home loan. You will not get any benefit of the principal amount, okay, but principal amount of home loan is already only adjusted under 80C. So if you are having PPF, if you are having LIC policies, you may not require that 80C benefit, but the interest benefit will always be there for you. And that interest what you are giving to your parents, okay, anyway they would have earned from the FD, okay, but over here you are giving interest income to your parents, okay, and you are claiming interest benefit also as per Income Tax Act. So it is like you are putting the money in one pocket and taking out from the other pocket, and the money rotates within the family only. Okay, Got it. So this is something which is quite interesting, which can be done in case I have done this. Okay. So all this what I am telling you now is my personal experience, which I have been very prudent in investing since 2001, and whatever inclusions I have told today are my personal experiences. And all the covers what you see, except for the term cover, are there in my portfolio. Okay. Now, as I told you, inclusion of the section in the 44 AD of the IT Act since 2016 and 17 is also very beneficial to the doctors, because then you don't need to keep any books of accounts. Okay. Whatever are your gross receipts, it will be immediately 50% of it will be considered as an income. Okay. And it will be deducted, and you will pay taxes on only 50% of it. Okay. We are not as lucky as traders are, because if we would have been traders, then up to 1 crore, 6% of the gross receipts are considered as profit. So if I would have been a trader and I have I have receipts of 1 crore, then what would happen? 6 lakh rupees, 6 lakhs would have been considered as my profit, and I don't have to maintain any record. But as doctors, if you are having an income of 1 crore, then 50 lakhs will be considered as your gross profit. But yes, there is one catch. Up in 44 ADA, you can only show income up to 50 lakhs as gross receipts. More than 50 lakhs, you will have to do audit in as per norms. Okay. But over here, you don't need any audit, and you don't need to keep any books of accounts. Whatever is your gross receipts will be considered as your income. Okay, 50% of that. So personal finance is not an enigma. It is not impossible to understand. It is just a subject that many avoid, but don't be one of them. Start now and get smart with the money. Thank you and happy investing. Acknowledgements. Thanks to my brother Aditya and Ashal Johari from Asan Idea and Wealth. We are a group of almost 1 lakh individuals on the Facebook, and we've been discussing about financial prudence on a daily basis. Thank you. Any questions?
So after this lecture by Dr. Deepak Bhargav sir, we have our next speaker of the day, and that is Dr. Dinesh Kumar Bagga sir, and he is the professor and head of Department of Orthodontics from Sharda University. So I welcome you sir for the lecture. I request you all to please give a round of applause for sir.
Good morning, all. Today, I'll be speaking about the information mastery in medical research. The a huge set of information is around us, and to decide the healthcare services. So, this information mastery is very important for the appropriate care of patient health services. So I'll touch upon the evidence-based practice, sources of evidence, information mastery, usefulness of evidence, locating information from available sources, strength of recommendation taxonomy, value-based care, and then summing up all these areas. The patient presents with a condition, the doctor queries the patient, gathers information from physical examination and other diagnostic measures, attempts to arrive first at an answer of what the problem is, then what caused the problem, then finally a solution or treatment to the problem is selected from a menu of options. The contemporary patient expectations regarding problem-solving approach of the doctor are the healthcare provider is paying attention to the wants and needs of the patient above all else. He is delivering the most effective means of arriving at an accurate diagnosis, then providing the most appropriate care, and the expected outcome of treatment meets the needs of the patient while remaining affordable. So we need to understand that the patient is at the center of the decision from starting till the end. So EBM is patient-centered, that is, the patient is the center of the decision process, starting with choice of diagnostic procedure, then the selection of treatment, and finally, he is the evaluator of the success of treatment. It all depends on his own feedback. The evidence, what we talk about, the evidence which has to be incorporated into the practice, has to be patient-oriented evidence rather than disease-oriented evidence. The outcomes that matter to the patient also matter to the doctors, and these are patient-oriented evidences. The outcomes can be characterized as the reduction of pain or improved function, improved quality of life, reduced mortality, and reasonable cost, which actually matter to the patient as well as the doctors. Patient-oriented evidences are essentially the scientific evidences regarding how long or well the patients lead their lives. If a POE would change practice, it becomes a poem, patient-oriented evidence that matters. Nowadays, patient-oriented evidence is becoming more common, but the medical literature is full of examples of studies that relate to disease-oriented evidence. These studies eliminate the etiology, prevalence, pathophysiology of the diseases, lab values, the blood chemistry, blood pressure, etc. Now, as an example, you can understand that disease-oriented evidence is like, which is related to the etiology, pathophysiology, prevalence, or any kind of blood chemistry and all. So same way, the beta carotene and vitamin E are good antioxidant, and supposedly they must act nicely in cases of cardiovascular disease and the cancer. When we come to the patient-oriented evidence, we find that neither vitamin prevents cancer or cardiovascular disease. That means that DOE is not supported by POE. And another example, antiarrhythmic drug X decreases the incidence of premature ventricular contractions or ECGs, but when we see patient-oriented evidence, this antiarrhythmic drug is associated with an increase in mortality. So it is not only supporting, but it is contradicting. POE is contradicting the DOE. So the available current evidences show that the needs of the patients are not addressed in a patient-centered way, nor the outcomes as good as doctors believe. So unless the patient is kept as the evaluator of the success, nobody can know that what exactly the success is. The evidence-based care and patient-centered care, this is either or model. When it is integrated into it, then we can give evidence-based care and patient-centered care. Then there is cyclic model, which are feeding each other, then continuum model that constantly the evidence-based practice and patient-centered care, both are in tandem. There are 5 steps of evidence-based practice. The 5 is ask a question which is patient-focused. It can be in PICO format, properly formulated as a patient's need. Then access the information or acquire the information. You have to find the evidence through literature search. Then appraise the articles found. There has to be critical appraisal of evidences. You have to dissect the methodology. You have to see the statistical analysis, the study design, and the biases, errors, or involved, what is the accuracy of the study. Then apply the information, incorporate it into the practice, then finally audit impact. Whatever is applied into the practice, you have to know whether this is working well or you need some further research studies in the same direction. The development of the question to be answered must be patient-centered, focusing on issues that matter to the patient. The doctor analyzes the patient within the context of evidence that is relevant to that patient, and then making the treatment options understandable by the patient in a relativistic way based upon the highest order of evidence available. And you have to explain their expected outcomes and possible unwanted outcomes so that patient can choose out of them. The reliance of clinicians on quick sources of information such as textbooks, review articles, electronic media, colleagues, etc. may be of great value, but there is a high probability that they are out of date or biased. It is the bias from the expert who is speaking on that, because he will be choosing the publications according to his own choice. So there is so much subjectivity involved, and there is so much opinions from the expert involved. So many feel that the healthcare providers, by reading current literature and attending CME courses, keep themselves updated and offer their patients the best health services based upon the best current knowledge. One of the most ingrained biases in all medical literature is highly selective patient population described in manuscript, as often the idealized patient in a study is not very similar to the patient in the doctor's practice, where the real world patient has multiple problems. It doesn't match, so it is very difficult to incorporate into the practice. So unless we have the correct best evidence, we cannot incorporate it. So there are three main sources of medical information that can be used in generating evidence. The first level of information or primary source material is the collection of original publications that answer the questions about patient care. The evidence generated is evaluated to determine if further evidence is needed to better solve the original need. The dissemination and implementation of the evidence becomes imperative to improve quality of patient care. The second level of information is the synthesis of opinions and creation of literature that informs clinicians about what is available. This group includes review articles, textbooks, online texts, and review literature, which is full of bias. So truthfulness is missing whenever there are errors involved in it. As a source of evidence, the second level is highly variable in that expert opinion may supersede the synthesis of the best evidence, and other biases may creep into the review product. The third level is the assimilation of best evidence via systematic reviews, which is the qualitative synthesis of the available evidences from various original studies. So that is synthesized through the qualitative analysis in an objective way so that biases can be controlled. And then, if possible, if it is quantitative, there is homogeneous studies, we can include them, and we can go for further quantitative analysis that is known as meta-analysis. So we can generate the third level of evidences. Studies that combine first level evidence into stronger support statements or non-support statements of diagnostic and treatment evidence. Medical knowledge is stratified in a pyramidal formula created by Bloom in the 1950s. Recall or remembering is the entry level of knowledge, with understanding and applying the next two levels that are necessary in medical practice. If you know Bloom's taxonomy, it starts with remembering or recall, then understanding, and then applying. So most clinicians operate mostly in the first three levels of knowledge and rely on sources that can analyze, evaluate, and create the understanding and application for improving medical knowledge. This taxonomy of learning is similar to the creation of best evidence and application to patient care. So clinicians are working in first three levels of knowledge, the remembering, understanding, and application of knowledge. But whatever they get from researcher through analysis, through evaluation, and through creation of knowledge based on that. So this is the Bloom's taxonomy. The dissemination and implementation of evidence is essential to improve quality of patient care, and later on, an evaluation of care after implementation is needed to determine if more and better evidence is still needed. So we can go further. EBM has created a hierarchy of evidence with greater credibility to the randomized control trials and highest level of evidence than non-randomized trials and case comparison studies. The case series and expert opinion, they make the lowest levels of evidence. There remains a great deal of reluctance on the part of practicing physicians to abandon their comfort zone in the reliance on expert opinion and the studies due to unaddressed problem of relevance, since most studies do not include the complexity seen in most real-world patients. This is the quality of evidence which starts with the observational studies, then through a controlled study by putting the intervention by the experimenter, then finally critical appraisal through systematic reviews and meta-analysis. That's how we increase the quality of evidence available. The usefulness of evidence. Information mastery is the applied practice of evidence-based medicine. Simply stated, the information mastery provides the simplest solution to the problem, with the important features of process being likelihood of success and ease of access to the information needed to make judgments and decisions. So this ease of access is very important with the relevance and validity of the evidence. Evidence should be good, it should be relevant, it should be valid, but the access to it should be with minimum of work, it should be easy access. So the guidelines based upon evidence facilitate the doctors to follow key elements of evidence-based practice without having to do extensive literature research and analysis, which makes him to dissect the methodology, to search for the study design, to go for the statistical analysis, and to look for biases, errors, whatever, how much accuracy is involved, what kind of evidence it is making. So it is a very tiresome job, and clinicians do not have the time to spare for that. So this is one of the fundamental principles of information mastery given by Slauson and Ellen Shaughnessy. The usefulness principles expressed as an equation, the relevance into validity divided by work. This is not a quantitative equation, but it gives a sense of relationship between key elements of best evidence, where relevance is similarity of the real world patient to that portrayed in the guideline and general applicability of the evidence. And validity is the scientific truthfulness of the information. And work is the amount of time spent and the energy, the effort, finding the answer to a question in clinical diagnosis or treatment. So validity is of prime importance, with relevance a close second. Information that is not valid is not useful, but information that is not relevant is also not useful. If the amount of work to find evidence is excessive, the clinician will not consistently put that amount of effort into the process. Other sources of information become the default search engine, like textbooks, review articles, etc. There is ease of access, but the problem is the validity of the information. The best use of internet is not to have a search engine deliver thousands of journal articles that would take countless hours and a great deal of analytic skill to synthesize a treatment. The internet can now provide rapid access to treatment guidelines, protocols, and algorithms based upon highest level of evidence that will produce good outcomes at reasonable cost. So that time is best spent gathering evidence and EBM guidelines instead of laborious process of generating the best evidence. So Slauson and Shaughnessy have created and tested a curriculum to teach the principles of information management, and they suggest the 3 levels. Level 1 is for clinician who can use the concepts to make better patient care decision, and level 2 is for teachers who teach clinicians the curriculum and provide evidence-based reviews of original research. Then level 3 is for researchers who are adept at conducting decision analysis, meta-analysis, and other techniques of synthesizing raw research information into usable clinical information so that clinical practitioner can use it. Locating information from available sources. With evidence-based medicine, there is no need for doctors to memorize and catalog volumes of information just in case they need it. There now exists just-in-time information that is processed into usable guidelines that inform and educate the patients with a more reliable systems-based solution that protects patient safety and delivers better outcomes in place of the individual decision-making of physicians, which may be of bias, because it is system-based solution. There are 2 tools in information mastery that apply to just-in-time application of evidence at the point of care, that is foraging tools and hunting tools. These are various hunting tools, and you can upgrade EBM skills. They are available. For example, these are NHS guidelines. Everybody is familiar with that, or clinical evidence, or ACP PIRS, physician information and educational resources. So these foraging tools are basically for the patient-oriented evidence, so that easily you can access to the relevant information. So this is a high-quality foraging tool which employs a transparent process that filters out disease-oriented research and presents only patient-oriented research outcomes. It demonstrates that a validity assessment has been performed using appropriate criteria, assigns levels of evidence, what kind of evidence it is, based on appropriate validity criteria to individual studies. It provides specific recommendations when feasible and on how to apply the information, placing it into clinical context. Then comprehensively reviews the literature for a specific specialty or discipline and coordinates with a high-quality hunting tool. The hunting tool is also a high-quality tool which employs a transparent process, and it uses a specific explicit method for comprehensively searching the literature to find relevant and valid information. It provides key recommendations supported by patient-oriented outcomes when possible, and when not, is specified as preliminary when supported only by disease-oriented outcomes. So it is a comprehensive tool, and it assigns levels of evidence or strength of recommendation to key recommendations using approved criteria in terms of strength of recommendation taxonomy that is sought, and it coordinates with a reliable foraging tool. So strength of recommendation taxonomy is sought is basically a simple rating system, and that meets the conditions of the usefulness equation. That is, it provides easy access to the information with high relevance and validity. The strength of recommendation grades, it can be A, B, C. If it is consistent, good quality patient-oriented evidence, it becomes A. Inconsistent or limited quality patient-oriented evidence, it becomes B. And C is consensus, disease-oriented evidence, usual practice, expert opinion, or case series for studies of diagnosis, treatment, prevention, or screening. Patient-oriented evidences, as I have spoken earlier, that it measures outcomes that matter to the patient, maybe morbidity, mortality, symptom improvement, cost reduction, and quality of life. When we talk about disease-oriented evidence, these measures are intermediate, physiologic, or surrogate endpoints that may or may not reflect improvement in patient outcomes. That is, maybe blood pressure, maybe blood chemistry, maybe physiologic function, maybe pathologic findings on any kind of etiology based on the lab values. The ideal source for the best evidence should be independent of bias. So the hunting tool thoroughly searches the literature, expertly assesses the validity in a transparent manner with a description of the process used in generation of evidence, as well as conflicts of interest with stakeholders in the results of evidence, and then summarizes the content in a concise, readable outline for the reader. In addition to hunting tools that zoom in on the relevance and validity are the second major type of location tools, that is foraging. As with hunting tools, these foraging tools provide a valid, updated information of patient-oriented evidences in a transparent way, explaining the process used in generation of evidence, as well as conflicts of interest among stakeholders. The habitual use of foraging tool prompts the clinician of patient-oriented evidence that will keep practice current. However, some review of the relevance and validity of these sources is needed before adopting recommendations. Unlike hunting tools, the practitioner is not looking for clinical pathways or immediate answer to patient care questions, as it is not at the point of care application, but is part of background work that should be done by those assuming patient care responsibility. The relevance is the patient-centered aspect of EBM, that is identifying patient-oriented evidence that matters, and he should look for that, but he can go for further the available critical appraisal. 3 questions that help assess the evidence as poem, to put it in poem category. Did the study or guideline evaluate an outcome, and is the outcome one that the patients care about? Did the study or guideline evaluate a condition, disease, or issue that is congruent with patients in your practice? And lastly, if the evidence is true, would the discovery of that truth require you to incorporate this finding into your practice. Validity is the most scientifically and intellectually challenging element of evidence-based medicine. Analysis and assessment of information that is considered evidence is difficult and time-consuming. It is most difficult to arrive at a judgment about the validity of any medical research without the background needed to dissect methodology, statistical plans, bias, and accuracy and error. So that there only this information mastery helps. Having reliable hunting and foraging tools brings the worlds of evidence back into the realm of patient care for the majority of clinicians who do not have the time to apply scientific rigor to patient care information. Then Slauson and Shaughnessy have described the value-based care, what is the value in healthcare. And when we talk about value, value is basically the quality divided by the cost. And when we talk about the cost, it is direct cost as well as indirect cost. Quality is desired outcome of treatment, while cost is monetary amount needed to provide that treatment. So cost includes the added expenses of treating complications, errors, and poor results, plus the loss in earnings and savings required to pay for services. Improved quality increases value, as does decreasing costs. EBM guidelines attempt to improve the quality metric of patient care by bringing the delivery of an outcome that is closer to the expectation of the patient. There is evidence now that improved quality by reducing unwanted outcomes and complications will reduce cost. So that's how the value increases. To sum up all, EBM offers patient-centered decision-making and patient-centered care. The shift from expert opinion and experience-based learning towards best evidence and clinical practice guidelines is a shift to improve quality of patient care. Critical evaluation of patient care requires a metric that is based on outcome meeting the patient's needs and expectations with a newer medical knowledge as a delivery system of evidence to the patient to the point of care. Familiarity with sources of best evidence and practice guidelines is a reasonable next step to improve upon historical performance of healthcare providers. Reducing errors and complications, improving compliance with best practice, lowering costs, meeting patient expectations are lofty goals that require a newer way of problem solving than that of the past century. And finally, using available information sources and experience, information mastery facilitates putting that which is better into practice and will create evidence-based patient-centered care. Thank you very much.
Thank you, sir. So that was Dr. Dinesh Kumar Bagga, sir, who spoke about information mastery in medical research. Thank you, sir, for the wonderful lecture. Now it's time to move ahead with the next lecture. For the next lecture, we have Dr. Chaitali Parekh ma'am, all the way from Ahmedabad. For her intro, she has done her master's in orthodontics and dentofacial orthopedics. She has done her fellowship in facial and maxillofacial aesthetics, and she is a proud alumni of IIM Indore. Apart from orthodontic clinic in center of the city, Ahmedabad, she is the founder of her own hair oil company, and she is the conference admin at Goenka Institute of Dental Sciences and is the official provider of Invisalign in India. We welcome you, ma'am, and we eagerly wait for your lecture to begin. Dr. Chetali ma'am is going to deliver the lecture on complete guide to smile makeover, braces, aligners, veneers, what, when, and why. So if you have any doubts or any queries, you can contact or have a discussion with ma'am after the lecture.
Very happy morning, all of you. I've been said that we have to finish the lecture in half an hour, and it's very difficult to concise everything about braces, aligners, veneers. So let's keep it a little interactive. May I know if there is any orthodontic friend of mine? No, any ortho PGs? Anyone who is doing smile makeovers in their practice? All of you are students? Okay. So what is the basic difference if I say between orthodontics and veneers? Anyone? Ortho में क्या करते हैं? Do you like to share something? Yeah. Malocclusions treat करते हैं. Right. Very rightly said by the beautiful lady. So we want to straight teeth when we talk about braces and aligners. And when we talk about veneers, we want to actually change the shape, size, and if there is a discoloration. So we can't change the position of the tooth when doing veneers. So a little alignment with braces or aligners will always give you a better result if you want to do a smile makeover. It's not worth it. The time he helps me. So I'm happy to say that I have performed more than 1500 smile makeover cases in my journey of 7 years in orthodontics and veneer practice. This is my Insta account. You can follow me there. I regularly share all the updates and we discuss cases with young practitioners who want to incorporate braces, aligners, and who want to grow their orthodontic or veneer practice at their clinics. So what is that one thing that should come in our mind when a patient wants a smile makeover? Remember, it's never an emergency procedure, right? It's an elective procedure. We want to, patient already has teeth. They have healthy teeth. You want to enhance the smile, or you want to do some tricks and picks here and there to make the smile beautiful. So you can never afford doing anything which is not in favor of a beautiful smile, of making the smile better than what it actually is. So sometimes it becomes very tricky to give ideal results in these cases because there is so many constraints like patience, duration of the treatment, and cost, of course. So to make a good smile, you should know what makes a great smile. So of course, alignment of the teeth, minimum buccal corridors, a good gingival, minimum gingival display, a smile arc. If you see, so the lower edges of your upper incisor should always be in consonance with your lower lip, which is very essential for a good smile. minimum gingival display. If there is more gingival display, it will result in a gummy smile. Of course, alignment of the teeth, anterior and posterior occlusion, and facial symmetry. So facial symmetry can be affected with jaws, alignment of the jaws, maybe the midline, the dentition, if there is a crowding, there is spacing, generalized spacing. If there is a structural problem, there can be a skeletal class 2, class 3. So you always want to look for structural balance, which is your skeletal class 1, skeletal class 2 or skeletal class 3, whether maxilla at fault, whether the mandible is at fault, whether both the jaws are at fault. Then you should maintain functional efficiency while giving a good smile. Patient should be able to chew. नहीं तो आके मारेगा कि अच्छा स्माइल तो बहुत ब्यूटीफुल हो गई, खा नहीं पा रहा हूँ. And your aesthetic harmony for which the patient has actually come to you. So what is going to make a good smile is the shape of the head. You might have noticed everyone in the room, they all have different shape of head, different profiles, a straight profile, a convex profile. Usually a class 2 skeletal patient is going to have a convex profile or a concave profile. A class 3 patient usually has a concave profile. Facial symmetry, as we've discussed, the lips. Lips can be, have you ever seen patients having open lips? They can't close their lips properly. There is potential incompetency of the lips. या फिर वो बंद ही नहीं कर सकता है, that is incompetent lips. So the shape of nose, size of nose, the direction of nose, facial divergence, whether there is a straight profile, but the patient's profile is anterior divergent or posterior divergent, chin, the nasolabial angle. What is the nasolabial angle? The angle which is formed by your upper lip with the nose. So when does it tend to increase? Or there is an acute nasolabial angle in case where there is a upper lip protrusion, जब ऊपर के दांत बाहर है, या there is a crowding also leading to proclination of teeth. So in that times you will notice potentially incompetent lip or lip strain of the patient. And of course the intraoral examination, like we all study in all other rotations, the present teeth, missing teeth, and etc. So what makes orthodontics different from veneers? So veneers we are not changing position of the tooth, but in orthodontics we want to actually change the position of tooth. In case the veneers are needed, it can be beautifully placed and the work can be done with utmost precision when, of course, and the tooth preparation is going to be very minimum. If the alignment is already done, things become easy. So I feel we are in the best era to practice dentistry. I think all my colleagues and ma'am and everyone would agree to that, because we have the best lab support right now. In years we did not have. We have the best porcelain ceramics which give like 10-15 years of warranty. So we can do the work with utmost precision and patient can trust in us because we can deliver good results. Best technology in terms of scanners, they have gone like 5D and 6D and 7D now. So patient chair time and duration of the treatment has become very easy. Of course, we have products like Invisalign who are doing most of their revenue is spent in the R&D, and every year they are coming up with regular updates to deliver better results in terms of aesthetics. So not necessary that the patient has to go with braces now. So a veneer is a thin shell, like we have eyes, lenses for the eye. So, similarly, a veneer gets bonded to the enamel of the tooth and becomes one unit. So orthodontics. So we have different kinds of braces. Traditional braces, you all have seen metal braces. So what are self-ligating braces? Self-ligating braces is nothing, it looks same like traditional braces, but it has shutters. Shutters to close the wire in the bracket. So जो bracket और wire के बीच में पहले elastics के वजह से जो friction पैदा होता था, वो अभी self-ligating braces में नहीं हो रहा है. So the treatment is faster, patient can eat properly, chew properly, brush properly, And oral hygiene maintenance with these appliances become very easy because there are no elastics, which creates friction between the bracket and the wire. So treatment is like 6 to 7 months faster than the traditional braces. So we are blessed to have self-ligating braces in ceramics also. So white colored ceramic braces, metal self-ligating braces, and of course the traditional metal and ceramic braces. And booming, clear aligners. Everyone wants to do clear aligners. Jahan dekho sab aligner, aligner, aligner. So what is an aligner? How is it different from braces? So braces में जो bracket और wire होता है, similarly, what is an aligner? Aligner has these attachments that we place on the surface of the tooth, and the aligner is going to act like a wire. So when the patient is wearing the aligner, via the attachments, the aligner is pressing force on your teeth and which enables the teeth to move. So clear aligner is nothing but transparent braces. Rightly said that it's very comfortable. Patient can eat and drink whatever they want in between wearing their aligners. So average aligner wear is 22 hours a day if the patient is wearing. And now there are so many updates that aligner wear is shifting from 2 weeks wear to 1 week wear. Okay, so we'll discuss more about Invisalign. So how is Invisalign different from other aligners? So Invisalign has a smart tracking material, it has smart force features and smart stage technology. So what is it? Smart stage technology सब जगह पढ़ा है, सुना है, पर actually क्या है? So we all know that we will start with keeping end in mind. So smart stage technology is nothing but knowing that when your patient is wearing his 10th aligner. तो 10th aligner पे patient की teeth movement कितना तक हुई होगी if the patient is actually wearing his aligners regularly. So that is what you can predict. So there is minimum discrepancy between your predicted end result and your desired end result, which is the main thing when using aligners, because it is a blind process. You're giving 20 sets, मान लो 20 sets of aligners you're giving to the patient, and you don't know where 14th set पे कितना alignment हुआ होगा. Patient keeps asking you कि अभी तक result क्यों नहीं दिख रहा है. So you have to let the patient know that okay, in this stage we are expecting this much of the tooth movement. When you come to 16th, we are expecting this much of the tooth movement. So very essential, smart stage technology. So as I said, we have the best companies in dentistry right now who are spending most of their revenue for the R&D because they want to sustain competition. So us chakkar mein we are getting good products, good technology, and it's becoming more and more affordable as time is passing by. So competition is always healthy. So if we talk about Invisalign, it has done the same over years. We can see that every year they have brought some new innovations in the technology which has actually revolutionized orthodontic practice worldwide. So you'll be happy to know that Invisalign has done more than 14 million plus mile transformed with Invisalign across the world. So yeah, we can say that it's the most trusted clear aligner system that we have today. So if we see over period of time 2015 and 16, so now we can also treat cases with all 4 extractions and with complex malocclusions and full crowding cases. We can do all these cases with aligners, which initially wasn't possible with other aligner systems and also with Invisalign. So now they've come up with predictability and 1 week wear. So why 1 week wear? So initially they used to have these attachments and the aligners, the patient had to wear it for 2 weeks. So now because of the smart track and smart force features with optimum attachments, we've shifted to 1 week wear of the aligner if the patient is wearing it for 22 hours. So this has really reduced the total duration of time. So if the patient is a light case, patient needs 14 active aligner treatment. So that is like 14 weeks of active treatment, which is so easy and so fast. Invisalign Teen. So now they have introduced Invisalign Teen, which has aligners with precision cuts and precision attachments for mandibular advancement. So we can use Invisalign in children, in teens. So how do we start? So of course, scaling, polishing, any prophylaxis if needed, cavities, rule out everything, and we scan the patient. We scan the dentition, we take radiographs, we take lateral cephalogram if needed, and OPG, and we upload the case with all extraoral and intraoral pictures, and then we upload the case for his virtual setup. So then, this is what I was talking about. These are this right side picture is showing the aligner with some space in the canine. Can you see? So what is it? It lets the canine erupt. So these are the eruption tabs that also we can use in patients who have buccally or highly placed canines. So initially we did not use aligners for complex cases where there was impacted canine. You want to bring the canine into the arch, but now yes, it's possible. These are the bite ramps. You don't actually fill the bite ramps, but the bite ramps are actually incorporated within the aligners, which will let the bite jump. And the precision cut for advancement of the mandible or some settling of the occlusion if needed. So this is the mandibular advancement. We all have heard about twin blocks, right? Twin block appliances. So what is it? This is similar to twin block appliance, but here the advantage is that the alignment of the teeth is also simultaneous with the twin block, with the mandibular advancement. So with braces, usually we do alignment and we come to a 1925 rigid SS wire, and that is when you can put a fixed functional appliance for mandibular advancement after the age of 15 or 16 years. But yes, with this, it's possible. The alignment and mandibular advancement goes hand in hand, so the treatment duration drastically reduces in patients who are growing. So what is a pontic? So if you are doing more of GD work, you'll always come across patients who require minor alignment for replacement of the tooth, right? Ma'am and sir and they all would have come across these patients जहाँ पे बहुत सालों से दांत नहीं है and the tooth have taken up these spaces, maybe supra eruption or some drifting has happened. And if this is in the anterior region, so the patient wants tooth immediately. So in these cases, what are the options that we have? So we have aligners which have these thin layer of white colored composite, or you can say white color enamel jaisa they paint it on it. And when the patient is actually wearing the aligner, the treatment is going on and hardly noticeable that there is a missing tooth. And the beauty of these pontics is when the tooth is actually moving, the pontic is going to increase or decrease the space as needed. So it actually takes up the space which is available during the treatment also. During all the active aligners, the pontic is going to take the shape. So whatever corrections you are doing with the aligners, the patient is going to have a tooth replacement, apparent tooth replacement even during the treatment. So these are the compliance indicators. Patient आके बोल रहा है 3 महीने हो गए कुछ रिजल्ट नहीं मिल रहा है, क्या करोगे? क्या प्रूफ है patient is wearing the aligner or not? He might not be, and since he's not wearing, we are not getting the results. So what do we have to track whether the patient is wearing the aligner? So these are the compliance indicators that you can add to all your aligners. You instruct the company to give compliance indicators on your, of course they price a little extra when you want compliance indicators, but this blue dot, the pigment is a food pigment, it's edible pigment, and it fades with time. So if the patient is actually wearing the aligner, you can check the shade of the pigment and see if the patient is actually wearing or not. So that is how you make sure that the patient is wearing, and if he's not wearing, since he's not wearing, he's not getting the result. Okay, so this is one of the cases. So very simple case. Looks very simple, right? So if I want to do veneers for this patient, you might have to reduce a little more enamel. So in this case, we did some alignment changes and then gave 2 veneers with teeth whitening. So then if there is not treatment duration constraint, which in most of the patients while doing cosmetic smile makers, they always come with, अच्छा 2 महीने में मेरी शादी है, 3 महीने में शादी है, परसों शादी है. Patients are crazy, you know. So कुछ भी करके आते हैं and you have to deliver whatever best in your hands. So if you have time, a little alignment will always help giving good results. So one more case where there was crowding and we did some alignment and then gave veneers to the patient. Same. So this is also a case treated with Invisalign, and such malocclusions can also be treated with aligners. It was an all for extraction. So this is a case. Now the patient got braces done. There was a mesodents in between. We removed the mesodents, we closed the spaces, we did some alignment and some retraction of the space. We removed the frenum as it was highly placed, doesn't relapse whatever space we've closed. So this patient can also get a good smile if there was added veneers done. But veneers, as I say, if you do 8 veneers upper, 8 veneers lower, plus Invisalign or braces, the treatment cost is patient, you have to charge a bomb from the patient and not all the patients can afford it. So whatever best possible in our limits, you try to deliver. In this case, as you can see, there is protrusion of the upper anteriors, there is spacing, generalized spacing, patient had got tongue thrusting habit. So I closed the spaces, retracted some of them, patient is very happy with the smile. But what is that? It little seems off track, right? Not that attractive smile. Why? Look at the gums. Okay, you might have seen very beautiful cases, but I actually chose cases to show you what, even after doing so much, 1.5 years of treatment, and still I am not happy with this smile. Patient is very happy, of course. Why? Because the gums, the zenith of the tooth, they are not matching. So if there was a little gingivectomy done here and there on the canines, on the laterals, this patient would have turned up with a beautiful smile. One more patient, 1 महीने के बाद शादी है, there's a diastema, there's a highly placed frenum, so we did direct composite veneer. So in this patient, we did some alignment and then we gave veneers to the patient. One more patient, 2 महीने के बाद शादी है, okay? Patient का budget बहुत ही, it's very constrained. तो क्या कर सकते हैं? Such a high diastema, and if you can see closely, there is a frenum on the ridge, highly placed frenum. Whatever you do, it tends to relapse over a period of time. So what we did in this patient, we distributed this space over 4 veneers. Of course, 6 veneers would have been wonderful, but because there was a budget constraint, we tried to do it with 4 veneers, and patient was, of course, very happy. And removed the frenum. So what is Invisalign Smile Architect tool? So it is the tool which is recently, this is this month's innovation from Invisalign. It is specially for people who are more into general dentistry practice, and this is a tool which will actually give you, while you start the treatment, the end result. So if there is a patient with a missing front, 2-1 is missing. So this is a tool which can actually, you can plan, all the virtual plannings can be done on the software. You can ask your orthodontist to do that space planning for you, and then you can put an implant there or put a bridge there, and you can calculate the exact space that you are going to get at the end of treatment. So this is a very useful tool where there is a team practice, which usually is. And also it becomes very easy to communicate with the lab person that, okay, this is what I'm expecting from this smile makeover. So what is going to make a great smile, and which is now the paradigm is shifting from hard tissue to soft tissue. So not all the rules are applicable on all the patients. There's no ideal thing. There are various factors that you have to consider while doing a smile makeover. So few of them are the facial midline, buccal corridor, gingival line as we discussed, tooth proportion, horizontal line that is going to evaluate the position of the image, whether it's straight or tilted, and the smile line, that the smile line should be in consonance with the lower lip. Okay, so always remember, happy doctors only can make happy patients. So be happy and keep innovating, keep doing good work.
Thank you, ma'am, for the wonderful lecture. It was indeed a complete guide to smile makeover about braces, aligners, veneers, what to do, when to do, and why to do it. Thank you once again, ma'am. So now it's time to invite the next speaker of the day. She is Dr. Shivani Mathur ma'am, Professor and Head of Department of Pediatric and Preventive Dentistry, Dean Student Affairs from ITS Dental College, Muradnagar. She has more than 60 publications in national and international journals, and she is a course faculty for lecture and hands-on courses on nitrous oxide inhalation sedation. She has received many national and international awards, and she is a guide to all her students. Dr. Shivani Mathur ma'am is going to deliver a lecture on medical clowning in in pediatric dentistry. We welcome you, ma'am, and eagerly wait for your lecture, ma'am.
well-being for not only the patient but also for the doctor and the supporting staff and the parents as well. So medical clowning is a metaphor which is taken from two seemingly totally different concepts. One is a serious thing, the serious business of being a medical doctor, and one sportsmanship and the spirit and the kind of emotions and humor of that of so, medical clown is actually not a very new concept when we talk about medical fraternity. First reference of medical clowning is as old as year 1908, where its reference was found in a Persian newspaper on the front cover, and the clowns have been found there on a hospital setting. A brief about the history of medical clowning. We all know that he is nothing but Mr. Charlie Chaplin. He has brought smiles to many of us, our faces, and he's been bringing smiles till now. So basically, he was the one who brought smiles and carried the legacy forward. In 1971, we had Dr. Patch Adams, who introduced laughter as a therapy in the field of medicine. In 1986, Michael Christensen was the one who introduced the Big Apple Circle, and it was there that the people started becoming medical doctors. He used to train them. In 1993, Theodora Foundation was established, who created multiple centers across the world for the people to become medical clowns. It was in the year 2015 that Rohini Rao, she was the first medical clown in India. So she got training from abroad and she came and created multiple centers out here in India as such. So clown, it's a pure embodiment of vitality. It transports the patient from the very serious environment of the hospital into a world without limitation. So there have been a phenomena of exploration in the medical field already. The medical clowns have been explored for giving intra-articular injections for rheumatoid arthritis patients in cardiac biopsies during the very, very painful botulism toxin injections in several parts of the patient. detection and diagnosis for as simple procedures as CT scans and MRI for very young individuals. So it's a non-pharmacological approach to reduce anxiety not for the patients only, but even for the doctors and the caregivers. It builds a positive environment for the patient and has an improved response on the immune system side. Strategy to reduce cyanogen. To truly laugh, you must be able to take your pain and play with it. Based on this concept, Dr. Hunter Patch Adams, who was a young physician in the 1970s, he brought clowning into the medical field. So according to him, the role of a clown and physician are the same. It's to elevate the confidence and relieve the suffering. On this very concept, so very influenced by the work of Dr. Patch Adams, Hollywood famous starrer Robert got the name of Patch Adams. From this Patch Adams or Dr. Hunter Patch Adams. So this recipe describes how Dr. Hunter Patch Adams caused peaceful trust and happiness by introducing the clowning concept in the field of dentistry. So both experts are scientists and describe the method of clowning. The method of clowning this is usually where in the hospital ward setting, in the cancer ward, basically. So in the cancer ward, the entire children, pediatric cancer ward was converted into a very playful, joyful place. So we use a simple concepts which are used, simple things which are used in the hospital setting and utilize them to bring about smiles and laughter. And how each one of the patients in the hospital ward finally are feeling rejuvenated by the entire day. He's just trying to create humor out of very, very small and simple things out there. anxiety levels are decreased in such individuals. So there are many elder clown care programs which are running all throughout the world, like in countries like UK and US, where the elder medical medical performer works with the older people living in various medical care facilities like nursing homes and long-term care facilities and closed dementia units as well. There has been a systematic review in this direction where a total group of 1612 children suffering from chronic and acute illnesses have been studied, and it has been found through various studies that there has been a 100% reduction in the anxiety levels, 44% reduction in the pain levels, 50% enhancement of the emotional well-being in the individuals, 75% population had a decreased stress levels, and in cancer-related fatigue, it was decreased in 67% of the patients. Now, how do these medical clowns help the children? They help in children with autism, they help children who are disabled, in the sexually abused population, which is a very major group of population, invasive medical procedures, reducing the stress both in the patient as well as in the parent. We as pediatric dentists and general dentists too, we do believe that we should be leaving a patient happy once we are done with the treatment. And there are some basic guidelines on behavior management which have been given by American Academy of Pediatric Dentistry, including there should be a proper communication established between the child and the doctor. The doctor should be able to elevate the child's fear and anxiety. He should promote the child's positive attitude towards oral health and build a trusting relationship. So we thought about why not explore medical clowning in the field of dentistry. With this concept, we proceeded towards doing medical clowning and utilizing in the field of dentistry as well. And thus we approached Ms. Sheetal Garewal, who is a program coordinator for counselor. So this is one of the program running in India. We did a lot of study, had a brainstorming sessions, and had a good communication with Mrs. Sheetal Garewal. And finally, she told that she has never worked with such kind of medical clowning and its applicability in dentistry. And so we called her in the department, her and her team. So the entire environment was created, and the child who was frontal definitely negative were converted into positive patients. So this is how they work. Such a happy environment all around. The stress buster totally for us as dentists and for the patients as well. So the child is trying to be potentially cooperative, but as soon as the child saw the clowns, they were ready to get work on them. In the world of digitalization today, we have many apps available which talk about medical clowning. So the patient can be prior told about these usage of these apps before finally introducing them to the clinic. There are various podcasts also available in case you want to study and listen to more about the use of medical clowns. Actually, we were totally unaware about this. It just clicked, and then we started it out. But there are certain barriers to the use of clowning. First is a very fearful and a very anxious patient who does not even want to listen to anything. Cannot be, here the medical clowning cannot be utilized as such. Then a person who is heavily medicated, or in cases of severely ill condition or the debilitating conditions, we cannot seriously utilize their effects completely. Person the child is very, very young, who does not even understand this concept, sometimes is not a good candidate for this. But most important limitation is the chlorophobia or the clown fear. Some children around the age group of 3.5 years, they have found to have developed an inborn fear of the clown. So in these patients are not the right candidates for them to be shown, introduced to the clown. So this was the experience by Ms. Sheetal Garewal. She said that for the first time, clowning for children on a dental chair was challenging, but it was extremely fulfilling. She further told that the moment we started clowning, we could see a difference in how the children were behaving. Children who were holding their hand, telling stories, performing simple magic, while providing a lot of support to help them fight the fear associated with the dental chair. There were a few extremely difficult children. One little child was crying badly and would not open her mouth for the radiographic examination. The doctor called the crown and then she opened her mouth gradually. There was another girl who got her procedure done holding her my hand while I distracted her from pain with my tricks. So, so these were the actual real-time experiences of the clown sellers as pertaining to dentistry. So this on this we achieved a copyright done also, and so we were the first ones to use medical clowning in dentistry. There are programs available for the medical clowns to be told and taught in India. So it can be taken up as a profession itself. It's a beautiful profession if somebody wants to work on the sample training of the job history of therapeutic medical clowns, the importance of patient well-being. They tell about the role of medical clowns within the hospital medical team and evidence-based practice. Another thing, applied skills which are taught in that how to improve communication with the patient through therapeutic clowning, the use of clowning techniques for intervention with population, the trust building exercises, and the tools to facilitate burnout relief among the staff. So these sections go about
Thank you, Dr. Shivani Mathur ma'am, for the lecture on clowning in medical emergency. Thank you once again, ma'am. Before proceeding for the next lecture, it's time to felicitate the speakers who have already given the lecture. Please put on the background. I would request respected Dr. D.N. Kapoor sir and Dr. M. Siddharth sir to please proceed on the stage for the felicitation of the guest speakers, and also Dr. Anmol Bagaria ma'am and Dr. Ashish Chandra sir. The first speaker of the day was Dr. Deepak Bhargav sir, and he had given lecture on personal finance, my take as dentist. Thank you, sir. That was indeed a very wonderful lecture and taught us a lot about finance. I would also like to invite Dr. Sukhdeep sir on stage so that he can felicitate our guest speakers. Once again, let's applaud for Dr. Deepak Bhargav sir, please. Then it was Dr. Dinesh Kumar Bagga sir who has given a lecture on information mastery in medical research. I would request Dr. Dinesh Kumar Bagga sir to please come on stage. Till the time sir is coming, let us felicitate the next speaker of the day. She is none other than Dr. Chitali Parik ma'am, who has given a lecture or complete guide to smile makeover about braces, aligners and veneers, what, when and why. Thank you ma'am, it was a very informative lecture indeed. Please give a round of applause for ma'am. Thank you once again, ma'am. The next speaker was the one who had just finished the lecture. She is none other than Dr. Shivani Mathur, ma'am. And she covered the topic, clowning in medical emergency. And it was indeed a very informative lecture, ma'am. Thank you, ma'am. As Dinesh Kumar Bagga sir is not here at the moment and he'll be joining us in the next 5 to 10 minutes. So I would request all the dignitaries to please take their respective seats. And we'll felicitate Dr. Dinesh Bagga sir later on. And let us continue with the lectures. Thank you, sir and ma'am. Thank you, sir. Please switch on the PowerPoint. The PowerPoint has been set up. Please जो भी पीछे उसको on कर दे. Okay, so meanwhile the setup is getting ready. Let me give you all an introduction of Dr. Sonali Taneja ma'am, who is here in front of us all, and she's going to deliver the lecture on First, I'll give the introduction. Dr. Sonali Taneja ma'am is BDS, MDS, Conservative Dentistry and Endodontics, and she is the Dean PG Studies and Clinics and Professor and Head of Department of Conservative Dentistry and Endodontics from IDS CDSR Muradnagar. Dr. Sonali Taneja ma'am has published 60 articles in peer-reviewed national and international scientific journals, most of which are PUB Med indexed. She has co-authored 6 books and she has been postgraduate guide for the last 15 years. She has been the past vice president of IACDE and EC member of IES and was conferred with Diplomat Indian Board of Endodontics. Along with all this, her achievements are innumerable. So I would request ma'am to please start the lecture. And ma'am, it's a pleasure to have you here among us.
Good morning, everybody. What this one? This is not the
The topic ma'am is going to cover today is decoding the enigma to endodontist, tips and tricks to manage premolars. Thank you, ma'am.
Good morning, everybody, and greetings from myself and the Department of Conservative Dentistry and Endodontics, ITS Muradnagar. So I'll be speaking on the topic, decoding the enigma to endodontists, tips and tricks to manage the premolars. This is my PG department. This is my clinical section of PG where all final year PG students are, their cubicles are well equipped with individual microscopes for each of them. So as you know, the success of endodontics depends not just on the diagnosis and case selection, meticulous biomechanical preparation and disinfection, on obturation and post-endo restoration, but for all this, the proper knowledge of internal anatomy of the root canal of that particular tooth is very important. Why this premolar has been said to be, this is the smallest one, and if I ask a graduate student which tooth you would like to treat first, they would always go for anteriors or single canal premolars. But for endodontists, this is an enigma. Why it is an enigma? Because of the variations present. Why is it so difficult to treat premolars? Because of the narrow mesiodistal dimensions. There is narrow access to the canal, and there are a lot of variations in it. And moreover, the splits which happen in the premolar, they happen in the middle third or near the apical third. And even under the microscope, there is lack of visibility. And to add up to that, there are apical third deltas and trifurcations and C-shaped canals present, as well as your dense invaginators. So what does that epidemiological data reveal to us? According to it, the lower bicuspids, they have got single root in 97% of the cases, though four rooted premolars and with 5 canals have also been reported. And amongst them, around 23.55, that is almost 1/4 of all of the premolars have 2 canals. And mandibular second premolar, it has got 12.64% of the 2 canals. And in mongoloids, C-shaped canals have been reported up to 24%, and dense invaginators in 13 to 27%. So how do we identify these aberrant anatomies in premolars? First, by radiographs, then we have advanced technology like CBCT, and third is your visual inspection and interpretation. So what do we see in the radiograph that makes us think that this tooth is going to have aberrant anatomy? First of all, you have to take the radiographs at horizontal angles, because multiple angles radiograph have to be taken, because the canals, they superimpose on each other, and even the roots. So to get to the right number of canals and right number of roots, we need to have horizontal angulation of 15 to 20 degrees. Then there are certain clues on the preoperative radiograph which will point to that aberrant anatomy. This is one. Can you see? There is a sudden change in the radiographic density of the root canal space. This suggests that there is going to be a bifurcation or an additional canal. And if there is sudden narrowing or disappearing of the pulse space, that means there is a divergence of the canal. Then, in cases where the mandibular premolar has 3 canals, in that case, the mesiodistal dimension of the root in the cervical third is very broad, and it does not taper to the extent what it normally does. So if it is broad in the cervical third, that points that there is going to be 3 canals. And then another thing is, here you can see the PDL, twin PDL space on one side of the root and the PDLs crossing over the root. So all these suggest there is the presence of accessory roots present in the premolar. Even after your treatment is done and you get a case of retreatment, if you happen to look at the radiographs closely, you will see that if your root canal obturation, it's inclined towards one side, please have a look on the opposite side. There is a faint canal right there. And after retreatment, this was what we got. And another clue is, if you see a sort of little bit of obturating material out of the total confines of the canal, it is moving towards the other side, that means there is some sealer entry into that extra canal. And if you try to trough that area, you will definitely get a second canal. Then is your advanced radiology, that is your CBCT. It gives us the information in 3 planes, the 3-dimensional views. And sagittal, coronal, and axial images, they provide 3-dimensional imaging. And it eliminates the problem of superimposition. And moreover, the advantage of this CBCT is it gives us the axial, this gives the inclination of the canals from the external surface so that we can modify our axis opening accordingly. So visual interpretations, you know, vision is the art of seeing things that are invisible to others. So you have to, when you have opened your axis cavity, you have to visualize it carefully. If it is a circular shaped, then it is a 1 canal. If it is buccolingually oblong or oval, it means it is going to be a 2 canal. And if it is triangular or if it is broader mesiodistally, then definitely there is going to be a 3rd canal also. Then what are the tests to locate the canal? First is your champagne bubble test. In this, under the rubber dam, and when we have done the pre-endo build-up, what we do is we flood our pulp chamber with warm hypochlorite. And because this hypochlorite, it interacts with the organic tissue, and wherever we will get the maximum effervescence, that means that is the point of your missed canals. And second is the use of dyes. Methylene blue, if we flush it off, the point where it concentrates, that is the point of your orifices. Then is your red line test. This is holds true for the vital teeth. In this case, the blood oozing out from one of the orifice, it will give a road map. It just paints the picture of the dentinal map. It flows between the isthmuses and grooves which are connecting those orifices. Then is your white line test. This holds true for your non-vital teeth. Here, whatever debris we have cut, they fill in between these isthmuses and between the orifices. So they also give a sort of a guide map where to hunt for those extra canals. Then is your transillumination, which is done in the dark background, and it reflects the internal canal anatomy. And magnification, definitely magnification has a role to play, and up to 10x, it is used to refine your axis chamber, and 15 to 25x to see inside the individual canal. So now I'll be showing some of the cases done by myself and my PGs in the department. First case, this was a case where the patient came with the food lodgement. So, and there was a chronic periapical abscess. And you can see very clearly that this is a taurodont premolar, and the roots are bifurcating at below the middle third. The axis opening was done, which was oblong. And on axis opening, first of all, we could just get we could find only 2 canals. And then in the lingual canal, on the distolingual part of that canal, we could find 1 catch. And when we went and we tried to go and negotiate that catch, there was a 3rd canal which was present. So there were 2 canals, that is mesolingual and distolingual, and 1 buccal. So that means total 3 canals were present. This is how we did the rotary instrumentation up to 36%. And then we had done, because there were 3 narrow canals which were present, during the instrumentation we did your continuous chelation. And finally we obturated it, and after vigorous agitation of the irrigant, we could even see You can see the lateral canals getting filled. So this is the post-obturation X-ray and the post-endodontic restoration. Then second case was almost similar. Similar case, we got, first we could identify only the 2 canals, and then on proper negotiation and scouting of the lingual, we could get the third one. And this is how we obturated it. What I want to say is, when we get 3 canals, sometimes working length X-ray, we cannot place all the 3 instruments in one go. So we will have to put the instruments in the individual canal and take the radiographs. And the obturation we did was individually down pack, that is warm vertical compaction till the point of its trifurcation, where the common thing ended. So from that onwards, we did the backfill with a thermoplastic injectable gutta-percha. This is the third case. The patient complains of pain in that lower tooth. You can see, if you see it very closely, you can see there is a change in the density of radiolucency as it approaches the apical third. This is again suggesting that there is going to be a deep apical split. So when we did the canal negotiation, we could feel that deep apical split in the apical third. And for that, first of all, we had to intentionally widen the common point, that is the point from here to here, so that we could easily do our BMP, and then it was done till 34% down pack, and then backfilling with thermoplasticized gutta-percha. Then this is the case 4. You can see first preoperative radiograph showing lot of canal outlines. So when we took another radiograph, we could clearly see that it is a 3-rooted mandibular premolar. So we took the working length radiograph. Because the 3 orifices were separate, we could take it in one go, all 3 instruments in that. And then we prepared the canals up to 36%, and all the 3 canals were filled with gutta single cone mixed with bioceramic sealer. This is the 5th case, in which you can see, again you can see that sudden disappearance of the radiolucency, and you can see some little bit of bifurcation at the apical third. In the preoperative radiograph was not very clear. When we took the working length radiograph at an angulation, we could clearly see the bifid root right from the middle third. Then we did the biomechanical preparation up to 36% and then obturated it. This was another case. This was a case, it was you can see in this case, you can see a dark radiolucency. Again, it is fainting down, and you can just see just 2 of the faint canals present out there. On access opening and canal negotiations, we could find, first of all, we could go into the buccal canal, and then we went from the same orifice, we went into the lingual canal. It was a type E vertices classification 1-1. So in this case, the buccal canal was easy to negotiate. So what we did was we prepared it with rotary instruments up to 36%, but the lingual one, It was very difficult to negotiate. We had prepared it with hand instruments that is 2% taper. And first of all, we obturated the buccal canal and then the lingual canal, and the backfilling of the common part of the canal. This is the 7th case. This is a case with 2 canals, 2 orifices. So right from the coronal end, there were 2 orifices, 2 into 1 configuration, that is Vertusius type 2 configuration. And here we filled the canals. The buccal one was prepared in 36 and the lingual 34%, and this was obturated using bioceramics. So not only the mandibular premolars, even the maxillary premolars also shows variations. So these are the 2 cases in which we had the maxillary premolars with 3-rooted, which were 3-rooted premolars. And you can see the axis opening. It is almost like a maxillary molar, like a maxillary second molar. Axis opening, the shape is almost like that. And the 3 canals were negotiated and they were filled. This is the post-obturation X-ray. 9th is again a case of 1-5. Again, from this end, you can see that it's a broad configuration at the cervical third, which points that there is going to be an additional root present out there, an additional root. So the 3 canals were accessed, negotiated, and then they were prepared and they were obturated. So seeing all the variations, what should be your takeaway message or the tips and tricks how to negotiate these extra canals or the aberrant canal anatomy? First, the careful visualization and radiographic interpretation. The eye cannot see what the mind doesn't know. What does that mean? That if you have the knowledge, then only you will be searching for it. If you do not have the knowledge, you will not be searching for it. Then you have to do your access cavity modifications. Now is the era of conservative, ultra-conservative access cavity, but the canals, but the premolars with aberrant canal anatomy cannot, all the canals, those extra canals cannot be negotiated with ultra-conservative access openings. We have to go in for traditional access openings in such cases. You can see from this, that if we do a very small one, we are able to negotiate 1 canal. But when we give a traditional access opening, we are going to have a straight line access towards both the canals. Then is the use of tests, which I have already told about. Then this is very important, the pre-curving and scouting of the canal. Your first file which goes inside the canal has to be pre-curved, and then you have to slide it inside the canal. You have to have with your tactile sensation, because tactile is going to play a lot of role. So once you slide it inside the canal, the point where you get the catch with a lot of your EDTA, just try to negotiate it. And then you have to frequently change your instruments, because once you will be negotiating those narrow canals, there will be definitely your hands, so the glide path what you are creating, there will be unwinding of the flutes. So there are problems of separation of the instrument. So you will have to frequently change your instruments. So you have to pre-curve and scout those extra canals. Then the use of apex locators. Why this is important? Because sometimes you get that fast break even in the case where your canal is exiting towards the buccal and the palatal extent. So you have to come from this apex locator. If it is, suppose, after you have negotiated the straight part till the point where it was visible in the X-ray. If it is short, means it is 2 or 3 mm short, then you have to pre-curve it in the buccal or the lingual direction and then try to find that there is a deep apical split or not. This is, I've already told, that use of fresh instruments. You have to keep changing because your glide path, it will be a full bowl of glide path if you have to really negotiate a narrow extracanal anatomy in case of premolar. Then the irrigation, that plays a key role. What we have observed is, then in most of the cases, when we started doing with hypochlorite alone, on the next visit, because it was some cases were difficult, so we had to finish it in the next case. On next visit, the narrowest canal was difficult to find because it got obliterated with the debris. So if we go in for continuous chelation, that will be removing the accumulated hard tissue debris, and so those narrow canals will not get clogged again. So it had to be done, and irrigation had to be, either the irrigant had to be agitated or activated. The cheapest method is your manual dynamic activation, and then you can, in manual dynamic activation, what you do is you take your master cone, the corresponding to the size of your MAF, cut it, and with push and put, it has to be a lot of strokes per minute. It has to be push and pull and filling of that irrigant so that it brings the irrigant to the apical third. Then is your sonic and ultrasonic agitation, and the latest we have the pips and the sweep. Obturation, what I told was, it is case specific. If it is a middle third or a apical third split, definitely you have to go in for warm vertical compaction followed by backfilling with thermoplasticized gutta puncture. And where warm vertical compaction, sometimes the angle is not such that you can do warm vertical compaction, then it's better to go in for single cone obturation with the sealer with the density, like a bioceramic sealer, which have got the bulk. So in the end, I would like to conclude that extra canals in premolars are well documented in literature. You have to keep your eyes open, and you have to visualize and read each and every X-ray and plan your treatment before you start the case. Thank you, and this is my department, my students, my faculty. Thank you so much.
Thank you so much, ma'am. It was a very informative lecture on decoding the enigma of endodontics, tips and tricks to manage premolars. Thank you once again, ma'am. Now, before moving forward to the next lecture by our guest speaker, it's time for the felicitation ceremony. I would request Dr. D.N. Kapoor sir, Dr. Anmol Bagaria ma'am, Dr. Ashish Chandra sir to come on stage for the felicitation of our guest speakers. I would also like to request Dr. Nitin sir to come on stage for the felicitation ceremony. We have Dr. M. Siddharth sir joining us for the felicitation ceremony. The speaker. I would request the coordinator to change the backdrop. The first speaker is Dr. Sonali Taneja ma'am, who had just finished a lecture on decoding the enigma of endodontics, tips and tricks to manage premolars. It was a very informative lecture, ma'am. Thank you, ma'am, for your lecture. Please give a round of applause for ma'am. I would request all the dear delegates to please occupy the seats in the middle, in the center. The next speaker is Dr. Yash Sharma, sir. Please give a round of applause for sir. Thank you, sir, for your presence here with us today. Next felicitation is for the speaker who is about to give the lecture next, but she's getting felicitated, and she is none other than Dr. Paridhi Arora, ma'am. Please give a round of applause for ma'am. Ma'am is going to give guidance on scope of implantology from single tooth to full mouth rehabilitation. Now it's time to felicitate the respected dignitary who is already present on the stage, Dr. M. Siddharth, sir. Thank you, sir, for your presence here. And we are really delighted for all Sharda University has done. Thank you, sir. Dr. M. Siddharth, sir, Dean, Science, School of Dental Science, Sharda University. Thank you, sir and ma'am. We'll continue with the lectures now. The next felicitation is for Dr. Dinesh Kumar Bagga, sir, and he has given a very informative lecture on information mastery in medical research. Thank you, sir. The lecture was indeed very guiding. Please give a round of applause for sir. Thank you, sir and ma'am. I would request Dr. D.N. Kapoor, sir, to please proceed to his respective seat. Thank you, sir. All the students whose spot presentation, that is paper or poster presentation, is left out or they are yet to give the presentation, they can proceed to the VIP lounge and get ready with the presentations. Rest all the people who are here to attend the lecture, please occupy the center seats or the middle seats. I would request the coordinator to please switch on the PowerPoint presentation. So the next speaker of the day is Dr. Paridhi Arora ma'am. A brief introduction about ma'am is that she has done her BDS and MDS in oral and maxillofacial surgery in the year 2017. She is Master and Fellow of International College of Implantologists, USA, Fellow of Indian Society of Implantologists, India, and Fellow of the Academy of Oral Implantology, India. She has been extensively trained in implant dentistry and regenerative dentistry from Turkey, Thailand, USA, and Spain. She is an author and co-author of various articles in national and international journals. She maintains a highly specialized oral surgery practice in New Delhi and is also the chairman of Institute of Dental Excellence. She is actively involved in academics and conducts regular courses on oral surgery and implant dentistry. Ma'am is here to deliver a lecture on scope of implantology from single tooth to full mouth rehabilitation. Let's welcome ma'am with a big round of applause, everyone.
Very good morning. I know it's hard to come on a Sunday morning and listen to anybody lecturing, so thank you all for being here. So a little bit about myself. I'm an implantologist. I'm an oral surgeon. I do implants mainly. This is my family. My husband, Dr. Dhruv Arora, he's also an implantologist, and my parents who've been a constant support for me. So I always mention them before I start any lecture. This is my clinic team. We have 6 associate doctors, 4 assistants, front staff, drivers. So the entire team is involved in all my cases, so I would like to thank them also. So when we hear dental implants, what is the first thing we understand when we hear dental implants? First of all, that they're fixed. They are a fixed solution to artificial teeth. Next, of course, you have a lot of options in dental implants in relation to material, in relation to the implant system, in relation to the type of surgery you want to do. And implants are, it's a unique subject because you don't need to be a specialist in anything to do implants. And of course, every specialization can do implant procedures. So when you have mastery over implants, you can do everything from a single tooth restoration to a full arch restoration, full mouth restoration, whatever you can, try on a patient. So why do most patients accept removable appliances or bridges when you have the option of implants? Because they are not aware of the alternatives. The longevity of bridges, as we can see in many studies and journals and articles, is very low. In 3 to 5 years, most of the authors will tell you that bridges fail in multiple studies over the years. Implants, however, as has been studied, last for many years. They last for 10 years, 15 years with a 90% success in most of the cases. So implants are obviously a better solution. So implants are basically a prosthetic discipline with a surgical concept. Why? Because the patient has come to you for teeth. The patient does not come for a surgery. The patient does not need, something extra in his mouth. The patient only needs teeth. So you need to place implants to give the patient teeth. So a basic implant procedure involves, of course, the first appointment where you place the implants, and the second appointment after 3-4 months when you start loading the implants. The first case we're going to discuss is a routine case of a missing posterior mandibular tooth. So this is the target area where we need to place an implant. We open up a full thickness flap and we prepare the osteotomy and place a single implant here. This is how the implant looks after placement, and you cover it up, suture, wait for 3-4 months and let the area heal. After that, you put a healing abutment on it, which is a screw which is larger than a cover screw originally placed, and then after a few weeks you can take an impression and load the implant. The crown here is a PFM implant, a PFM screw retained implant crown. This is how a screw retained crown looks. This is the final occlusion, and this is the pre and post-op X-ray. So a second case, this case was slightly more challenging. It was more difficult because, as you can see, the patient has a combined hard and soft tissue defect in the upper anterior region. So we opened up the area, took our measurements, and we had about 5 mm of buccal bone width, crestal bone width. So we went ahead and placed an implant in the ideal 3D position. After placement of the implant, there was a significant buccal bone defect, which we had to fill up with bone grafts, artificial material, and over that we placed the collagen membrane so that our soft tissue doesn't grow into the bone graft that we have placed. And then this is the post-op IOPA. And the significant change we found in this case was that after 15-20 days, the soft tissue bulk as well as the hard tissue bulk was significantly better at the surgical site as compared to the pre-op situation. So this is what we had, and this is what we ended up with after about a month of surgery. As you can see, the defect is almost gone. And then we again placed the healing abutment over the implant for tissue. And as you can notice here, that the implant area has a better soft tissue coverage than the normal tooth. So we could achieve the results that we desired. And then we went ahead and gave the patient a cemented restoration. Another case, a young patient had a fall while training, fractured his anterior 3 teeth. All these 3 teeth were mobile. And since the patient was planning to go for armed forces, he needed implants and a minimum number of teeth in his mouth before he could clear the medical exam, which was not possible with an RPD or a bridge. So the implants was the only solution for him. So we went ahead, and this is how the situation was before we entered. Extractions were done, and Zimmer implants were placed, osteotomy site 1 and osteotomy site 2. And whatever gap was left between the implant and the buccal bone, we filled that area with bone graft and filled the socket in the middle with bone graft so that there is no additional bone loss in this area while the healing phase is occurring. This is the IOPA, and we filled the area with xenograft, sutured, and after 5 months the area is healed quite well. So we went ahead, put zirconia abutments, and gave the patient Emax crowns. This was his final smile. He was very happy with the result, and these crowns are still going strong. So this is the before and after of the patient. He has now cleared his armed forces exams and is, I think he's studying at NDA now. This is his final OPG. Another case, young patient, young female patient with a high gummy smile, all gingiva visible when she smiles, and this single 2-1, which is artificial after a trauma. This is how the tooth is below the faulty prosthesis. This is her smile line. It is very high, so the gingiva and teeth are all visible. So aesthetics are very important for this case. So again, we went ahead, raised the full flap. As you can see, there is a buccal bone defect in this area. So went ahead, of course, placed an implant, drilled palatally to the buccal defect. After the implant placement, we can see that the label plate is entirely missing. So after that, we collected some autobone from that area and mixed it with some bios, which is xenograft, and grafted over that area. BioOS plus blood and covered it with a PTFE membrane and left it to heal. But after 9 months, we saw that the soft tissue healing is not adequate because the patient has a thin gingival biotype, so the membrane is visible inside her gingiva. So of course, we had to do a second stage surgery, remove the membrane, and the bone formation we found underneath was quite good. To just augment the soft tissue area, we added a soft tissue graft. This is known as a fibroguide and closed. We waited for about 30 days and gave her a acrylic crown for to just shape the tissue. As you can see, the gingival zenith is not matching, but we left the highly polished crown in its place for about a month, and within a month we saw that the gingival zenith has grown and the gingival tissue is now matching that of the adjacent tooth. So after this, we saw that the tissue contour has also built up nicely. So we gave her her final prosthesis. The black triangles between the crowns filled up after 3 days. And this is the post-op CBCT where you can see that we have achieved a large amount of buccal bone augmentation, which is stable till now. And this is her 3-year follow-up, and her smile looks pretty good. So this is another case. This patient was, when she came to us, was in 3rd year BDS. She had this faulty prosthesis, the anterior region of her mouth, and these failing implants, which we removed. And as you can see, there is hardly any bone in this area. Went ahead and placed Bioner implants, placed 3 implants. Took some autogenous bone from the ramus area with this drill called the automatic chip maker. And we mixed this autogenous bone with xenograft, placed it over our implants, and closed the area, left it to heal for about 6 months. And this is the healing phase. So this was the final prosthesis that we gave her, and the post-loading IOP of the implants. Post-loading CBCT, the buccal bone has grown quite well, and this is her final smile. She now has her own practice in Haridwar, I think, and the prosthesis is still working. So I think this is my second last case. This is a patient who came from Canada. Dental treatment is very expensive in Canada, so she wanted to get her implants done in India. Plus, a lot of practitioners in Canada told her that, there is nothing they can do for her. This case is too complex. So she came to us. This was her initial situation. It looks like a full mouth rehab case. We had to remove all the teeth and give implants and a new prosthesis. So this is a pre-op CBCT. As you can see, there is hardly any bone anywhere in her arch. All her bone is really thin and fragile, with a lot of infection both in the maxilla and the mandible. So we went ahead, this is the presenting situation, we went ahead, extracted all the teeth, raised the full thickness flap, cleaned out all the granulation tissue and all the areas infected and all the infected bone, and placed 6 implants in the lower arch, and we placed 8 implants in the upper arch. Grafting was done with BioOS and BioGuide, and this is how it looks, just immediate post placement. As you can see, we've retained the 2 canines in the upper arch. That was to give the patient acrylic prosthesis in the interim phase, so that she could chew and her smile didn't look so bad. This is the acrylic temporary. This is her smile. So in the final phase, we chose to go for multi-unit abutments because of the angulation of the implants. Impressions, models were made, and then we did a teeth setup trial, metal trial, followed by a bisque trial. Bisque trial is basically the unglazed ceramic trial you do in the patient's mouth, where you can do all your occlusal adjustments and change aesthetics if you need to. This is the final prosthesis, the final bite of the patient. This is the immediate post-loading OPG. All the bone levels are stable, the implants look good. And this is her pre and post-treatment smile. This is my final case for today. Similar case, very old patient, all teeth failing. Nothing can be saved. So similarly, we had to go for, in this case, we could not do immediate implant placement because of the amount of calculus and periodontitis she had. So we extracted all the teeth, waited for the tissues to heal, soft tissue closure to happen. After that, we placed implants, small implants because there wasn't much of a buccal height. So we placed small implants, grafted wherever required, and gave her temporaries. And this is her smile. Now, this case is still ongoing, so I don't have a post-op pictures as of yet. So, this lecture was basically to tell you that, implants are not just about replacing a tooth or, adding a tooth to the patient's mouth. It's a good procedure, a good surgery can change a patient's lives in many ways. So implants are, they don't, of course, I mean, you can't say that, you know, do we save lives? Of course not. I mean, we're dentists. But can you change somebody's life with a good prosthesis, with a good surgery? Of course you can. So implants has to be targeted towards the patient's needs and wants, and not just a procedure which you read in the book. So, you know, a small change can make a huge difference to the patient's self-confidence, self-esteem, quality of life. So, implants are not a cosmetic treatment as is considered by a lot of panels in India. You know, you can improve speech, pronunciation, aesthetics, function, health, and overall life of the patient. So, thank you for patient listening. And these are my contact details if anybody ever wants to get in touch or have a discussion or discuss a case or just have a cup of coffee. Thank you.
Thank you so much, ma'am, for the wonderful lecture. It taught us the scope of implantology from single tooth to full mouth rehabilitation. Thank you once again, ma'am. Till the time the setup is getting ready, I would like to introduce you all to the next speaker, Dr. Sumit Goyal, sir. A brief introduction about sir. Dr. Sumit Goyal is a professor in the Department of Oral Medicine and Radiology. He's from Subharti Dental College. He's also the alumni president of Subharti University and joint secretary in IDA, Meerut. He has more than 900 citations along with several prestigious awards to his credit. He is the known face as a mentor for NEET MDS preparation in India. And today, sir is going to address oral and maxillofacial anxiety. I would like the coordinator to switch on the PowerPoint. Welcome, sir, and we eagerly wait for your lectures.
Jai Hind and good afternoon all. Like the audience is not much in the hall, but the most important honor for me is that I don't know after how much long I am giving a presentation in front of my mentor D.N. Kapoor sir. I was doing PG when sir was the principal of that college, and I don't know अगर sir को याद है या नहीं है. My research was on ultrasonography on for periapical lesions, and no one was supporting me that you should take up this topic. So one day in the evening in the campus, I happened to meet sir, and sir को मैंने पूरा बताया कि sir I wanted to do this thing, and he was the only one who supported me कि बेटा तुम करो, and I'm sure you are going to do it very well. And then I did that research, and sir, now that topic is having more than 200 citations, sir, my research. So it's all because of sir. And it's a privilege again that I'm speaking. I'm nervous now. I usually don't get nervous when I give presentations, but when sir is sitting there, so it's like I'm giving my PG time presentation once again. But then like it will be a memory for me that I'm here. But I don't know sir को मैं कितना याद हूँ, but I'm sure थोड़ा बहुत याद होगा sir को. So students, stress, nervousness, anxiety, अभी मेरे को भी हो रहा है. But आप लोग सब जो बैठे हैं, आर यू ऑल, जितने लोग बैठे हैं इधर, जितने लोग बैठे हैं, आर यू ऑल स्ट्रेस्ड? आप लोग स्ट्रेस्ड हो अभी? मुझे भी ऐसा लगता है कि मैं स्ट्रेस नहीं होता हूँ, आई एम नॉट स्ट्रेस्ड, बट हम लोग स्ट्रेस्ड हैं. every day, हर वक्त हमारी जिंदगी में कुछ ऐसा चल रहा है. अभी तो सोशल मीडिया का इतना ज़्यादा haunting effect है that we all are actually stressed, but we don't even know that we are stressed. And I always tell all my students also, now I am a professor with 13 years experience, and I always tell them that जितना बुरा इफेक्ट टोबैको, हम लोग ओरल मेडिसिन वाले हर बार टोबैको की बात करते हैं, that tobacco has adverse effects on the oral cavity, but I say that even stress have उतना ही adverse effects in the oral cavity as tobacco is having, and it is actually true. It is actually true. That is why I have named my topic as oral and maxillofacial anxiety. Her patient, every patient which is coming to us, or if I am visiting any clinic, I see them all stressed because abhi lifestyle ही ऐसा हो गया है. And I will speak for half an hour, but I would really appreciate if you pay attention to this presentation, because I will be just like everyone know what effects of stress we have in the oral cavity, but I'll be happy to share my experiences of my patient, how I coped up with them, how they dealt with all those things with you all. So starting with my presentation today, first of all, I am Dr. Sumit Goyal. I am professor in Subharti Dental College and Hospital, because I have done my BDS from the same college. So I'm honored that they selected me to become the alumni president of the whole university. And plus, yes, he's our principal, Dr. Nikhil Shrivastava. He's also an alumni of prestigious KGMC. Sir must be knowing him. And he is my ideal. He supports me a lot in the university and dental college. So I always start my every presentation with his photograph. So these are the messages I'm getting in on WhatsApp. Or every time on the WhatsApp, I'm getting these messages. Good evening, Sumit, and my mother is having this problem. She's under a lot of stress. Another, my friend has given you this number, and the friend is under a lot of stress. One of my senior, Sumit, ye kya ho gaya? My husband is under a lot of stress. Stress, and stress. The stress is there, and अगर कुछ problem हो रहा है, the stress is increasing, and वो problem भी साथ साथ increase हो रहा है. Stress, all about stress. Why so much of stress regarding the diseases are there? Because these two important terms do exist very badly. One is cancerophobia, the other one is delusion. Cancerophobia फिर भी अच्छा है, because the patients who have cancerophobia, if we counsel them, they will understand and they'll cope up with it. Delusion is a very difficult thing. If someone is having delusion, अगर हम counsel भी करेंगे ना, they will not understand that. Like an hypochondriac, they will go to another doctor. नहीं वो तो ऐसे ही बोल रहे हैं, जरूर मुझे कुछ है. Because simplest of the things are getting undiagnosed these days in our country. Because in our dental colleges, yes, we are taught very nicely regarding implants, endodontic treatment, but the branch, I talk about my branch, which I really love a lot, that is actually badly neglected. And that is why when these patients with the simplest of the pathology, they go to dental surgeons, they say, bhai, किसी बड़े डॉक्टर के पास चले जाओ, ये बड़ा कुछ हो सकता है. The first one is just a blood blister, which is called as angina bullosa hemorrhagica, that heals with itself within 2 days. The second one is simple geographic tongue. The third one is a hyperplastic papillae. We call it as foliate papillitis. And the last one is just cheek biting, but white lesion is there. So whenever a patient who are actually reading a lot of internet and all, when they have such problems and they go to a general dentist or a doctor who are not aware of these things, what basically they do is, they say नहीं आपको अब किसी स्पेशलिस्ट के पास जाना पड़ेगा, नहीं इसका ट्रीटमेंट तो बड़ा है. Then what they are doing is they are increasing the stress in that patient. And when the stress increases, the problem यहाँ जो है वो तो छोटा सा था, but वो stress की वजह से वो problem और बड़ा होते होते और बड़ा होता जा रहा है. Because अगर हम किसी को treat कर भी रहे हैं, उसका हम अगर वो अंदर वाला stress नहीं treat कर पा रहे हैं, तो हम कुछ नहीं कर सकते, हम उसको ट्रीट भी नहीं कर सकते. That is why I like this quotation, that before you heal someone, ask him that he is willing to give up the things that made him sick. वो sick क्या है? वो sick तो अंदर से है, वो mind body interaction है that is making him sick. और हम लोग जब treat ही नहीं कर पा रहे हैं, Dr. Arora is there, I don't know you sir, but my friend was praising you that you are doing a lot of good work on TMJ in South Delhi. And you also know sir that TMJ problems are a result of stress. Most of the times it's a result of stress. हम कितना उसको treat कर लें, but if the stress component, वो जो patient के ऊपर हावी है, if that we are not able to treat, then that problem persists most of the time. True, sir. It is the both way around. But majorly, sir, most of the patients what we encounter are those patients which usually tell us, अगर उनसे पूछा जाता है, yes, we are facing these problems, उसके बाद TMJ problem start हुआ, right, sir? So the common effects of stress is there on the screen, which we all know. It starts with headaches. Headaches can be a simple tension headache, a migrainous headache, or a cluster headache. Hypertension is there, then GIT is disturbed, then diabetes develops because of all these are all bodily effect on stress, right? A lot of cognitive things takes place. People, their memory becomes like sharpened memory, एकदम से memory loss में convert हो जाता है. People, they usually get confused. They are not able to think well. They become judgmental. They are most of the times quiet and dreamy. They start feeling lonely. They develop negativity. They develop negativity within themselves, right? They think everything is bad, everything is not negative. Of course, heart rate, pulse rate, and they don't want to do anything. The people who are anxious, who are stressed, they love lying on their bed, watching television with their mobiles in their hand, waiting for some text to come. That is the actual sign of the people who are troubled. And big people, celebrities, big politicians, they have a lot of stress. And what they do is they go to psychiatrists and they are taking medications. But the medications what they are taking, they themselves are associated with a lot of other side effects that we all are definitely aware of. So these are the few signs or responses which a patient have when that patient is stressed. And we all know this. Hyperactivity, वो बहुत जल्दी बात कर रहे होते हैं, इधर-उधर घूम रहे होते हैं. So these are all the signs जो patient में हैं, तो हम समझ सकते हैं that this particular person or a patient is stressed. And we have several stress scales. This is all bookish things. That we have several stress scales to evaluate how much stress that person is. We have grades also. Grade 1 depression, grade 2 depression, like that we have stress grades as well. So I will be just talking about few of my experiences which I encountered. And that's why I felt that this is an important presentation to give in front of the audience. So this is case 1. I had a patient. Now this patient had a pain in third molar. He went to Delhi and he got his tooth extracted. After extraction, he was not happy because he says कि मुझे यहाँ पे pain होता है. It starts from third molar, radiates to the temporal region. All the investigations were done. Nothing was there which could lead to this pain. But still, that patient says, "नहीं, I am disturbed. I am having pain. मुझे पूरा face पे इस region में pain रहता ही रहता है." Then he visited several doctors. Delhi भी पूरा visit किया, सब कुछ किया. He came to me also. But then he said कि नहीं हो रहा है, and no one is even understanding that I am having pain. They say नहीं आप सोच रहे हो, that is all psychiatric problem what you are having, आपके mind में है. But then actually ये relation है, थोड़ा mind में भी है, but वो थोड़ा है भी. अभी भी हम जितने लोग यहाँ पे बैठे हैं, अगर हम लोग एक point पे feel करेंगे कि हमें यहाँ पे दर्द हो रहा है, if we feel that we have pain in this region, and we press that region and we keep on feeling नहीं यहाँ दर्द है, तो नहीं भी होगा ना, तो भी वो दर्द हो जाएगा. आप feel करो, आप बस चुपचाप बैठ के feel करो, हाँ इधर दर्द है. नहीं भी है, तो you'll start feeling that actually that pain is there. I'm not saying that it is related to completely, it is having a psychiatric component, वो तो है ही है, but because that patient का वो component है, उसकी वजह से actually वो pain हो रहा है, but this pain is again related to nerves. The C fibers, the peripheral fibers, they are stimulated, resulting in that kind of pain. Now this is called as atypical facial pain, and those who practice dentistry, they should know about it, that this exists. This is called as progressive atypical facial pain. It is related to nerves, and it do occur. वो patient satisfy होंगे ही नहीं. और वो ही उनकी wife ने मुझे अलग से बताया. मैं आपको एक बात बताती हूँ सर, ये पूरे टाइम सोचते रहते हैं केवल इसी के बारे में. He is not doing any work. He just sit in the corner, plays Alexa, and he asks, बार बार Alexa को बोलते हैं, Alexa next song, Alexa some sad song. वो Alexa भी परेशान हो गई थी. And she kept on hearing those sad songs and just focused. हाँ मुझे pain है, हाँ मुझे pain है. So when you feel that pain, वो nerves भी feel हो रही हैं, and that nerves are getting stimulated, and actually वो pain है. That is atypical fail. Pain again related to that emotional component, that anxiety component. Similarly, I'm sure most of the dental surgeons are here, they know about this atypical odontalgia. That is a pain that is called as phantom tooth pain. कई बार हमें एंडोडोंटिक कोई ग्रॉसली डिकेट टूथ होता है, यू परफेक्टली रेस्टोर इट, परफेक्ट आरसीटी आप लोग कर देते हो, बट देन अगेन द पेशेंट सेज नहीं 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 नहीं, टूथ तो रेस्टोर हो गया है, बट दैट पेन इज स्टिल प्रेजेंट. वो पेन अभी भी है, वो पेन ठीक नहीं हुआ है. Perfectly everything is done, no pathology is left. Why that pain is there? That pain is there because वो pain यहाँ से start हो रहा है. वो patient is not able to forget what he had when that tooth was carious, and that time that pain was so severe. Now that tooth has been restored, that has been healed, but that pain जो यहाँ पे था, that persists. वो अभी भी है, and this is phantom tooth pain again. वो यहाँ से शुरू हुआ है, but tooth ने feel किया because that nerves have felt it. Now the nerves are stimulated and that pain is persisting. So this is atypical odontalgia, very much related to emotional stress. A lot of treatments are there, which a lot of anticonvulsants and antidepressants are given to treat such kind of atypical facial pains or atypical odontalgias, but nothing is happening. Only patients are developing dependence on these medicines, developing side effects. जब तक वो स्ट्रेस कंपोनेंट नहीं जा रहा है, तब तक नहीं ट्रीट हो रहा है, नहीं जाता है किसी भी पेशेंट का, राइट. कमिंग ऑन टू केस 2, नाउ दिस इज समथिंग डिफरेंट, एंड आई जस्ट पुट दिस पिक्चर जस्ट टू एक्सप्लेन, बिकॉज ये वाला जो केस है, इसमें मोस्टली फीमेल्स आर इफेक्टेड, एंड दे यूजली कम, एंड आई हैव डन माई lot of research on this thing, this problem. So I am telling you, this is called as burning mouth syndrome. I am sure that most of you are aware of this burning mouth syndrome. It's a pain in the, it's a burning sensation basically on the tongue, which patients feel, but actually when the doctor examines, there is nothing in the oral cavity. Symptom of pain is there, but there is no sign. Only symptom is there, that burning sensation is there. Now this is most commonly seen in postmenopausal females. They usually come to doctors, they say मुझे tongue में burning sensation है. Doctors examine the tongue, they say नहीं नहीं आपको कुछ नहीं है, फिर भी you can have those tantum, mouth rinse, dologel लगा लो, dentogel लगा लो, you'll be fine. But जब कोई पैथोलॉजी नहीं है तो ये सब क्या करेंगे, एंटी इन्फ्लेमेटरी एजेंट्स कुछ नहीं करेंगे. सो पेशेंट्स ट्रीट हो नहीं पाते हैं, पेशेंट्स go from one doctor to another, and then they develop that cancerophobia and delusion कि मुझे कोई बड़ी बीमारी है, which that even the doctors are not able to diagnose and treat. Because we are not aware of this fact that burning mouth syndrome actually occurs. Now this burning mouth syndrome is seen in postmenopausal female usually, and it is seen in those females who are stressed. जो लोग अपनी दिल की बातें अपने दिल में रखते हैं, दूसरों से शेयर नहीं करते हैं, they develop this burning mouth syndrome. The trigeminal nerve के जो C fibers हैं, they get stimulated, resulting in that burning sensation. And I am not lying this, but because I have done a lot of publication on this, I have done a lot of research on this project of burning mouth syndrome, and I do visit several clinics also to treat these patients. And it is a surprise survey, but 8 out of 10 females tell me, when I ask them कि आप परेशान है क्या, तो पहले तो बोलती नहीं नहीं हमें तो कोई ऐसी प्रॉब्लम नहीं है. फिर मैं आराम से बैठ के जब पूछता हूँ नहीं नहीं सही से बताइए, आई एम श्योर यू आर स्ट्रेस्ड फॉर some of the other reason, then वो मेरे को क्या बोलती हैं, 8 out of 10, and I'm not joking, they say हाँ बेटा हम परेशान हैं. हमारा बेटा अब हमारा नहीं रहा, वो अपनी वाइफ की सुनता है, अब हमारी सुनता ही नहीं है. और मैं किससे अपनी दिल की बात करूं, जब कोई सुनने वाला ही नहीं है तो अपनी दिल की बात किससे करूं. मैं किसी से कर ही नहीं पाते हैं, मैं कर ही नहीं पाती हूँ किसी से बात, और अपनी बात दिल में रखती हूँ. और देखो ना अब ये सब शुरू हो गया. एंड एट द सेम टाइम आई से आई अंडरस्टैंड मैम, चिंता मत करिए, आप मुझसे बात करिए, आप मुझसे शेयर करिए, यू विल बी फाइन. एंड आई टॉक टू देम फॉर half an hour, and in the next visit they are happy. They come with some sweets or all, I am feeling much better. I haven't given any medicine. I have only understood the problem. कोई आजकल सुनने का टाइम ही किसके पास है? आप लोग जितने स्टूडेंट्स बैठे हैं, कितने अपनी मम्मी पापा के पास बैठ के जाके बातें करते हो? किसी के पास टाइम नहीं है. वी ऑल आर बिजी इन आवर लाइव्स. तो वो किससे बात करेंगे? तो वो जब बात कर पाते हैं अपनी, दे फील बेटर. अगेन आई एम टेलिंग यू, दिस बर्निंग माउथ सिंड्रोम है, इसको प्लीज इग्नोर मत कीजिए. जितने भी लोग यहाँ बैठे हैं सुन रहे हैं, इफ यू कम अक्रॉस सच केसेस, प्लीज टेक देम सीरियसली, टॉक टू देम, एंड they actually need treatment. Again, most of the times anticonvulsants like clonazepam or antidepressants like amitriptyline are given in such treatments. But more than that, counseling helps, that stress management helps more than these medicines. The next case is simple. I'm sure all of you are dentists here, you all know about this, that when we take a lot of stress, we develop some parafunctional habits like bruxism. The effects directly goes up to the muscles and TMJ. Lateral pterygoids get affected, TMJ get affected, and MPDS develops. Nothing it is new. Everyone knows what is myofascial pain dysfunction syndrome. And जो लोग बोलते हैं that MPDS is because of occlusal disharmony, no. MPDS is because of emotional stress. ये तो NEET में भी question आता है, which is the most common reason for MPDS. Answer is always emotional stress. कोई स्ट्रेस है, हमें नहीं पता, बस हमारे अंदर स्ट्रेस है, और जब हम स्ट्रेस के साथ सोते हैं, then we keep on clenching our teeth. That is called as bruxism. And when we do that, the load, effect, everything goes to these muscles and TMJ, and all the problems occurs. And then you treat whatever medicines you treated with, whatever muscle relaxants, कितना खिलाओगे, all are associated with side effects. कितना आप लोग toxins दोगे, कितना TENS therapy, whatever, phorophoresis दोगे. But till that stress is gone, जब तक वो नहीं जाएगा, you will not be able to treat that patient. And because the patient is not getting treated, that stress keeps on increasing, and increasing. Right? So this is a cycle. This is a typical cycle. Then next case, this is again related to TMJ, as I was discussing with him, but the sir is not here. But what happens is, when we take stress, again, because of that occlusal load, the disc gets displaced. I'm sure many of you must have heard of the term disc dearrangements. Disc displacement with reduction and disc displacement without reduction. There are two things which we should know, which actually occur. कितने लोग हैं यहाँ पे जो बैठे हैं जिनको clicking होता है? कोई है जिसको clicking है TMJ में? Clicking sound? नहीं है तो अच्छी बात है, क्योंकि और अगर है तो और अच्छी बात है, क्योंकि जो अच्छे लोग होते हैं ना, उन्हें क्लिकिंग होता है. मेरे को है क्लिकिंग. केवल अच्छे लोगों को क्लिकिंग होगा, जो दिल के बहुत अच्छे होते हैं ना, जो दूसरों के बारे में बहुत सोचते हैं, जो दूसरों की बहुत चिंता करते हैं, वो इतनी ज़्यादा चिंता कर लेते हैं कि अपने बारे में नहीं सोच पाते हैं. वो ये नहीं जानते that how they will serve from an empty vessel, because they think a lot for others, their disc gets displaced. Because occlusal load की वजह से trauma है यहाँ पे, disc gets displaced. And clicking is because that disc comes back to its original position. I don't know, I'm not teaching oral medicine, but जब clicking होता है, suppose this is the disc and this is the condyle. When the patient opens the mouth, तो disc आगे displaced है, तो disc एक वापस आती है पहले ऐसे, like this it comes back, tuck करके. ये जो tuck करके it is coming back is called as clicking. Then the patient is like easily patient can open the mouth. But then, if we don't, most of the times it don't require any treatment, but if it's severe stress और ये चीज़ बढ़ता रहता है, it converts into disc displacement without reduction. That means now disc is not coming back. If disc is not coming back, तो फिर मुंह कैसे खुलेगा? Patient आ करके मुंह खोलने की कितनी भी कोशिश कर ले, वो मुंह नहीं खोल पाता है. That is disc displacement. So this is all related to stress component only. And trust me, not very easy to treat. Splints बनाए जाते हैं, surgery तो कोई नहीं कराता. A lot of occlusal soft splints are there, which are being made to treat them. But then again, कितना भी कर लो, वो जब भी हटाओगे और वो stress component नहीं हटाओगे, तो these things will persist, right? Next case, because I'm talking about TMJ, so I'll tell you regarding this case also. ये हाथ देख के आपको समझ में आ जाएगा. वो morning stiffness जब हाथ में होती है, that swan neck-like appearance is seen in the hands, when the patient morning में tries to flex the finger, सीधी करने की कोशिश करता है, वो हो नहीं पाती, तो हम समझ जाते हैं this is one of the most initial sign of developing rheumatoid arthritis. Now, rheumatoid arthritis is an autoimmune disorder, not uncommon. It is commonly seen in young individuals also these days. As I'm talking about, that anxiety is there, so it is common. But when it affects the TMJ, तो वैसा हो जाता है. The normal condyle converts into like a pointed condyle, that is called as sharpened pencil appearance of condyle, because there is something called as pannus formation, that is a synovial granulation tissue which develops because of this rheumatoid arthritis, and it destroys the bone and the condyle, and condyle gives this typical appearance which is called as sharpened pencil appearance. This is typical of rheumatoid arthritis affecting TMJ, right? Rheumatoid arthritis, again, related to this anxiety and stress. The simple things like xerostomia, मैं अभी बोल रहा हूँ मेरे को प्यास लग रही है, because when I'm speaking on stage in front of people and the senior people, so I'm anxious, I'm stressed, I'm feeling thirsty, because xerostomia is naturally developing. But then, yes, these are all treatment, we leave it now. But then, lots and lot of stress can aggravate that autoimmune factor, and when the autoimmune factor is aggravated, then problems like Sjogren syndromes can develop, or agar ye Sjogren syndrome jaisa problem develops, then it becomes difficult. You know what is happening actually in our body? When we take stress, there are two particular mechanisms. One mechanism is related to adrenal medulla. I'm sure everyone knows that adrenal medulla secretes adrenaline and noradrenaline. Now these adrenaline and non-adrenaline, again, वो T helper cytotoxic cells को increase करके stress levels बढ़ाकर affect करता है body में. The other mechanism is related to HPA axis, hypothalamus pituitary axis, which secretes lot of steroids, and when in our bodily steroid secretion increases, the immunity comes down. And when the immunity comes down, all the immune mediated diseases, they occur in our body. The third mechanism is when we take stress, हम लोग खाने ज़्यादा लगते हैं. होता है ना, जब आप stressed होते हो, एग्जाम होता है, कुछ भी है खाना है हमें बस खाने से आराम मिल रहा है. What we are doing is, we are troubling our body. People start smoking. What they are doing is, they are troubling their body and the oral cavity and oral mucosa. So these are the mechanisms by which stress-induced effects do occur in our body. Very simple, but yes, taste sensation भी disturb हो जाता है. कुछ लोग आके बोलते हैं हमें taste नहीं आ रहा है, sensation disturbed है, एक बार ले लो anxiety वाला history, because it is also related to the same thing. And this, as I am already talking about, no, this is not gingivitis. This is not gingivitis, normal gingivitis, what you see on the screen. This is desquamative gingivitis. I don't know how many of you are familiar with this term, and how many of you actually can diagnose desquamative gingivitis in your clinics. I don't know. But if you can, then it is well and good, because desquamative gingivitis in itself is not a disease. It's a manifestation of an underlying autoimmune disorder, most commonly seen with erosive lichen planus, pemphigoid, and those such kind of autoimmune diseases. Now students, the desquamative gingivitis को diagnose कैसे करना है? We have some scrapable sloughing on the gingiva with underlying red erythematous component present. And kabhi bhi you see such a presentation, do check for the buccal mucosa and other things as well, because you will find some white striae or something like that which will tell you that this is an autoimmune disorder. Sir, good afternoon, sir. Really happy to see you here. So, this is desquamative gingivitis associated with several autoimmune disorders. As you can see, first one is lichen planus, then we have aphthous, we have pemphigus, so there are many, SLE, DLE, all of you are aware of these things. I'm not going into the details of these, but yes, this is a known fact that autoimmune disorders, they are aggravated with this anxiety. Our oral cavity हमें बता देती है, मुंह खुलते ही हमें बता देती है, अच्छा आप stressed हो, बताने की जरूरत ही नहीं, हम देख के बता देते हैं that the patient who are with us is stressed or not. और आजकल तो बच्चों में, see, these are the, I'm not saying this, these are all publications, ulcerative lichen planus in childhood. And I have seen in my college also children developing lichen planus. Now this is something which should not happen, but it is happening. I don't know how many of you, because mostly are the practitioners, dental practitioners, I don't know how many lesions you see, but trust me, as an oral medicine specialist, after every 3 days I am seeing a lichen planus. This was not before, this is now, because of increasing lifestyle anxiety and stress in our lives. So children are developing such things. Gingiva and periodontium, the literature is, literature is flooded with the articles on effect of stress on periodontal disease, so I'm not going into the details. That is all known fact, and I'm sure all of you know that stress से Periodontal and gingival health disturb होता ही होता है. They are simple things. When we take stress, we start chewing our own mucosa, buccal mucosa. We have self-destructive habits. We keep on clenching, we keep on biting our buccal mucosa and developing such lesions. और फिर जब develop हो जाते हैं, then we go into tension. हमें और tension शुरू हो जाता है. अरे कहीं कोई potentially malignant disorder तो नहीं हो गया है. और फिर जब diagnosis ही correct नहीं हो पाती है, तो वो stress level और बढ़ता रहता है, and then things are again becoming deteriorating. ये तो बड़ा ही इंटरेस्टिंग है. बॉडी डिस्मॉर्फिक डिसऑर्डर सब लोग जानते हैं. जब हम स्ट्रेस होते हैं ना, खड़े हो जाओ शीशे के सामने थोड़ी देर, हाँ यहाँ से चेहरा थोड़ा बड़ा लगने लगे, मेरा मोटा हो गया यहाँ से चेहरा, यहाँ से तो ठीक है, नहीं नहीं यहाँ से भी मोटा लग रहा है, नहीं इधर से ज़्यादा मोटा लग रहा है. ये सबके साथ होता है. दिस हैपेंस विद मोस्ट ऑफ अस व्हेन वी आर स्टैंडिंग इन फ्रंट ऑफ मिरर. और हम जब एक एज तक, मेरी एज तक आ जाते हैं, जब हमें लगता है कि अब हम एल्डरली होने जा रहे हैं, तो हम अपने आप को देखते सोचते रहते हैं, अच्छा हम अभी ऐसे होने लगे हैं. एक्चुअली हमारी एज तक आते आते स्ट्रेस लेवल भी बढ़ता है, बिकॉज लाइफ में बहुत सारी रिस्पॉन्सिबिलिटीज़ बढ़ती हैं. तो ये सारी चीज़ें, इतना टाइम हम निकाल पाते हैं और ऐसे ख्याल हमारे मन में आने लगते हैं. दिस शुड नॉट कम. दिस इज ऑल्सो समथिंग वेरी इंटरेस्टिंग, अगेन एसोसिएटेड विद स्ट्रेस. हेलिटोफोबिया वेरी कॉमन. कुछ लोग तो बैठ के यही सोचते रहते हैं, अरे यार बात करने से पहले कुछ इलायची खा लेते हैं, कहीं मुंह से बदबू तो नहीं आ रही है. अगेन that person, if he's thinking this much, that means he's under grade 2 stress. And yes, as I told you, the immunity is coming down when we take stress. क्या हो रहा था कोविड में? Most of the, I don't know how many of you know, but COVID time पे, I'm not, because I'm an oral medicine specialist, so I'm not boosting it, but yes, I'm telling you that I was one of the most contacted oral physician during COVID, and I did my publication also. I published a research of 179 COVID patients who consulted me telephonically. They were developing oral lesions. But why were they developing oral lesions? इसलिए नहीं, कोविड का डायरेक्ट लिंक था. That was all linked to the stress. COVID हुआ, people were dying. That stress component was increasing, and our immunity level was coming down. So most of the times, the people during COVID, they were developing herpes labialis, herpes zoster. If that lichen planus component was there, that was getting stronger. Right? Candidiasis was developing. So yes, stress decreases our immunity. And yes, all immunocompromised diseases like viral infections, fungal infections do develop in our body. This is herpes zoster. I mean, this is unilateral. If it is unilateral, it is zoster. If it is bilateral, then it is simplex. And yes, this is NF. This also is related to stress. So a lot of articles are there which gives authentic classification of such anxiety and stress related disorders. And बहुत लंबा है. दिस इज साइकोसोमैटिक डिसऑर्डर्स टर्म है. मैं वो पूरा पढ़ाने के लिए नहीं था, बट आई जस्ट वांटेड टू टेल माय एक्सपीरियंसेस विद यू. स्पेसिफिकली आई वांट टू टेल यू दैट इन योर क्लिनिक्स इफ सच पेशेंट्स कम एंड से हमें यहाँ दर्द होता है, हमें टंग में बर्निंग होता है, डू ट्रस्ट देम. डोंट जस्ट जंप टू कंक्लूजन इनका कोई कंपोनेंट यहाँ कुछ खराब है इस वजह से ऐसा बोल रहे हैं, बिकॉज हमें तो कुछ दिख नहीं रहा है. Please do not jump to any conclusion. It is actually there. Those trigeminal nerve fibers are actually stimulated. But we need to understand that patient. Don't just send that patient to some neurologist, because they will start writing medications. Which medications? I'll just show you. And those medications will again deteriorate them. Because of their side effects. Listen to your patients. They need your patience. They need to tell you something. You listen to them, then only they'll be completely treated. So these are all researches which are done on these psychosomatic disorders, which says that lichen planus, pemphigus, all these are related to old age. Elderly people, they usually develop these burning mouth syndromes and such problems. Young patient develops because of stress either MPDS or that atypical facial pain which I was telling you, or that atypical orontalgia, that phantom tooth pain. कि RCT के बाद भी दर्द जा नहीं रहा है. All related to nerves. वो young patients में हो रहा है and बहुत ज़्यादा हो रहा है. And ये known fact है कि कुछ चीज़ें female में common है, कुछ चीज़ें male में common है. हम हमेशा पढ़ते आए हैं. Lichen planus हुआ, these disorders, stress-related disorders are more common in females, because females they take lot of stress. But कहाँ हैं अभी? Females are not taking lot of stress these days. They are giving stress. So ये सब change हो गया है अभी. Males are having all these problems. Lichen planus male ज़्यादा आ रहे हैं. परेशान है वो लोग अपने घर पे. So this is actually happening. So this, ये तो I don't agree with this. Female and male वाला अभी हम लोग को छोड़ देना चाहिए, more common in females and males, all everything is changing. And yes, you give best treatment, but until that component जो tension stress है वो नहीं जाएगा, the treatment हम कुछ भी best treatment देंगे, it is not going to help us. So how to deal with your stressed patients? Best is to give these medications. फटाफट उनको anti-anxiety drugs दे दो, antidepressants, convulsants दे दो, बहुत बढ़िया है. I always take this name Miss Nirupara Roy because she is supposed to be the highly stressed lady. जब से मैं छोटा था तब से मूवीज में मैंने देखा है वो बेचारी हमेशा ही परेशान रहती थी. So if such a patient comes, तो उनको हम जो medicines देते हैं, alprazolam, amitriptyline और gabapentin, these are all anticonvulsants and antidepressants. But these anticonvulsants and antidepressants आप दे तो दो, but what will happen the next day? Patient जो stress था वो stress छोड़कर, क्योंकि stress पे लोग कई बार बोलते ज़्यादा हैं या कम बात करते हैं, वो stress छोड़ के बस सो रहे हैं. नेक्स्ट डे उनके बच्चे आके बोलते हैं कि सर वो स्ट्रेस ही ठीक है, बिकॉज अब तो वो चुप हो गई हैं, अब तो वो सोते ही रहती हैं. सो अगेन दीज मेडिसिन्स वी हैव टू गिव समटाइम्स बट नॉट ऑल द टाइम. प्लीज टॉक टू योर पेशेंट. सो आई ऑलवेज से, एंड यस डेंटल सर्जन्स व्हाट दे आर डूइंग इज, बिकॉज वो बर्निंग है, समझ नहीं आ रहा, तो दे गिव दिस डोरोजेल, डेंटोजेल, म्यूकोपेन कि भाई हमें कुछ तो देना है. दे हैव गिवन अस द कंसल्टेशन. बट आजकल अगर आप ये मेडिसिन देंगे तो पेशेंट एक्चुअली बोलेगा अरे वो तो हमारे घर पे रखी है ना, हम तो लगा लेंगे, खुद ही लगा लेते हैं वो. सो दीज आर ऑल्सो नॉट गोइंग टू हेल्प. वॉट हेल्प इज, अगर आप बोलोगे भी ना नहीं टेंशन मत लो, अरे आपकी टेंशन से हो रहा है, आप ठीक हो जाओगे, तो भी कुछ नहीं होने वाला है. बिकॉज बोलना तो बहुत आसान है, मैं कितना चिल्ला के बोलूँ दैट एवरीवन हु सिटिंग देयर प्लीज स्ट्रेस मत लीजिए. आप लोग स्ट्रेस लेके अपने को हार्म कर रहे हो. बट ये बोलना बहुत आसान है. मैं खुद ही तो अभी यहाँ पे खड़े हो गया, आधे से ज़्यादा स्ट्रेस्ड हूँ. So everyone is stressed, no one can help it. But yes, what I say is that what I have learned is that we need to develop trust of the patient. I think I have taken a lot of time, but एक छोटा सा experience I would love to share with you all, because ये एक ऐसा experience है जो I always cherish, and I want all of you to just listen to me for 2 minutes. For 2 minutes, एक small story है. There was a patient, he lived in a village somewhere, and he showed to a local doctor, dental surgeon there. He was having lichen planus, और वो डेंटल सर्जन ने बोला अरे ये सफ़ेद ना, ये तो मुझे लग रहा है कि कैंसर में बदल रहा है, तुम ना ऐसा करो किसी बड़े अस्पताल जाके दिखाओ. बस इतना कहना था. वो पेशेंट के छोटे छोटे बच्चे थे, वो पेशेंट खत्म हो गया. वो 3-4 दिन तो सो ही नहीं पाया. 3-4 दिन तो दैट पेशेंट वाज अंडर स्ट्रेस एंड depression. But then he came to us, he came to our college, Subharti Dental College, and then wo patient, luckily I was on the OPD that day, so I happened to see that patient, and then that patient said कि डॉक्टर आप मुझे बस इतना बताओ, क्या मैं अपनी बड़ी बेटी की, मैं 1-2 साल में शादी करने की सोच रहा हूँ, उसकी शादी कर पाऊंगा? मैंने बोला ऐसा हुआ क्या, पहले ये तो बता दो. कहते सर वो कैंसर बोला है, मेरे मुंह में तो बन रहा है. I just saw that and I just said कि this is lichen planus, this is very common. Although it is potentially malignant, but only 2% to 10% it is given in literature. But in my 13 years of experience, I have not seen even a single lichen planus case converting into malignancy. होता है, but हुआ नहीं है, तो आप इतना घबरा क्यों रहे हो? Don't worry, trust me. I am giving you medications. Take these medications, you will feel better. I gave medications, and after 15 days, that patient came with the whole family. Lichen planus, not completely, but it had come down to a very बहुत ही थोड़ा सा रह गया था. And that patient and the family was super happy that that patient had got sweets for me and was given blessings to me, and I was so happy to had that feeling which I had. And then he went off and he kept on calling me once or twice that I'm feeling better. अब वो जब भी मुझे कुछ होता है वो medicine से मेरा better हो जाता है. But then suddenly what happened one day, after a month or 2 months, his wife came to me. I was sitting in the OPD. She said, "Sir, आप 2 मिनट बाहर गाड़ी तक आ सकते हैं?" I asked, "हुआ क्या?" She said, "वो सब कुछ भूल चुके हैं." मैंने बोला, "सब कुछ भूल चुके हैं?" हाँ, उन्हें कुछ हुआ, उन्होंने उस न्यूज़पेपर में पढ़ा, उसके बाद बिकॉज समथिंग हैपेंड इन हिज ब्रेन, एंड अब वो कुछ नहीं पहचान रहे हैं, वो हमें नहीं पहचान रहे हैं, उन्हें यही नहीं पता मैं उनकी वाइफ हूँ और ये उनका बच्चा है. बस वो एक को पहचान रहे हैं, वो आप. उन्हें एक नाम याद है, डॉक्टर सुमित, और मुझे उनके पास ले चलो, बस वही मुझे ठीक कर सकते हैं. बिकॉज दैट ट्रस्ट वॉज देयर, दैट बिल्ट अप. I didn't understand ये हुआ क्या, but then I went outside and I can see him, he was lying like this. I said, आपको हुआ क्या? तो उसने मुझे देख के बोला, अब आप मुझे मेडिसिन बताओ, आप जो मेडिसिन बताओगे बस मैं वही खाऊंगा, क्योंकि आप ही मुझे ठीक कर सकते हो, पहले भी आपने मुझे ठीक किया था और मुझे बोला था मुझे कैंसर नहीं है। आई सेड ऐसा नहीं होता है, आप डॉक्टर के पास जाओ। ही सेड आप बोल रहे हो तो मैं डॉक्टर के पास जा रहा हूँ, वरना मैं नहीं जाता। देन ही वेंट देयर। देन उनको एडमिट करना पड़ा, बिकॉज आई थिंक उनके सब लेवल्स जो थे, पोटेशियम सोडियम लेवल्स, वो कम हो गए थे, सो ही हैड सफर्ड दैट, so he got admitted, but then he was not taking any medicine in the hospital. Then I got a call from the hospital authorities, you need to visit this patient, he only want you as a doctor. In the evening I went to that hospital, and in that hospital that neurosurgeon was there. That sir said that we'll pay you every day at 5 o'clock, you just need to come for 5 minutes and talk to this patient. And I did that for a week when he was there in the hospital. मुझे कुछ नहीं करना था, वहां जाके बस बोलता था, अरे आप ठीक हो रहे हो, दवाई खाई आपने, ये वाली दवाई खाई, देखो कितना बेटर हो गया है. And I just did that, and after 1 week he was perfectly all right. आज भी ठीक है, आज भी खुश है, आज भी बात होती है. And I do need coaching, उनकी daughter मुझसे ही need coaching भी ले रही है, and I'm happy with this. So it's a small experience I'm telling you. If you want someone to get cured, उनका वो trust please develop कराओ. बिल्कुल बहुत ईजी है बोलना, योगा करो, मेडिटेशन करो, जो लोग कर पाते हैं उनके लिए बहुत अच्छा है, जो लोग नहीं कर पाते उनको अपनी बातों से ठीक करो, बहुत इंपॉर्टेंट है. एज अ गुड डॉक्टर, टॉक टू योर पेशेंट, देन ओनली your patient will be cured. And I don't know how many of you know about this cognitive behavioral therapy. It is very good, very interesting. This is done these days for all stressed patients. Cycles hoti hai ye. In cognitive behavioral therapy, they say that thoughts create feelings, feelings create behavior. If we have negative thoughts, हमारी feelings negative होंगी and हमारा behavior negative होगा. If we have positive thoughts, हमारा feelings भी positive होगा and हमारा behavior भी positive होगा. And these sessions, these psychiatric sessions होते हैं, and they change the thoughts of a patient. And जब हमारे thoughts feel होंगे, if you feel you are all right, if you feel you are blessed, if you feel you are loved, you will be happy. If you feel सब कुछ अच्छा है, ये जो इंसान इतनी देर से बोले जा रहा है, हमारा टाइम वेस्ट किए जा रहा है, अच्छा है, तो मैं आपको अच्छा लगूंगा. If you will feel नींद आ रही है, पका दिया इतनी देर से बोल के, तो मैं आपको बुरा लगूंगा. So please, that is what I say is that this is very important, that all of us should think good, see good and appreciate good things. And I always say ये सब तो बड़ा आसान है कि हम पेशेंट्स को बोलें कि अपना ECG, EJ, मसल्स एक्टिविटीज़ देख लो, आप कितने स्ट्रेस्ड हो. लेकिन मुझे ऐसा लगता है कि हमें किसी को अगर अच्छा करना है तो we should always appreciate them, because positive reinforcement and appreciation matters a lot. चाहे वो पेशेंट हो, चाहे हमारे बच्चे हों, चाहे हमारे पेरेंट्स हों, चाहे हमारे फ्रेंड्स हों, चाहे आप लोग हो. So we should always praise people to make them happy. Small things we need these days, so that is good. And thank you so much. My conclusion, and I again say, हम लोग सब stressed हैं, but we need to be happy. हमें खुश होने का पूरा हक है, because our parents need us, our children need us. And जब तक हम खुश नहीं होंगे, हम अपना ध्यान नहीं रखेंगे, हम उनका अपने जिनको हम प्यार करते हैं, हम उनका ध्यान कैसे रखेंगे, right? Thank you so much.
Thank you so much, sir, for your wonderful lecture on oral and maxillofacial anxiety. Do you feel so? We all are stressed in everyday life, and this lecture will help us to get the symptoms and to get the conditions of our oral cavity diagnosed in hand by us. So thank you so much, sir. Now moving forward to the next lecture. Before moving forward to the next lecture, I would like Dr. Anmol Bagaria ma'am and Dr. Ashish Chandra sir to come on stage for the felicitation of the guest speakers. I would also request Dr. D.N. Kapoor sir and Dr. Siddharth sir to come on stage for the felicitation. So I would like to call upon Dr. Sumit Goyal sir, who had just delivered the lecture. Thank you, sir, once again for the lecture. It was very guiding. Dr. Sumit Goyal sir. I would also like to call upon Dr. Sanjay Arora sir for his felicitation. He is the next guest speaker of the day. Please give a round of applause for sir. Next, I would like to call upon Dr. Sukhdeep Singh sir. Dr. Sukhdeep Singh sir is associated with Sharda University and has helped us to organize the conference. Thank you, sir. Next, I would like to call upon Dr. Nitin Bhagat sir. Dr. Nitin Bhagat sir. Thank you, sir, for helping us with the conference. Please give a round of applause for sir. Next, I would like to call upon Dr. Rohit Sharma sir. Sir is also associated with Sharda University and has helped us with the conference. Thank you, sir. We appreciate your efforts. The next speaker is yet to give the lecture, but I would like to call upon Dr. Abhinav Sharma sir. Dr. Abhinav Sharma sir, he is yet to give the lecture and he will deliver the lecture on lasers, a hope of ray in orofacial pain and preventive oral oncology. We thank you in advance, sir. Please give a round of applause for sir. Dr. Abhinav Sharma sir. Next speaker is also left out to give the lecture, but we'll call upon sir, Dr. Nitin Garg sir. He is going to deliver a lecture on impression implants. Please give a round of applause for sir. Dr. Nitin Garg sir. The next speaker that is felicitated in advance is Dr. Achint Juneja sir. Dr. Achint Juneja sir. He will deliver the lecture later on. Please give a round of applause for sir. Thank you, sir and ma'am. I would request the respected dignitaries to please proceed to their seats. We'll continue with the lectures. So the next speaker for the day is Dr. Sanjay Arora sir. Dr. Sanjay Arora sir is a leading endodontist and a TMJ and occlusion specialist practicing in south of Delhi since 28 years. He has been highly appreciated by leading researchers in the world. He has been practicing TMJ-centered dentistry since 17 years, and his practice is quite large and has a staff strength of 55 employees. Dr. Sanjay Arora sir is going to give the lecture on learn curing TMJD, headaches, neck, shoulder, and other body parts in less than 5 minutes, research aspects. We welcome you, sir, and eagerly wait for your lecture, sir. Please give a round of applause for sir. I request all the delegates who are attending the lecture to please occupy the center rows and the middle rows, please.
गुड आफ्टरनून. गुड आफ्टरनून. जब तक आगे बोलोगे नहीं मैं आगे चलूंगा नहीं. गुड आफ्टरनून. तो जो आज बाहर छोड़ के जाएगा इज गोइंग टू रिग्रेट थ्रू आउट हिज लाइफ और हर लाइफ, बिकॉज व्हाट आई एम गोइंग टू टॉक टू यू विल चेंज योर पर्सपेक्टिव अबाउट डेंटिस्ट्री कम्प्लीटली. प्लीज कम एंड सिट इन द मिडल. मुझे थोड़ा सा लगना चाहिए कि लोग यहाँ पे ज़्यादा है. अगर जितने लोग आ सकते हैं प्लीज रिक्वेस्ट. कैन यू हियर मी वेल? या इसको बंद कर दें माइक को? मैं लाउड है ना बोल सकता हूँ. ऐसे ठीक है? इंटरैक्टिव रखेंगे और आज मजा आ जाएगा. ठीक है? वो डॉक्टर गोयल हैं, चले गए प्रीवियस लेक्चर वाले. अच्छा, वो स्ट्रेस को हम 5 मिनट में ठीक कर सकते हैं, उनको बताना था. सो students, how many of you are students here? Just want to know the house before. नहीं मतलब okay, final years या final year से नीचे? फाइनल ईयर नीचे भी हैं, फाइनल ईयर से नीचे भी हैं. ओके, प्रोस्टोडोंटिस्ट, ऑर्थोडोंटिस्ट, Periodontists? Okay, good. So, इससे पहले मैं पर्सपेक्टिव चेंज करूंगा आपका about the dentistry, about the way we look at the dentistry. Started very young, lecturing here, Dr. Sandesh Maikar, Dr. Kumar Swami, Dr. Ajit Shetty. फिर मैं लेक्चर सर्किट से 10-12 साल के लिए मैं सोने चला गया. Started now. Let's hope I am able to help you guys out. So we have been on national TV with stalwarts like Dr. Venugopal talking on this subject. He verified almost 50 cases of recovery. Then only he decided to come on the national TV. Gave two times he came and gave beautiful interview on that subject. So we will keep perspective of talking to each other in a non-scientific language. मंजूर है? भाषा का प्रयोग जो हम करेंगे वो साइंटिफिक लैंग्वेज नहीं करेंगे, पर्सपेक्टिव साइंटिफिक रखेंगे. इज दैट ओके? ठीक है, क्योंकि मेरे हिसाब से इतना कॉम्प्लिकेटेड है हमारी जो स्क्रिप्ट है जो लिखी हुई है बुक्स के अंदर में कि नॉलेज पहुंचती नहीं है स्टूडेंट्स तक या डॉक्टर्स तक. सो इफ यू आर विलिंग, क्योंकि आइंस्टाइन कहता था कि 6 साल के बच्चे को आप नहीं समझा सकते तो आपको खुद को समझ में नहीं आया. ठीक है, तो मैं बिल्कुल लेमैन लैंग्वेज इस्तेमाल करूंगा. वेरी फ्यू साइंटिफिक टर्म्स आई विल यूज, बट मुझे आती सारी हैं. ओके, सो दीज आर लॉट ऑफ इंटरव्यूज. प्ले करेगा. साउंड केबल है इसमें? इसमें साउंड केबल है? चलिए, जब तक ये अरेंज होता है हम वापस आएंगे. ये डॉक्टर सुरभि माहिदर है और ये जो पेशेंट इनका बता रहा है कि कैसे विद इन ए फ्यू मिनट्स द हेडेक completely went away. He is a leading prosthodontist and a trainer in temporomandibular joint, and ये उनका मैंने रखा है स्पेशली दिखाने के लिए. Then there are many more people who have had reliefs in various areas. I am not going to waste time on interviews. ये सर्वाइकल पेन के पेशेंट थे. करीब 20 साल से कॉलर पहनते थे. अमिताभ बच्चन के सगे भाई हैं और आज 12 साल से दोबारा कभी इन्होंने नहीं पहना. ये सारी वेबसाइट पे है. ये ओरल सर्जन है, बड़ी सीनियर, और काफ़ी सारी बॉडी पेन से सफ़र करती थी, स्ट्रेस से सफ़र करती थी. कम्प्लीटली क्योर्ड फॉर नाउ मोर देन 15 years. दिल्ली की लीडिंग ओरल सर्जन है. ऐसे बहुत से पेशेंट्स हैं. ये सारी की सारी मेरी वेबसाइट पे हैं. सो विल नॉट लीडिंग फिजिशियन. शी डाइड इन ए रॉबरी रिसेंटली, बट 10-15 साल दोबारा हेडेक्स, माइग्रेन्स का कोई आना जाना नहीं हुआ. नी पेन्स, बैक पेन्स, etc. Look at the lady in the on the this slide. खड़े होने में 85-year-old गायनेकोलॉजिस्ट को पूरा जोर लगाना पड़ रहा है सीधा खड़ा होने में. 5 मिनट के बाद राइट साइड की पिक्चर देखिए. 5 minutes later, after we finished the treatment. Interesting? आप करना चाहेंगे ये सब? तो बड़े साधारण शब्दों में समझाएंगे. टेम्पोरोमैंडिबुलर जॉइंट को अब देखिए, ये जो बॉल है ये एक गद्दे को डिस्क कहते हैं, मुझे आता है. ठीक है, तो वो उस गद्दे के साथ साथ आगे ट्रैवल करती है जब मुंह खुलता है. क्लियर? सिंपल. और ये पॉइंटर इस पे चलना चाहिए. ओके, तो ये बताइए कि ये जो एरिया है यहाँ पे ये गद्दा इतना मोटा और यहाँ पे इतना पतला क्यों है? सोच.
गद्दा मोटा तभी होगा ना कि जोर ज्यादा लगेगा, है ना? सो दैट्स द पॉइंट वेयर द क्लेंच टेक्स प्लेस। सर आप बाहर थे, मैंने परमिशन ले ली है नॉन साइंटिफिक भाषा में बात करने की सबसे। तो ये गद्दा यहाँ पे मोटा इसलिए है क्योंकि यहाँ पे दांत दांत क्लेंच करते हैं तो हाईएस्ट फोर्स होता है इस जगह पे, और यहाँ पे सबसे पतला इसलिए है कि ये वहाँ पे ग्रेविटी से मुंह खुलता है तो कोई जोर लगता नहीं है मुंह खोलते वक्त के अंदर में। ठीक है, ये बात अभी समझ में आएगी, इंपॉर्टेंट मैं क्यों बता रहा हूँ। क्लियर? अब देखिए एक जना मुझे चाहिए यहाँ पे, कोई भी, एनीबॉडी कम हियर क्विक। अरे भाई कोई भी आ जाओ भाग के। अब देखिएगा, ऐसे हाथ करो, ये ऊपर के दांत फिक्स्ड, नीचे के दांत ऐसे चलते हैं। अब अगर किसी के दांत एक तरफ के घिस जाएं कंपेयर टू द अदर साइड, तो मैं थोड़ा एनहेंस करके दिखा रहा हूं, तो क्या होगा, ऐसे और फिर ऐसे टिल्ट करेगा जॉ, बहुत माइक्रो लेवल पे, फ्रैक्शन ऑफ ए मिलीमीटर का टिल्ट होता है, बट वो जब टिल्ट करेगा तो वो टिल्टिंग का फोर्स कहां जाएगा, वो टिल्टिंग का फोर्स कहां जाएगा, वो इस जगह पे, क्लेंच तो यहां हो रहा था ना, तो टिल्ट भी वहीं होगा, तो वो फोर्स रिस्पॉन्सिबल होता है। ये देखिए टिल्ट हुआ और वो डिस्क स्लिप कर गई। लोग लगे रहते हैं डिस्क स्लिप होता है नहीं होता है, होता है तो वापस आता है कि नहीं आता है। अरे भाई क्या करना है, वो जान के करोगे क्या? मोटी बात यह है कि स्लिप हो रही है तो कोई फोर्स या खींच रहा है या उसको फेंक रहा है, लॉ ऑफ इनर्शिया कहता है। तो जब क्लेंच के वक्त में अगर जबड़ा टिल्ट कर गया बिकॉज एक तरफ के दांत घिस गए या निकाल दिए आपने, तो उसकी वजह से वो जो डिस्क है वो स्लिप आउट कर जाएगी, और वो डिस्क देखिए स्लिप करके गई कहां, वो अंदर चली गई। अब अंदर खाली जगह तो बॉडी में होती नहीं, देयर इज नो डेड स्पेस इन द बॉडी, तो वो अंदर के जो टिश्यूज हैं वो भी बाहर वापस धक्का दे रहे हैं कि भाई वापस जाओ, हमारी जगह पे क्यों आ गए। तो जब जगह मिलेगी उसे वापस आने की, देखिए फिर से देखिए इसको, ये बड़ी इंपॉर्टेंट स्लाइड है ये। अब क्या होता है कि जब यहां तक पहुंचती प्रोस्टोडोंटिस्ट को मैं यहां पूछना चाहूंगा कि एट दिस पॉइंट द कॉन्डाइल शिफ्ट्स डाउनवर्ड्स, व्हाई? At the beginning of the closing cycle, the condyle shifts downwards. Why? 99.99% prosthodontists have not been able to answer this question. जबकि किताबों में साफ-साफ लिखा है कि kinetic axis of rotation shifts downwards during the closing cycle. उसी के बेसिस पे आप ऊपर आपका fully adjustable articulator बना हुआ है। तो क्यों होता है वो नहीं मालूम बिल्कुल भी, वो किताब भी साइलेंट है उसके ऊपर। इसलिए ऐसा होता है कि जो जबड़ा है वो जब बंद करने की बारी आती है तो वो खाने को एंटिसिपेट करते हुए मसल्स ऑफ मैस्टिकेशन टेक ओवर कर लेती हैं और जबड़े को रीओरिएंट करती हैं उस खाने को क्रश करने की। इज दैट क्लियर? तो जो रीओरिएंटेशन होती है तो कॉन्डाइल नीचे की तरफ शिफ्ट होता है, नीचे की तरफ शिफ्ट होता है तो वो जो गद्दा दूसरी तरफ स्लिप हो गया था उसको उधर से धक्का मिल रहा था तो वो गद्दा वापस आ जाता। बड़ी सिंपल सी कहानी कि रिडक्शन क्यों होती है? रिडक्शन तब होती है जब कॉन्डाइल डाउनवर्ड शिफ्ट होता है। रिडक्शन क्यों नहीं होती है? जब नहीं होती है इसलिए कि या तो फंस गया या ढेर हो गया अंदर वाले टिश्यू से, इसलिए बाहर नहीं आ पा रहा। अब डिस्क डिसलोकेशन है, रिडक्शन है, उसे क्या करना है? हाउ डज इट हेल्प यू? एन ओरल सर्जन वुड से कि भाई मैं वापस उसको पकड़ के सिल दूंगा, वहां पे सिल भी देंगे तो फिर मुझे डिस्टर्बिंग फोर्स तो हटाया नहीं ना, वो फिर चली जाएगी, है ना? सो नाउ थैंक यू डॉक्टर साहब। वो गई कहां? वो डिस्क गई कहां? वो 1.5 इंच गहरी थी, रफली इतनी गहरी, वो गई कहां? Where did that disc go? it went into the intratemporal fossa, ये जगह पे चली गई, या एंटीरियरली जाएगी या एंटीरियर मीडियली जाएगी या मीडियली जाएगी या पोस्टीरियर मीडियली जाएगी, डिपेंडिंग अपॉन फोर्स किस जगह धक्का दे रहा है या खींच रहा है। डू आई मेक सेंस? बाहर की तरफ क्यों नहीं जाती? क्योंकि बाहर की तरफ में लिगामेंट है और अंदर की तरफ में पतली सी मेम्ब्रेन है, तो वो इंफ्राटेम्पोरल फोसा में। लेकिन पड़ा क्या है? सैंक्टम सेंक्टोरम है, सारी की सारी ब्रेन की नर्व्स जो हैं और ब्लड वेसल्स जो हैं वहीं से एंट्री और एग्जिट ले रही हैं। तो पहले तो ये जानना जरूरी है, क्या टेम्पोरोमैंडिबुलर जॉइंट डिजीज, कोई ओरल फेशियल पेन्स, कोई एमपीडीएस, कोई पता नहीं 50 नाम पढ़ के मेरा तो दिमाग खराब हो गया। समझ में किसी के नहीं आ रहा तो समझा नहीं पा रहे तो और कॉम्प्लिकेटेड लैंग्वेज कर दीजिए, जितना कॉम्प्लिकेटेड करते जाइए अंत ही नहीं है उस चीज का। तो वो जो डिस्क अंदर चली गई, वहाँ जो इतनी सारी नर्व्स हैं वो ना सिर्फ बॉडी पेन्स के लिए रिस्पॉन्सिबल है, कैसे रिस्पॉन्सिबल है मैं अभी बताऊंगा, दे आर ऑल्सो रिस्पॉन्सिबल फॉर, अभी ऑटो इम्यून डिसऑर्डर्स की बात हो रही थी, इसी वजह से होते हैं, रेस्पिरेटरी एलर्जीज, गैस्ट्रिक प्रॉब्लम्स, हार्ट प्रॉब्लम्स, साइकियाट्रिक प्रॉब्लम्स, ये जितनी गायनेकोलॉजिकल प्रॉब्लम्स, हार्मोनल डिसऑर्डर्स, ये सब इसी वजह से होते हैं। I will give you a small glimpse into this area today. Make sense? देखिए, अब यहाँ क्या हो रहा है, ये था कॉन्डाइल बॉल और ये थी सॉकेट, ग्लेनॉइड फोसा का ये बॉर्डर है, डिस्क यहाँ से लेकर के यहाँ तक थी, और देखिए सबसे पास टच करती हुई क्या पड़ा है यहाँ पे, इंटरनल कैरोटिड आर्टरी और एक्सेसरी नर्व। इंटरनल कैरोटिड आर्टरी के साथ साथ एक नर्व भी साथ में पड़ी होती है, जैसे सिंपैथेटिक ट्रंक कहते हैं, और पूरी स्पाइन को ट्रेवर्स करते हुए जितने भी हमारे विसरल ऑर्गन्स हैं, वाइटल ऑर्गन्स हैं, सबको सप्लाई हो देती है थ्रू द स्पाइनल नर्व्स। इट्स द सिंपैथेटिक ट्रंक ऑफ द बॉडी। वो 0.5 मिलीमीटर दूर पड़ी हुई है, और वो डिस्क ट्रैवल करके 1.5 इंच की डिस्क पूरी की पूरी उसको जा करके धक्का दे रही है। हमारे ब्लड प्रेशर कंट्रोल करती है, हमारे सारे ऑर्गन्स के फंक्शंस कंट्रोल करती है, कैसे नहीं करेगी प्रॉब्लम, है ना? डू आई मेक सेंस? हाँ ना, या सो गए? कुछ तो बोलो, शायद बोल दो। ओके, ये एक्सेसरी नर्व पड़ी है। एक्सेसरी नर्व कौन सी नर्व होती है, याद नहीं होगा किसी को भी, 11 नंबर की नर्व कहते हैं इसे, 11th क्रेनियल नर्व। यहाँ पे एक्सेसरी, यहाँ पे वेगस, यहाँ पे ग्लॉसोफेरेंजियल। अब एक्सेसरी नर्व, जो 12 क्रेनियल नर्व भगवान ने बनाई हैं, उनका भगवान ने बड़ा जबरदस्त काम दे रखा है। किसी को दे रखा है भाई तुम देखने का काम करो, किसी को आई बॉल को मूवमेंट का काम दे रखा है, किसी को सूंघने का काम दे रखा है, किसी को फेशियल एक्सप्रेशंस का काम दे के रखा है, किसी को सुनने का काम, किसी को बैलेंस मेंटेन करने का काम, मतलब सुपर स्पेशलाइज्ड फंक्शंस हैं। एक एक्सेसरी नर्व को एक अजीब सा काम दे दिया, और वो काम ये दे दिया कि भाई तुम ना सिर्फ 2 मसल संभालो, एक स्टर्नोक्लीडोमास्टॉइड और एक ट्रेपेजियस, एक ये और एक ये। अजीब सी बात लगती है कि भाई ये 2 मसल्स को संभालने का क्यों काम दे दिया। ये 2 मसल्स क्या करती है, ये हेड को सेंटर ऑफ ग्रेविटी पे रखती है, ठीक है? और हेड कितने किलोग्राम का है? 5 किलो का, किसी किसी का 6 किलो का होता है। और इस नर्व की इरिटेशन की वजह से हेड शिफ्ट्स इट्स पोजीशन। गांव में घड़ा लेकर के लेडी जा रही है, 3 मील चली जाती है, आप आधा मिलीमीटर घड़े को आगे पीछे करके देख लीजिए। आप होने वाले हैं फिजिशियन कल के। फिजिशियंस के पास इन प्रॉब्लम्स का कोई सॉल्यूशन नहीं। किताबें साफ साफ कहती हैं क्रॉनिक बॉडी पेन्स का कारण हमें नहीं मालूम है, तो ध्यान से सुनिए, आधा मिलीमीटर भी घड़ा आगे पीछे कर दीजिए, वो 4 कदम नहीं चल सकती है। तो सारा दिन इस घड़े को, पूरा दिन, बच्चे को 4 महीने लग जाते हैं नेक को ढंग से संभालने में, सीखने के लिए। सारा दिन इस 5 किलो के घड़े को आप एब्नॉर्मल पोजीशन पे कैरी करेंगे तो बॉडी की मसल्स तो टायर करेंगी ही करेंगी। There are lots of interdisciplinary theses on this subject all over the world. Google करके देखिए, amazing number of theses are there on this subject. किसी जिधर जिधर जिस जिस ऑर्गन पे कर्व्ड बैक के लोग होते हैं, स्ट्रेट बैक के लोग होते हैं, उसके हिसाब से उसका एक्स्ट्रा लोड जो करीब करीब नाउ इट बिकम्स 30 किलोग्राम, इसको कहते हैं मेटासेंट्रिक ग्रेविटी फिजिक्स के अंदर में। तो उसका लोड जिस जिस मसल पे पड़ेगा वो मसल थक जाएगी, और थक जाएगी तो दर्द करेगी। Do I make some sense? And if you know how to let the disc come back to its position, तो वो जैसे ही वापस आएगी वो नर्व से प्रेशर हट जाएगा, एक्सेसरी नर्व से प्रेशर हट जाएगा, इमीडिएटली जो आपका ये स्टर्नोक्लेडोमास्टॉइड एंड ट्रेपेजियस है, हेड को अपने सेंटर पर ले जाएगी और जाते साथ ही पेशेंट की पेन रिलीव हो जाएगी। यस, बहुत सारे इंटरव्यूज हैं, मैं वो अभी आपको सुनवाता हूँ सारे के सारे। So this is called as infratemporal fossa catastrophe hypothesis. I published it in 2010. And so look here, middle meningeal artery. This is the trigeminal nerve, foramen ovale से निकलती है। देखिए कितना कम डिस्टेंस है, ये 1.5 इंच है, और ये देखिए कितना पास है। यहाँ से मैंडिबुलर डिवीजन निकल करके मैंडिबल के अंदर घुस जाती है। यहाँ पे C2 C3 के फाइबर्स पड़े हैं, ये इंटरनल जुगुलर वेन पड़ी है। तो सारे के सारे वाइटल स्ट्रक्चर्स ऑलमोस्ट जॉइंट को टच करते हुए जा रहे हैं, है ना? तो कैसे नहीं नुकसान होगा, कैसे नहीं बॉडी। अब इसको टेम्पोरोमैंडिबुलर जॉइंट डिजीज कहें, या बैक पेन कहें, या नी पेन कहें, या ओरोफेशियल पेन कहें, या टिनाइटिस कहें, क्या कहें, नाम क्या दें, क्योंकि डेफिनेशन गड़बड़ हो गई ना टेम्पोरोमैंडिबुलर जॉइंट डिजीज की। अब कि टेम्पोरोमैंडिबुलर जॉइंट डिजीज से एक जना बोलता है कि ये लोकल पेन्स, कोई कहता है नहीं नेक तक भी हो सकती है, थोड़ा सर तक भी जा सकती है। अब देयर इज अ स्कूल ऑफ थॉट, और वो डेमोन्स्ट्रेट करते हैं कि सारे शरीर की दर्दें, रेस्पिरेटरी एलर्जीज और बहुत सारी बीमारियां, तो हम फिर किसको टेम्पोरोमैंडिबुलर जॉइंट डिजीज कहें? सोचने की बात है ना, डेफिनेशन गड़बड़ हो गई सारी की सारी। एमपीडीएस कहें, ओरल फेशियल पेन कहें, क्या कहें, और बड़ी सारी टर्मिनोलॉजी, इवन ट्राइजेमिनल न्यूरैल्जिया बाय द सिंपली रिस्पॉन्स 5 मिनट के अंदर में आप ट्राइजेमिनल न्यूरैल्जिया को ठीक कर सकते हैं। आई हैव लॉट्स ऑफ केसेस। तो क्या कहें बीमारी को? अभी मैं सजेस्ट कर रहा हूं, आगे दिखाऊंगा कि इसको हम ऑक्लूजल डोमिनोज डिजीज कहें। कि जब ऑक्लूजन में गड़बड़ होती है, तो जैसे साइकिल खड़ी है ना 20, तो एक साइकिल को गिराइए, देखिए सारी गिर जाएंगी, इसको डोमिनोज इफेक्ट कहते हैं। तो एक जगह प्रॉब्लम स्टार्ट हुई और ट्रैवल करते करते पूरे शरीर को एनकैप्सुलेट कर लिया। आप होने वाले हैं फिजिशियंस, आज से अगर किसी के समझ में आ गई ये बात, और शायद 2-3 महीने में अगर आप ट्रेनिंग ले लें इसकी, तो आप 2 से 3 लाख रुपए महीना अपनी अर्निंग बढ़ा सकते हैं। क्योंकि जो आपके पास पेशेंट आ रहा है उसको आप पूछ सकते हैं ना कि भाई नेक पेन तो नहीं है, बैक पेन तो नहीं है, फिर उसको बता सकते हैं कि ये भी करेंगे तो वो भी ठीक होने के चांसेस हैं। खतरा भी है, खतरा ये है कि अगर आपको ठीक से करना नहीं आता और आपने गलत कर दिया, एक बार मुझसे हो गया था, तो वो पेशेंट को अभी तक तो दर्द थी नहीं, अब हो जाएगी। तो अभी तक तो उसको पता नहीं था कि उसकी पेन का उससे रिलेशन है, आपसे रिलेशन है ना, तो ध्यान रखिएगा। तो एनीवे, so looking at it from another perspective, so that disc mugs up here, curls up here in this area, और यहाँ से जाने वाली सारी नर्व्स के ऊपर में इमेंस प्रेशर आता है। यहाँ तक कि साउंड आती है आपको अगर आप पास में खड़े हो, इतना प्रेशर होता है उसके अंदर, जगह ही नहीं है ना अंदर तो कहीं पे जाने के लिए। अब ये लेडी फॉर एग्जाम्पल 10 साल से न्यूरोलॉजी हॉस्पिटल पे जाती थी, माइग्रेन था, दोपहर में कभी घर से बाहर नहीं निकलती थी क्योंकि वो ट्रिगर हो जाता था माइग्रेन। अब देखिए कैसे ट्रीटमेंट करने के बाद में हम एम्पेरिकल डाटा से बात करेंगे। बाकी के जो डॉक्टर से पेन तो सब्जेक्टिव फेनोमेनन है ना, उसको नापेंगे कैसे, पता कैसे लगेगा कि भाई वाकई में है कि नहीं। जो पेशेंट बता रहा है उसके बेसिस पे आप चलेंगे। आइए एम्पेरिकल डाटा देखें। देखिए इसके मुंह में हम इस तरह का एक सेंसर डालते हैं और कुछ तारे लगा देते हैं, इलेक्ट्रोमायोग्राफी कहते हैं जिसे, और एक सेंसर डाल देते हैं मुंह में, पेशेंट को कहते हैं बाइट करने के लिए, एंड दिस इज व्हाट वी सी। Now this is called as a T scan. It's a pressure scan on time. It's very critical. टाइम वाला पार्ट इंपॉर्टेंट है, प्रेशर इंपॉर्टेंट नहीं है. जब हम खाना खाते हैं ना तो रफली 1000 मेगापास्कल तक के फोर्सेस जनरेट होते हैं. 1000 मेगापास्कल के फोर्सेस आप समझते हैं कितना होता है? दिवाली का छोटा बॉम्ब होता है ना, जो हाथ में पकड़ लीजिए और गलती से जल जाए. मेरे ब्रदर के छोटे चुटपन में जल गया था तो चिथड़े उड़ जाते हैं मांस के. इतनी पावर होती है 1000 मेगापास्कल में. गलती से बच्चा खाना खिलाते खिलाते उसकी उंगली बच्चे की आपके आ जाए, आपका ध्यान कहीं और था, बच्चा खाना खिला रहा था, आपका ध्यान कहीं और चला गया, तो उसकी उंगली क्रश हो जाएगी. इतना फोर्स है. लेकिन आपको महसूस तो होता ही नहीं, नहीं ना होता. हम जब खाना खाते हैं कहाँ महसूस होता? तो ये ऐसे है कि जैसे चौका मारा सचिन तेंदुलकर ने, बॉल ऐसे करके पकड़ी तो झन्नाटी रहेगी ये सारी चीजें अगले कम से कम 2 से 3 दिन तक. लेकिन अगर बॉल को आपने प्रॉपर तरीके से कैच किया तो आपको पता भी नहीं लगेगा कि बॉल कब आई आपके हाथ में. Do I make some sense? तो कुछ ऐसी बनावट है सारे स्ट्रक्चर की कि वो उन फोर्सेस को डिसिपेट कर देता है, इतने ब्यूटीफुली डिसिपेट करता है कि आपको पता भी नहीं लगता इतना सारा फोर्स लग गया और बार बार हर बाइट में लग रहा है ना. अब अगर सोचिए उस फोर्स की डिसिपेशन में जरा सी गड़बड़ हो जाए, है ना, और वो सीधा प्रेशर यहाँ बढ़ाएगा और उसके प्रेशर बढ़ने से वो डिस्क पे प्रेशर बढ़ेगा और डिस्क आगे अपना काम शुरू कर. यहाँ तक ठीक हूँ? मैं जा रहा हूँ, ठीक जा रहा हूँ? ओके. एक काम कीजिए, अपने फोन से मेरा टेलीफोन नंबर नोट कीजिए. कोई प्रोड्यूसर डायरेक्टर को जानते होंगे तो उसको मेरा नंबर नहीं देना. आई डोंट वांट शाहरुख खान टू बी आउट ऑफ बिजनेस. नोट कीजिए 98102. आगे मदद चाहिए ना, चाहिए ना? तो 98102 34065 and send me a hi on WhatsApp. 98102 34065. और कोई मुझे स्टॉक नहीं करेगा. You got it? Just send me a hi on WhatsApp. So ये देखिए, ये बता रहा है कि ये जो लाइन है ये वाली, इसको वेक्टर कहते हैं. वेक्टर का मतलब होता है डायरेक्शन. एक तीर है, वो किस दिशा में चला, वो ये इसको वेक्टर कहते हैं. ये समझ लीजिए. और ये तीर का अगला एंड है ये वाला, ठीक है. तो ये बता रहा है कि ये यहां से चला, फिर कभी लेफ्ट कभी राइट, अर्जुन के तीर की तरह कभी लेफ्ट कभी राइट होते होते फिर आखिर में जाकर के यहाँ पे तीर जाके अपनी एनर्जी को उसने डिसिपेट कर दिया. इसका मतलब क्या हुआ? इसका मतलब हुआ साधारण शब्दों में कि पहले ये दांत मिले. अब यहाँ प्रश्न बनता है प्रोस्थोडोंटिस्ट से पूछना, जनरल डेंटिस्ट से पूछना, भाई पहला दांत मिलता कौन सा है? तो कोई कुछ कहता है, कोई कुछ कहता है, कोई कुछ कहता है. बड़ी लंबी कहानी है, उसमें नहीं जाएंगे. आप सबसे पहले सेंट्रल इंसाइजर्स मिलते हैं, फिर लैटरल्स मिलते हैं, फिर कैनाइन्स मिलते हैं, फिर प्रीमोलर्स मिलते हैं, फिर मोलर्स मिलते हैं. बड़ी लंबी कहानी है, उसके लिए आज का डेट ठीक नहीं है. बट देखिए ये बता रहा है कि पहले ये वाले दांत मिले और फिर ये मिले, मतलब लेफ्ट साइड पहले मिली और राइट साइड बाद में मिली, मतलब राइट साइड के दांत घिस गए थे, है ना. और फ्रंट के तो मिल ही नहीं रहे. एंटीरियर टीथ आर नॉट मीटिंग एट ऑल, जबकि पहले मिलने चाहिए थे. तो इस तीर को कहां से आना चाहिए था? फॉरवर्ड बैकवर्ड आना चाहिए था, है ना. तो हमने थोड़ा थोड़ा मटेरियल ऐड किया, स्टेज मैनर के अंदर में ऐड किया, और जैसे ही ऐड किया, और ये देखिए मसल राइट टेम्पोरालिस, लेफ्ट टेम्पोरालिस, राइट मैसेटर, लेफ्ट मैसेटर. क्या दिखता है आपको? राइट टेम्पोरालिस की एक्टिविटी में क्या दिखता है कंपेयर टू द लेफ्ट टेम्पोरालिस? करीब 3 गुना ज्यादा है. सर दर्द कहाँ का था? राइट साइड का. राइट साइड में नी पेन थी, राइट साइड में हेडेक था, है ना. अब वो डॉक्टर साहब गोयल साहब कह रहे थे कि स्ट्रेस में हम सोचते हैं नहीं, हमें आता नहीं है क्योर करना, इसलिए हम पेशेंट के ऊपर में रख देते हैं। हमें क्योर करना आता हो एज ए डॉक्टर तो 5 मिनट से ज्यादा का पेन को हटाने का कोई लॉजिक नहीं। देखिए समझिए, तो अब ये राइट टेम्पोरलिस की इलेक्ट्रिकल एक्टिविटी 3.5 times more than the left temporalis थी, confirming that this is not a subjective pain, although I mean it's not a subjective phenomenon, although it is never a subjective phenomenon, it's always real. The patient is not imagining things. Now observe, as soon as we added the material, देखिए temporalis को, हाथ क्या शांत हो गई। तो पेशेंट ने कह दिया मेरा हेडेक चला गया, नहीं, वो दिखता है कि ठीक हो गया। और हमने क्या किया, हमने यहां मटेरियल ऐड किया और देखिए ये तीर को देखिए फॉरवर्ड बैकवर्ड आ रहा है ना। अब इससे ज्यादा ऑब्जेक्टिव डेटा क्या देंगे। ये देखिए पेशेंट को बोला राइट ग्राइंड कीजिए, तो पीछे के दांतों पे 28%, 41%, 17%, 8% फोर्स। ठीक है, होना कितना चाहिए पीछे के दांतों पे ग्राइंड करते वक्त में। वैसे ग्राइंडिंग हम करते नहीं है, वो अलग बात है, बट कितना फोर्स होना चाहिए, 0। सारा फोर्स कहां जाना चाहिए, ये सबसे लंबा दांत भगवान ने यहाँ पे कैनाइन जो दिया है इसी पर्पस के लिए दिया है। सबसे लंबा है, कर्वेचर ऑफ द आर्क पे है और सबसे कर्व्ड टूथ है। उसका काम है टेंजेंशियल फोर्सेस को, टेढ़े फोर्सेस को, कर्व फोर्सेस को एब्जॉर्ब करना। तो वो फोर्स इस पे होना चाहिए था, कैनाइन पे होना चाहिए था। देखिए मसल्स की हालत देखिए, राइट टेम्पोरलिस की हालत देखिए, लेफ्ट टेम्पोरलिस की हालत देखिए। जैसे ही जबड़ा राइट और लेफ्ट को जा रहा है, ऑब्जर्व कीजिए कि पेशेंट की हालत बिगड़ जाती है उसकी मसल्स की। दे आर अंडर डीप स्ट्रेस। नाउ इमीडिएटली आफ्टर द ट्रीटमेंट ऑब्जर्व, जैसे ही हमने कैनाइन की शेप और कैनाइन की पोजीशन ठीक करी और कैनाइन की थिकनेस ठीक करी, ये सब पे 0 0 0 0 और यहाँ 100 हो गया। देखिए ऑब्जर्व कीजिए मसल्स को। डू इट मेक सम सेंस? Immediately the response of the muscles is in 1 second. 50 साल पुरानी पेन पे। Observe left lateral excursion. Observe forces on these teeth. Observe the muscles. कितनी बुरी शेप में है। Post the treatment देखिए, प्री ट्रीटमेंट देखिए, ये मसल, ये सॉरी प्री ट्रीटमेंट देखिए, ये मसल 1200 मिली सेकेंड लेटर स्टार्ट हो रही थी ये वाली। पोस्ट ट्रीटमेंट देखिए, जैसे ही कैनाइन पे फोर्स गया, ये देखिए मसल्स का बिहेवियर एंड लुक एट द मसल्स, दे ऑल स्टार्ट इन द सेम सिंक्रोनिसिटी। मेरा नंबर ऐड कर लिया था, हाय भेज दिया था, पक्का? तो अभी तक का लेक्चर इसके आगे सुनना है कि नहीं सुनना है? सुनना है तो पहले यहाँ तक बताओ कैसा है, गुड है, बैड है, कैसा है? भेजो मैसेज भेजो, मैं देख रहा हूँ। उसके बाद ये इसको एक तरह का डिजिटल स्टेथोस्कोप है और ये बता रहा है कि जॉइंट के अंदर ये पिंक लाइन, जो बड़ी बड़ी पिंक लाइंस हैं, वो ये बता रहा है कि अंदर कुछ हिल रहा है भाई। वो डिस्क हिल रही है ना, हिलनी नहीं चाहिए, है ना? तो देखिए जैसे ही हमने वो ऑक्लूजल फोर्सेस ठीक किए, देखिए वो एकदम से नीट एंड क्लीन हो गया। तो इट इज ऑब्जेक्टिव डाटा, नॉट सब्जेक्टिव डाटा। डू आई मेक सम सेंस? यस, जोर से। ये पेशेंट 20 मिनट की प्लॉटिंग होती है। पेशेंट को 20 मिनट तक खड़ा करते हैं और ये उसकी बॉडी मूवमेंट है। 20 मिनट के अंदर में सीधा खड़ा होने पे रेड लाइन बिफोर द ट्रीटमेंट है और ब्लू लाइन आफ्टर द ट्रीटमेंट है। तो पूरी बॉडी अलाइनमेंट में आ जाती है, पूरी स्पाइन अलाइनमेंट में आ जाती है। दिस इज कॉल्ड एज रिस्ट स्टीरियोग्राफी। आपको जरूरत नहीं है, मैं थोड़ा सा रिसर्च बेस्ड रहता हूँ तो मैं खरीद लेता हूँ, करीब 1.5 करोड़ की मशीन आती है, बट दिस इज व्हाट हैपेंस। So, neuromuscular dentistry, simply speaking, means balancing the nerves, muscles and teeth to correct the head position, technically speaking, creating a harmonious state of minimal stress between teeth, muscles and the temporomandibular joint. This is what neuromuscular dentistry is. You know? So, pains that it solves, right from all the pains, ENT problems, GIT and kidney infections, gynecological problems, psychiatric, sinus related, and 57 approximately more diseases, multiple sclerosis, Parkinson's, सब ब्लड सप्लाई के इश्यूज हैं। और ब्लड सप्लाई तो उसके नीचे जा रही है, जॉइंट को टच करती हुई जा रही है। हमारा फील्ड है, वो लेके बैठे हैं, उनसे होता तो है नहीं, लिख देते हैं क्लियरली कि भाई हमें कारण नहीं मालूम है, उथे लिख दिए, डेफिनेशंस के ऊपर में बड़ा कुछ लिख दिया, ट्रीटमेंट होती नहीं, 2-4 गिनी गिनी टेबलेट्स हैं, उससे कहाँ क्योर होता है उनसे, है ना? ओके, ये ऐसे बहुत सारे केसेस हैं। आई एम नॉट गोइंग टू गो इनटू द केसेस, आई एम गोइंग टू बिल्ड अप द कॉन्सेप्ट फॉर यू टुडे so that you are able to start doing something in your clinics the moment you go back. मेरा नंबर है, मैं तभी जवाब दूंगा जब अगर गुड रिस्पॉन्स आया होगा, नहीं तो नहीं दूंगा। देख सबने किसने किसने किया है, दैट्स ऑल। अच्छे बाकी उन्होंने नहीं भेजा, भेजो भाई, नहीं तो मैं आगे बढ़ता ही नहीं। ओके, सो लेट्स गो टू द नेक्स्ट पार्ट। अब देखिए, ये च्यूइंग साइकिल है, मतलब हम ऐसे नहीं खाना खाते, हम जैसे ऐसे ऐसे ऐसे, और हर खाने के लिए अलग अलग तरीके से खाते हैं। फॉर एग्जाम्पल, ये चिकन का पीस है पेशेंट के मुंह में, और ये उसकी प्लॉटिंग है बाइट की, अगर फ्रंट से देख रहे हैं तो, ठीक है। ये च्युइंगम के साथ है, देखिए, है ना। और ये साइड, अगर आप ऊपर से देख रहे हैं, एक्सियल व्यू देख रहे हैं, तो ये साइड से देख रहे हैं, सजाइटल व्यू में देख रहे हैं तो ऐसे, ये कॉर्नल व्यू में देख रहे हैं आप तो ऐसे, ठीक है। ये च्युइंगम है, ये चिकन है, ये रोटी के साथ में है, ये चने के साथ में, ये मटन के साथ में, और अलग अलग पेशेंट में, ये दूसरे पेशेंट के अंदर में चने के साथ में। कितने दांत हैं उसके बेसिस पे, उसके फेस का स्ट्रक्चर कैसा है उसके बेसिस पे, हर एक की बाइट मैसिव फोर्स 1000 मेगापास्कल लेके, कोई इस एंगल से कोई उस एंगल से, या कदे इस फुलते थे कदे उस फुलते, दैट्स व्हाट इज हैपनिंग, राइट। क्लोज करती हैं मसल्स ऑफ मैस्टिकेशन, लैटरल टेरिगॉइड को छोड़ करके जो काम करती है, बाकी की एक्सकर्शन का काम करती है लैटरल टेरिगॉइड मसल। सो वील गो बैक ए लिटिल बिट। वो जो लैटरल टेरिगॉइड मसल है, वो यहां से स्टार्ट होती है और यहां जाके लगती है। सिंगिंग, स्पीकिंग एंड एक्सकर्सिव मूवमेंट्स, वेरियस एक्सकर्सिव मूवमेंट्स को वो करती है। और देखिए, नर्व्स के बीच में पड़ी हुई, अगर उसकी डिस्टोनिया हो जाए, मतलब फड़कना शुरू कर दे, तो क्या करेगी, और नर्व्स को डिस्टर्ब करेगी। Does that make some sense? So the dystonia of the lateral pterygoid causes all the diseases to enhance themselves. Can I get a glass of water, please? So अब ये जो अपर posterior teeth है ना, they are all the teeth are basically causing mesial migration, मगर जो सबसे forceful teeth हैं 7 और 8 upper, they are either straight or tilted slightly backwards, while the lowers are tilted slightly forward, which means what? जब mesial migration हो रही है भाई, तो उस वक्त पे वो बेचारे ऊपर वाले वहीं के वहीं रुक जाते हैं कंपैरेटिवली, रिलेटिवली, और नीचे वाले आगे बढ़ जाते हैं, है ना? तो जब ऐसा होना शुरू होगा तो क्या होगा? अब देखिए इस स्लाइड में, क्या पता आपको कि ये जो दांत है ये वाला, ये हो सकता है कि ये यहां होना चाहिए था अगर दोनों की माइग्रेशन बराबर होती तो, है ना? पॉसिबिलिटी है ना? यस नो मे बी, यस नो मे बी, ओके। तो ये जो दांत है, देखिए वो चिकन की मूवमेंट, वो मटन की मूवमेंट, वो चिकन की मूवमेंट में, will this tooth, will this surface of the lower tooth not contact this posterior surface of the upper tooth, particularly the super erupted part at abnormal contact points? जो उनकी posterior slope है upper की और lower की जो mesial slope है, क्या वो abnormal touches नहीं पैदा करेगी? और जब एबनॉर्मल टचेस जो आगे जाकर के लगने का काम है, उसका काम लेटरल टेरिगॉइड का है, और अगर वो एबनॉर्मल फोर्सेस लेगी तो वो डिस्टोनिया में जाएगी। तो मैं क्या करूंगा ऐसे पेशेंट को, जब पेन होगी, किसी भी पेन होगी, तो मैं इसके जरा सा जो इसका कांटेक्ट से नीचे का जो सरफेस है उसको जरा सा हल्का सा फिनिशिंग पर से ट्रिम कर, और देखते ही देखते विद इन ए फ्यू सेकेंड्स आपके सामने पेशेंट की पेन चली जाए। डू मेक सम सेंस? ओरोफेशियल हो, टेनाइटिस हो, नेक पेन हो, बैक पेन हो, शोल्डर पेन हो, नी पेन हो, नी पेन शायद एक आध दिन में चली जाएगी, बट आपके देखते देखते पेशेंट विल स्टार्ट सेइंग आई फील मच रिलीव्ड। देखिए same thing happening here. This slope and this slope, there is a possibility of an anterior touch taking place there, and it is impossible for you to see. Do I make some sense? यहाँ ठीक है सब, यहाँ ऐसा कोई एबनॉर्मल कांटेक्ट नहीं नजर आता। ये देखिए, ये देखिए लिंगुअल साइड पे, इफ यू हैव अ स्कैनर इट विल बी मच बेटर देन अ मॉडल, बिकॉज मॉडल्स एक तो ठीक से बैठते नहीं है, कहीं ना कहीं वो बबल होता है। ये देखिए, कैन यू सी दैट triggers the lateral pterygoid. ये डॉक्टर सुरभि माहिदर का है केस। अब एक बड़ा इंपॉर्टेंट एस्पेक्ट है सारी चीज का कि जब हम कॉन्डाइलर विड्थ को नापते हैं तो इस पे ज्यादा डेटा कहीं है नहीं, मगर जब कॉन्डाइलर विड्थ को मैं नापने बैठा और करीब 50 केसेस के अंदर में देखा मैंने, तो करीब 11 से 14 से 15 mm कॉन्डाइलर विड्थ होती है अमूमन मोस्ट पेशेंट्स के अंदर। मगर whenever I get a very serious disease patient, ये देखिए 20 mm, 19.9 mm and 19.9 and 15.9 on the other side. ये नॉर्मल पेशेंट है, ये देखिए 15.9 एंड 19.9, 20 mm. These are all very seriously diseased patients. Autism 20 mm, 21.8 mm. This ये publishing के लिए already गया हुआ article इसके ऊपर में काफी सारा so nerves के लिए compression हो गया ना, the ratio of the space between the infratemporal fossa and the condyle is further compromised. Such patients won't respond to your treatment of the lateral pterygoid dystonia जो मैंने अभी आपको glimpse दिखाया. तो इनके इस तरह के केसेस में भी सर्जन्स नीड टू सिट डाउन. हमारे देश में सिंपोजियम्स होते ही नहीं आजकल. पुराने ज़माने में सिंपोजियम्स होते थे जहाँ पे ट्रेनर्स बैठ करके एक दूसरे को गाली गलौज दे करके साइंस डिस्कस करते थे और दोस्ती रहती थी आखिर के अंदर में. आजकल क्या है, एवरीबडी जा करके बच्चे को सिखा रहा है, बच्चे को मालूम नहीं है उसको क्या सिखाना है. आप बात करिए, बहस करिए, आपस में बहस करिए ताकि पता तो लगे कि हम कैसे कंट्री. I've been trying lot of oral surgeons. Let's sit down and try to find out if this condyle is wide, what do we do about it? So can you open the other presentation? ड्राइव को कौन कंट्रोल कर रहा है? नहीं, वो इसके अंदर में एक और है. अब एक बड़ी बढ़िया चीज मैं आपको दिखाने वाला हूं कि पेरियोडोंटिस्ट है कोई यहाँ पे कि नहीं है. चले गए, मजा नहीं आया. बट आप लोग बडिंग साइंटिस्ट हैं आने वाले टाइम के, और ये इनका खत्म हो गया. अब आने वाली जनरेशन आप हैं. तो मैं यहाँ पे एक्चुअली एक बहुत स्ट्रॉन्ग स्टेटमेंट कहने वाला हूँ कि प्रोबेबली पेरियोडोंटल डिजीज डज नॉट एग्जिस्ट. और मैं 12 साल से चैलेंज थ्रो कर रहा हूँ उसके ऊपर में. I'm going to show you something which will blow your mind off. कि periodontal disease probably doesn't exist. और मैं एक ही स्लाइड से आपका माइंड ब्लो ऑफ करूंगा और चैलेंज करूंगा. मैं 12 साल से इंटरनेशनली चैलेंज थ्रो कर चुका हूँ फेसबुक पे, इतने सारे जितने पेरियोडोंटिस्ट को टैग कर चुका हूँ कि भाई एक एक्सरे दिखा दीजिए मेरे टर्म्स के हिसाब से और हम मान जाएंगे कि पेरियोडोंटल डिजीज एग्जिस्ट करता है. तो हाँ ये फिलहाल. So I'll come to the periodontal part in a few minutes. Before that, I'm going to build up the concept in your mind and then show you that thing. So ये आज ब्रक्सिज्म का भी क्योर सीख के जाइएगा, ठीक है? पता नहीं कितने कसीदे लिखे हुए ब्रक्सिज्म पे और हम परेशान हो जाते थे पढ़ते पढ़ते. इलाज किसी बीमारी का लिखते ही नहीं थे. देखिए कितना सिंपल और साधारण इलाज है, 5 मिनट में ब्रक्सर ठीक हो जाता है. ये पेशेंट आता है ना कितनी बारी पीडियाट्रिक्स के अंदर में कि मेरी बेटी जो है वो रात भर या मेरा बेटा रात भर दांत किटकिटाता रहता है और इतनी आवाज होती है कि वो आवाज जो है मतलब दूसरे कमरे तक सुनाई देती है. और पेरेंट कंसर्न होता है और डॉक्टर कहता है कि भाई पेट में कीड़े हैं. हमारी बर्किट जैसी ओरल मेडिसिन की बुक. So is this suggestion correct? Absolutely wrong. फिर डॉक्टर आए गो क्लिनिक, एडल्ट्स भी आते हैं कि मेरा सारा दिन दांत में किटकिटाता रहता हूँ. कई बार तो डाइवोर्सेस होने पे आ गए इस बात से. ट्रीटमेंट क्या है? कोई गार्ड, कोई नाइट गार्ड बोलता है, कोई सॉफ्ट गार्ड बोलता है, कोई साइकोलॉजी, अभी डॉक्टर साहब बोल रहे थे कोई सा साइकोलॉजिकल थेरेपी दीजिए, कोई लैटरल टेरिगॉइड ब्लॉक कहता है कि आप लोकल एनेस्थीसिया बुपिवा के इनका लॉन्ग एक्टिंग ब्लॉक दे दीजिए एंड व्हाट. बट भाई पूछो ब्रक्सिज्म और किसी मसल में तो नहीं होती बॉडी के, हम इस मसल को ऐसी क्या तकलीफ है बैठे बैठे? तो कोई जवाब नहीं. तो डॉक्टर आई हैव आंसर. सो देन देयर आर all these questions are also there which are answered by a common answer. ब्रशिंग से क्या लेना देना है इसका? ब्रश के अंदर में या टूथपेस्ट में इतनी ताकत नहीं कि इस तरह के गड्ढे कर दे, ना आपके हाथों की मसल्स में इतनी ताकत है किस तरह के गड्ढे. एट्रिशन कि जी आप फूड जो है ना बड़ा हार्ड खाते हैं. डायमंड हार्डनेस की चीज हमारे पास पड़ी हुई है, इससे ज्यादा क्या हार्ड खा लेंगे हम? क्यों होती है एट्रिशन, कोई जवाब नहीं है। दांत क्यों हिलते हैं, कोई जवाब नहीं है। पेरिडोंटल डिजीज है, व्हाट नॉट। लेट्स सी, लेट्स ट्राई टू फाइंड सम आंसर्स। Can you, I hope this works. देखिए बड़ा सिंपल सा आंसर है इन प्रॉब्लम्स का। Do click take lacking. Do click. Do click take lacking. अब ये ब्रक्सिंग का टॉपिक इंटरेस्टिंग है। ब्रक्सिंग do click take lacking. Do click take lacking. नहीं ये नहीं, do click take lacking. किसी और वीडियो से try hard. ऐप से do click. तो ये ब्रक्सर जो है, आप ब्रक्सिंग करके दिखाइए कि आवाज निकलती है कि दूसरे कमरे तक जाती है। आप ऐसा करिए कि बस मैं कान आपके बिल्कुल बिल्कुल वो आपके मुंह के पास ले आऊंगा, आप इतना करके दिखा दीजिए, ब्रक्सिंग करके दिखा दीजिए। ओनली अ ब्रक्सर कैन ब्रक्स, नॉन ब्रक्सर कैन नॉट ब्रक्स। क्यों क्यों? बोलिए बोलिए बोलिए। क्या टोनिसिटी की वजह से? अगर वो बेचारा सारी रात कर सकता है तो आप एक सेकंड के लिए तो टोन ला सकते हैं उसकी। आप ब्रक्सिंग कर सकते हैं क्या? कारण क्यों नहीं कर सकते? बोलिए ना, बड़ा इंटरेस्टिंग टॉपिक है, 5 मिनट में समझ में आ जाएगा आपको। है तो थोड़ा देर उसको याद दिला के कर दो भाई। अगर देखिए, अगर ये मेमोरी की वजह से बाहर रात को ऐसे ऐसे कर रहा है या दिन में, बाकी अगर मैं तो कॉन्शियसली भी कर सकता हूँ ना। आप ये कह रहे हैं इनवॉलेंटरी मसल मेमोरी है, वो एग्जीक्यूट हो रही है, तो फिर वॉलेंटरीली भी तो किया जा सकता है जो इनवॉलेंटरी करा जा रहा है। तो आपसे रिक्वेस्ट है, वॉलेंटरीली 1 सेकंड के लिए कर दीजिए, छोड़िए पूरी रात। नहीं कर सकते ना, तो देखिए क्यों नहीं कर सकते। इट्स वेरी सिंपल आंसर। अच्छा हम वापस एक बार इस पे शिफ्ट कर रहे थे, तो उसके बाद मुझे इस पे कंप्यूटर पे आना पड़ेगा, तो मैं आपको वो एक स्लाइड इसमें दिखा देता हूँ कि पेरिडोंटल वाली, ताकि फिर दोबारा ना आना पड़े। ये देखिए, ये क्या दिख रहा है इसमें? पेरिडोंटल डिजीज में कुछ कैरेक्टरिस्टिक दिख रहा है? कोई ऐसी चीज है जो आपको बड़ी अजीब लग रही हो इस पेरिडोंटल डिजीज के? क्रॉनिक पेरिडोंटल सुपरेटिव पेरिडोंटल डिजीज है ये। इस this is one of the most important slides if you want to understand how to make sure कि periodontal disease doesn't happen only. देखिए इसकी रूट की शक्ल देखिए, the tapering, the triangular, तो देख रहे हैं रूट्स की शक्ल देख रहे हैं, they are tapering and triangular. एक ओपीजी ऐसा दिखा दीजिए कि जहां रूट बल्बस हो, कर्व्ड हो और पेरिडोंटल डिजीज हो। मैं 12 साल से चैलेंज थ्रो कर रहा हूं, एक ओपीजी, मैंने 100 पब्लिश कर रखे हैं फेसबुक पे, आप एक दिखा दीजिए। रूट फॉर्म टेपरिंग जब होती है और ऐसा हिलाने वाला फोर्स जब आ जाता है तो हिलेगा, हड्डी गलेगी। तो हमारा काम क्या है? ऐसे आने वाले फोर्स को समय से आइडेंटिफाई कर लीजिए, हटा दीजिए, ऐसे पर्टिकुलरली जिसकी रूट फॉर्म ऐसी हो। होगा ही नहीं, पेरिडोंटल डिजीज हो ही नहीं सकता। कोई भी कॉक्स का प्रिंसिपल लागू नहीं होता पेरिडोंटल डिजीज में। वो कहते हैं ये इन्फेक्शन है, अरे बाबा आप एनिमल में नहीं प्रोड्यूस कर सकते, चलिए छोड़िए। आप अपने स्पाउस में नहीं प्रोड्यूस कर सकते पेरिडोंटल डिजीज, चलिए छोड़िए। आप इधर से इधर नहीं कर सकते, चलिए छोड़िए। आप जहां पे पेरिडोंटल डिजीज है, जहां पे सुपरेशन हो रही है, उसके आधा मिलीमीटर आगे करके दिखा दीजिए, इनोकुलेट करके। आप वहां भी नहीं कर सकते प्रोड्यूस, तो फिर किस बेसिस पे इन्फेक्शन कह रहे हैं? तो कहें मॉडिफाइड कॉक्स पोस्टुलेट्स, क्या कोई लेना देना नहीं। इट्स वेरी सिंपल, आप रूट फॉर्म दिखा दीजिए जिसके अंदर में कर्व्ड या बल्बस हो, और मैं डेंटिस्ट्री छोड़ने को तैयार। So now the last 2-3 slides on bruxism, if you get that, how to cure bruxism in like 5 minutes time. तो देखिए अब इसको चलाना। अब ये दांत कैसे रगड़ेगा बताइए?
क्लिक टिक लैकिंग, डू क्लिक टिक लैकिंग, डू क्लिक टिक लैकिंग, ट्राई हार्ड।
ये क्यों नहीं रगड़ पा रहा दांतों को, पीछे के दांतों को? कारण क्या है? आप जिसको पता है वो चुप रहे, जिसको नहीं पता वो बताए। फिर से चलाना। सोचो ना, आज घर जाकर के आप ब्रक्सिज्म को रोक पाओगे? फिर से चलाओ। ये दो महारथी जो हैं, लंबे वाले दांत जो हैं, कैनाइन जो हैं, ये बाकियों को मिलने नहीं दे रहे।
ट्राई हार्ड।
देख रहे हैं, देख रहे हैं? अब इनको घिस देते हैं, देखिए क्या होता है। नेक्स्ट, अब देखिए इनको घिस देते हैं, या इनको निकाल दीजिए, या इनको थोड़ा आगे पीछे कर दीजिए, फिर देखिए क्या होगा।
क्लिक टिक लैकिंग, जोर जोर से आवाज आएगी।
अब सब रगड़ खाएंगे।
अब जोर जोर से आवाज आएगी।
इट्स वेरी सिंपल। 90% पेशेंट्स में आप कैनाइन बिल्डअप करेंगे, हाथ के हाथ पेशेंट ठीक हो जाए। Do I make some sense? Uh, So the saviors are well-placed canines. They act like checkpots. So ये लंबी कहानी नहीं सुनाएंगे आपको, आपको बस खाली लास्ट उस पर ले जाते हैं। तो जब कैनाइन्स और एंटीरियर टीथ गलत जगह पे होते हैं तो रगड़ने का फोर्स आ जाता, एग्जीक्यूट हो पाता है, और जब वो हो पाता है ऐसा रगड़ने का फोर्स, तो अगर दांत सॉफ्ट मटेरियल का होगा तो घिस जाएगा। कंडीशन इसलिए होती है, डायमंड से डायमंड रगड़ खा रहा है ना, तो घिसेगा, है ना। और अगर हार्ड मटेरियल का होगा और ऐसा रगड़ने का फोर्स आएगा, मतलब एंटीरियर टीथ नहीं अगर होंगे या गलत जगह पे होंगे, तो दांतों में रगड़ की पॉसिबिलिटी होती है, और वो रगड़ अगर आएगी हार्ड मटेरियल होगा तो दांत बेंड कर जाएगा, और बेंड करने की वजह से यहाँ पे एब फ्रैक्शन कहते हैं, टूथ ब्रश एब्रेशन ही कहते हैं। क्लियर? अब अगर बूटी छोटी हो, टेपरिंग है ना जो अभी दिखाया था एक्सरे, और ऐसा फोर्स आएगा तो हिल जाएगा, क्योंकि हड्डी दूर हो जाएगी, हट जाएगी। ऐसा ऐसा जोर लगाएगा, ऑर्थोडोंटिकली भी तो करते हैं तो हड्डी गलती है ना, तो ऐसे ऐसे करने से हड्डी गल जाएगी। मेक सम सेंस? ठीक है। तो ये अगर पेशेंट ऐसा वाला आएगा और वो पूछेगा कि मेरी मेरी बेटी या मेरा बेटा सारी रात दांत किटकिटाता है, तो क्या बोलोगे? 13 साल तक वेट कीजिए, कैनाइन्स आ जाएंगे, उसके बाद ठीक है ना। स्ट्रेस है, साइकोलॉजिकल स्ट्रेस है, बच्चों को ऐसे करिए वो करिए। नाउ द लास्ट 1 minute, 2 minutes I want to talk about something called as prevention of all these diseases. How can you prevent? There are 3 main reasons for all these problems to happen. 1, lack of nesting in humans. Lack of nesting in humans. वो दूसरी वाली प्रेजेंटेशन खोल दीजिएगा प्लीज, जो पहले खुली हुई थी। लैक ऑफ नेस्टिंग, जितने भी बाकी के जानवर पक्षी हैं उनको नेस्ट की जरूरत पड़ती है, उसमें 2, 3, 4, 5 बच्चे होते हैं, है ना। तो वो एक दूसरे के ऊपर चढ़ 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 खेल 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 एक दूसरे को इम्यूनिटी पास करते हैं, थक जाते हैं, थक के सोने चले जाते हैं, राइट। लेकिन ह्यूमन बींग्स में एक बच्चा पैदा होता है। पुराने ज़माने में पड़ोसियों के बच्चे आ जाते थे, मामा चाचा ज्वाइंट फैमिलीज होती थी, उनके बच्चे होते थे, तो बच्चे कभी किसी के साथ खेल रहे हैं, कभी किसी के साथ खेल रहे हैं। आजकल क्या है, माँ बाप अकेले रहना चाहते हैं तो बच्चे के हाथ में आईफोन पकड़ा देते हैं, आईपैड पकड़ा देते हैं। देयर इज नो फिजिकल टायर्डनेस, द ग्रेटिफिकेशन इज नॉट देयर, सो द चाइल्ड टेंड्स टू डू द थंब सकिंग। अगर वो थक जाएगा तो आधे मिनट से ज़्यादा थंब सकिंग नहीं करेगा और छोड़ देगा। सेकेंड मेन रीजन, द फ्लोरिंग। पुराने ज़माने में फ्लोरिंग नहीं होती थी आम घरों के अंदर में, तो बच्चे जब गिरते थे तो छिन के बल गिरते हैं, और जब गिरते थे तो वो मिट्टी के ग्राउंड्स पे गिरते थे या सैंड पे गिरते थे, which used to be soft, घास पे गिरते थे। तो ये इंजरी टेम्पोरल मैंडिबुलर जॉइंट को टिल्ट अंदर की तरफ नहीं करती थी। आजकल के बच्चे जो गिरते हैं वो फ्लोर पे गिरते हैं, और गिरते ही गिरते हैं, और वो इंजरी से उनके जॉइंट पे ग्रीन स्टिक फ्रैक्चर होता है, और वो टिल्ट कर जाता है अंदर की तरफ, और अंदर आपको पता है क्या है, पूरा का पूरा सर्किट पड़ा है बॉडी का। सो 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 रिमेंबर, दीज आर द 3 थिंग्स: लैक ऑफ नेस्टिंग, lack of nesting and the flooring. Okay, so I hope I was useful. बहुत ज़्यादा भीड़ थी। हो सकता है मेरी बात ना पहुंची, हो सकता है। सो थैंक यू वेरी मच। अब जो बचे हैं जिंदा यहाँ पे थोड़े से, तो एक अच्छा सा कमेंट डाल दो मेरे व्हाट्सएप पे, मैं भी जाके दिखाऊंगा उनको। कुछ अगर अच्छा लगा हो तो एक कमेंट भेज दो, ठीक है।
Thank you so much, Dr. Sanjay Arora, sir, for the wonderful lecture on learn curing TMG, TMJD headaches in less than 5 minutes research aspects. It was indeed a very wonderful and guiding lecture. Thank you so much, sir. Sir, there is a query. Sir, can you come forward? I'll give you the mic, sir.
मिनट में ठीक हो जाता है। हाँ, अब बिना उसकी जरूरत नहीं पड़ती मेडिसिन। दूसरे पर्सपेक्टिव के लिए डॉक्टर साहब थोड़ा माइंड को तो खोलना पड़ेगा ना। और क्या मैं बताऊं, आपने कहा कि मैं बिलीव नहीं करता हूं, तो मैं तो कह रहा हूं कि बिलीव कर। हाँ, हाँ, कैसे पता? ये क्योंकि ये मैंने टेक्निक ही मैंने 15 दिन पहले 4 महीने पहले अनाउंस करी है वाली। हाँ, ये जो टेक्निक है, श्योर श्योर, मैं इंडियन जर्नल्स में पब्लिश करता हूँ यार। मेरे इंडियन जर्नल में फैमडेंट में ऑलमोस्ट मंथली बेसिस पे आता है। और इट्स अ वेरी सिंपल थिंग कि आप मेरे सबसे पहले तो वेबसाइट पे पेशेंट्स के डिटेल्स हैं, उसमें से एक तो डेंटिस्ट ही हैं मौलाना आजाद की, उनकी मदर करीब करीब 15 साल से इन मेडिसिन पे थी, 1200 मिलीग्राम। हाँ, आप थे क्या? आप वही देर इन द लेक्चर? नहीं पूरा, मैं आपको बुलाया 2-3 बारी तो आप मुझे नजर ही नहीं आए। डॉक्टर साहब अगर यहाँ पे थोड़े से लोग हैं, आइए मैं आपको 1 मिनट ग्लिम्स देता हूँ, देखिए। हाँ हाँ श्योरली, अभी देखो मैं तुम्हारे को दिखाता हूँ।
features.
तो ये जो 5 मिनट वाले केसेस है ना, वो मैं आपको मैं पहले तो करता था, जो करता था वो 10-10 घंटे वाले होते थे. इट यूज टू टेक 10 आवर्स. बट पिछले 7 सालों में आई स्टार्टेड डूइंग दिस टेक्निक. बट अब मैं रिलीजियसली पिछले 4 महीने से ये टेक्निक कर रहा हूँ. और डॉक्टर वेणुगोपाल, फॉर्मर डायरेक्टर ऑफ ऑल इंडिया इंस्टीट्यूट ऑफ मेडिकल साइंसेज ने 55 केसेस को स्क्रीन करने के बाद ही डिसाइडेड टू कम ऑन टेलीविजन and appeal to the government of India that please we should do research on this topic. और बड़े कड़क इंसान हैं वो ऐसे प्यार से नहीं आ जाते किसी के भी कहने से. मतलब गहरी दोस्ती हो तो भी नहीं आते. ये देखिए, अब आप देखिए, आपको मैं जो, और इन सब पेशेंट से आप मिल सकते हैं, आकर के इनका रिकॉर्ड्स चेक कर सकते हैं. कंसेप्ट मैंने समझाया ना, जो लैटरल टेरिकॉइड में जो डिस्टोनिया है, देखिए मैंने बताया तो था, मिस कर दिया वो वाला स्लाइड. दोबारा से दिखाता हूँ. देखो, ये देखो, एक मिनट, ये देखो, एक मिनट देखो, ये देखो, didn't I show you 4 slides की कौन सा टीथ को ग्राइंड करने से इमीडिएटली रिजल्ट्स आते हैं. ये डॉक्टर एक सुरभि माहिदर का केस भी दिखाया था. 2 मैंने अपने, अच्छा अच्छा अच्छा, है जब एंटीरियर मीडियली ट्रैवल करेगी तो इसको बार बार छेड़ेगी. वो क्या करते हैं, जो आप सर्जिकल करते हैं, वो पल्सेटिंग आर्टरी को के बीच में और ट्राइजेमिनल नर्व के बीच में एक फैट की लेयर डाल देते हैं या कोलेजन की लेयर डाल देते हैं. द रिजल्ट इज इंस्टेंटेनियस. उनका भी तो रिजल्ट इंस्टेंटेनियस है ना डॉक्टर साहब. सर्जिकली तो ऐसे ही करते हैं ना.
Sir, but surgery will also take a long time, will not take 5 minutes, sir. Plus, sir, we are putting lot of efforts.
देखिए, बड़ा अच्छा आपने
We
पॉइंट
people,
कहा.
आप sir endodontist हैं, but as oral medicine specialist,
हाँ,
we
हाँ.
people put in a lot of efforts to treat our nerve वाले patients, specifically trigeminal neuralgia patients. And sir, trust us that with all the efforts, with all the research,
साहब.
with everything, with performing all type of best treatments, it is very clear that this is treatable. It is medicinally also
अच्छा,
treatable.
सुनिए ना.
But it takes time, sir.
आपकी बात मान के अब एक बड़ी इंटरेस्टिंग
Even
कहानी
God
सुनाता हूं.
cannot do something like
सुनिए ना
5
डॉक्टर.
minutes में he cannot cure of these pains,
सुनिए
sir.
तो सही डॉक्टर साहब, सुन तो लीजिए, क्योंकि आज मेरे से लेके जा सकते हैं आप अगर चाहें तो, ठीक है ना. और मैं आपकी बात मान जाऊंगा तो मुझे तो फर्क नहीं पड़ेगा, मैं तो रोज ठीक
Sir,
कर रहा हूं.
आपको मानना ही नहीं है, हम मानने
एक
के
मिनट
लिए नहीं
सुनिए
कह
तो
रहे,
सही,
it's just our
आपसे
point.
रिक्वेस्ट है. एक
This is
सुनिए,
what we think, sir.
सुन लीजिए ना. एक आदमी घर जाता था तो उसकी पिटाई होती थी, उसकी बीवी पिटाई करती थी क्योंकि दारू पी के जाता था खूब सारी. तो एक दिन किसी ने साइकेट्रिस्ट ने समझाया बीवी को. बीवी कहने लगी कि मैं तंग आ गई. तो कोई तुम उसको सज धज के बड़े प्यार से रिस्पेक्टफुली ट्रीट करो, वो दारू छोड़ देगा। बोले ठीक है। तो वो आया जब दारू पी करके, तो वाइफ वाज टोटली अ डिफरेंट ह्यूमन बीइंग एंड दिस गाय सेड गलत घर आ गया। सो ही वेंट, बाहर ही पड़ा रहा, बोला मेरे को मेरा घर नहीं मिल रहा। तो फिर लोगों ने क्या किया कि उसको एक बैलगाड़ी पे बिठाया, 2-4 चक्कर खिलवाए और वापस उसी जगह पे लेकर के आए। बीवी को तब तक बोला चेंज हो जाए वैसी जैसी थी, बोला घर आ गया बेटा। यू मेड अ कमेंट डॉक्टर साहब, आपने कहा कि सर्जरी में टाइम बड़ा लग जाता है। हम बात कर रहे हैं सर्जरी में का क्या मतलब है? रास्ता कितना भी 4 गली घूम फिर के कहीं से भी जाएं, जब हम वहां पहुंचते हैं,
सर
जब
आई
हम-
थिंक ये
एक
क्वेश्चन
मिनट,
आप समझ ही नहीं रहे हैं, तो लेट अस नॉट डिस्कस। ये डिस्कशन आर्गुमेंट में बदलता है, दैट इज नॉट वर्थ इट सर। कॉन्फ्रेंस इज जस्ट
मैं
टू
समझ
लर्न
पा
एंड
रहा हूँ कि क्या
अंडरस्टैंड,
कहने,
है ना सर?
am I able to understand what he is saying? वो अल्टीमेटली तो डालना तो उन्होंने जरा सा फैट टिश्यू में कितनी देर लगेगी डॉक्टर साहब? 5 मिनट ही लगेंगे ना।
राइट सर, बिल्कुल।
तो मैं भी तो
सर
नर्व
तो
से
आप
प्रेशर,
अपने क्लिनिक पे सर्जरी करते हैं?
नहीं प्रेशर हटा रहा हूँ।
वही, दैट्स व्हाट आई एम टॉकिंग सर।
हाँ।
यही तो मैं आपसे बात कर रहा हूँ कि आप अपने क्लिनिक पे यू आर नॉट, आप ये सब सर्जरी करके एकदम से ठीक नहीं करते हैं ना। दैट इज व्हाट द क्वेश्चन
डॉक्टर साहब, मैं आपके उस कमेंट की
वांट टू
बात कर रहा
लर्न
हूँ।
दैट व्हाट इज द ट्रिक, टिप्स एंड आर्ट ऑफ ट्रीटिंग अ ट्राइजेमिनल न्यूरैल्जिया पेशेंट्स। आपने बोला मेरे 15 पेशेंट्स ट्रीट करें, जस्ट 5 मिनट में रिलीफ हो गए।
मैंने ये नहीं कहा, फिर से सुनिए।
आपके लेक्चर में
मैं फिर से
quoted
बताता हूँ,
term था,
फिर से
इसलिए
बताता
हमने क्वेश्चन पूछा है।
मैं फिर से बताता हूँ। मैं 20 घंटे लेता था ट्रीटमेंट करने के लिए, पिछले 17 साल से कर रहा हूँ। 20 घंटे से 100 घंटे का ट्रीटमेंट होता है। जितना बूढ़ा पेशेंट होता है 300 घंटे का भी ट्रीटमेंट होता है। बट पिछले 7 साल से समथिंग स्ट्रक माई माइंड एंड आई स्टार्टेड डूइंग अ पार्ट ऑफ द ट्रीटमेंट डिफरेंटली एंड आई स्टार्टेड गेटिंग समटाइम्स रिजल्ट्स विद इन 5 मिनट्स टाइम। Now for the last 3 months, for the trigeminal, for the temporomandibular joint pain, I am doing it consistently, giving priority to this treatment. Now, should it work on trigeminal neuralgia? For sure. Have I done trigeminal neuralgia with this particular technique? No. कर तो वही रहा हूं कि लैटरल डिस्टोनिया हटा रहा हूं। पहले हटाता था पूरे क्राउन दे करके, पहले हटाता था गाइडेंसेस चेंज करके, अब कर रहा हूं खाली इस तरीके से। तो क्योंकि कर मैं लैटरल टेरिगॉइड का डिस्टोनिया ही दूर कर रहा हूं, जो कि ट्राइजेमिनल नर्व को टच करती हुई जा रही है, तो वही रिजल्ट आना चाहिए। अब जब आएगा पेशेंट तब कर सकता हूँ।
राइट।
अच्छा ना, ठीक है ना। तो बेसिक मेरा गोल क्या है? लैटरल टेरिगॉइड का डिस्टोनिया ठीक करना। Make sense? अब एक छोटी सी चीज सुन के जाइए, ये बड़ी इंटरेस्टिंग लगेगी आपको, अगर ये इनका कंप्यूटर काम कर गया तो। और हम बिलीव नहीं करते हैं ऐसे जगह कि चलिए लेट्स डू ए जॉइंट रिसर्च ऑन दिस थिंग। हम इकट्ठे मिलके कुछ पेशेंट्स को करके देखते हैं। ये देखिए, सुनिए। इसमें आएगी आवाज? इसमें तो आ रही है, लेकिन वॉल्यूम आएगा इसमें? तो फॉर सम रीजन ये प्ले नहीं हो रही हैं, मगर मेरे पास में बहुत सारे वो हैं। अब ये देखिए, ये तो कोई और डॉक्टर हैं, सेम चीज उन्होंने करी जो जैसे बताई, और देखिए उनको रिजल्ट आया है ना। तो और ये भी मेरे ख्याल से लीडिंग प्रोस्थोडोंटिस्ट हैं इंडिया के, है ना। डॉक्टर हाँ, आपके ओरल मेडिसिन के डॉक्टर शार जो हैं, वो इस टेक्निक की बड़ी तारीफ कर चुके बॉम्बे में, है ना। और कम से कम 6 ओरल मेडिसिन वाले मेरे ग्रुप के अंदर में जो लीडिंग ओरल मेडिसिन के लोग हैं, दे एग्री टू दीज थिंग्स। और आपको है, इट्स अ गुड थिंग, यू हैव दैट थिंग इन यू। आप आइए ना, लेट्स नॉट ओनली डिस्कस, गो थ्रू दैट। और हम पेशेंट्स पे भी देखेंगे। आपके पास पेशेंट है, मैं आता हूँ, मेरे पास पेशेंट है, आपको बुला लेता हूँ, आइए देखिए, लेट्स क्योर द पेशेंट। हाँ, वो कह रहा बिली, हाँ, श्योर श्योर श्योर। और ये अगर आप इनकी साउंड बाइट सुन पाते हैं पेशेंट्स की, यू वुड हैव बीन सरप्राइज्ड। बाकी सारी आ रही है, पता नहीं क्यों नहीं आ रही है। नहीं, ये तो क्योंकि अच्छा, ओ साउंड फाइल, हाँ, ऑलराइट।
So anyway, thank you very much. I hope.
Three chairs for our
Thank you so much once again, sir, Dr. Sanjay Arora, sir. We'll proceed to the next lecture now. The next lecture is by Dr. Achint Juneja, sir, and he is going to speak about 10 commandments of smile aesthetics. But before we move on to the lecture, I'll give a brief intro of sir. Dr. Achint Juneja, sir, is currently working as Vice Principal and the Head of Department of Orthodontics and Dentofacial Orthopedics at Institute of Dental Studies and Technologies. He did his BDS and MDS from ITS, CDSR, and with an academic experience of more than 10 years. He has numerous clinical and academic achievements to his credit. He is an active member of Indian Orthodontic Society and Fellow of Pierre Foucault Academy. Dr. Juneja has a keen eye towards technological advancements in clinical practice and has advocated them for a betterment of the students. His strong basic knowledge of the subject, amalgamated with his keen interest in the world of orthodontic innovation, makes him a proficient teacher. Added to all this, his great interpersonal skills and kindness make him an approachable guide to all his students. We welcome you to the stage, sir, and we eagerly wait for your lecture. Please welcome, sir, with a round of applause.
Thank you very much. Thanks, Anam, for the introduction. So, I think we are hardly having any. So the topic today which I choose is 10 commandments of smile aesthetics. I think this is a topic we can consider it for all the practitioners, like be it endodontist, periodontist, or the undergraduate students as well as the general dentist. So the topic is regarding the aesthetics. So when we are talking about aesthetics, there are so many branches we deal with, like endodontics, periodontics, prosthodontics, when we are talking about rehabilitation. So the basic thing which we always concentrate or focus is the aesthetics. So why should smile be assessed? So Dale Carnegie said that one of the most important way to win friends and the people is to smile. So he's a American literature author, and he was also he conducted so many courses also regarding this. So he concluded that it is very, very important when you are dealing with other people. So smile plays an important role. Likewise, another scientist, Alfred Lurbus, he also said that whenever we are doing any kind of personal interactions and all, so attention is primarily given to the mouth and the smile. So smile is our business card. So how should smile be assessed? So we can assess smile by doing a clinical examination, photographic examination, and a videography. So all these things we routinely do in the private practice as well as when we are taking records and all. So clinical examination, definitely we check for the smile arc, buccal corridor, gingival exposure, diastemas, midline shifts, all these things we take into consideration. So when we are evaluating all these things, we take some photographs, right? And sometimes when we are taking a photographs, it is, it is very difficult to bring the patient into that kind of pose which we want. So there is another concept that is videographic method. So in that, we ask the patient to sit in front of a camera and we take some frames. So those selective frames we captured, and then a smile can be assessed with that. So like in this, you can see that a patient is speaking, smiling, and in between that videography, we can capture a certain frame so that we can analyze the smile. Now, according to Rubin, there are 3 levels of smile, or 3 patterns. That is a commissure or a Mona Lisa smile, when you see there is no tooth exposure, only the corner of the mouth is slightly raised, basically that zygomatic muscle slight, and then um, uh, it gives a cupid bow kind of thing. So that is a commissure smile or a Mona Lisa smile. When there is an increased muscular activity, then we get this social and the cuspid smile. And then when there is along with the elevation of the upper lip, there is a depression of the lower lip, then we have a complex smile. So what should be assessed when we are talking about the smile? So there are 10 commandments, that is the principles that should be considered when we are analyzing and when we are planning a treatment. So these 10 concepts are, in a particular order that should be considered when we are planning a treatment for a patient, be it an orthodontic treatment, a prosthodontic treatment, endodontic treatment. So whatever it is, but these things should be considered. So coming to the first commandment, that is a smile arc. Smile arc is basically an incisal contour of the anterior teeth in relation to the contour of the lower lip. So whenever we are smiling, so the upper teeth edges should follow the lower lip contour. So the first commandment said that the ideal vertical positioning of the maxillary incisor at smiling is the first step to be planned. So that is the first thing you should consider. So whenever we are seeing a patient, we should focus on the smile part, and that too the arc. So if you see this patient, the teeth are normal, there is no cavity, the shape and everything is looking normal, there is a gingival display a bit. But when we are talking about the smile arc, so that smile arc is missing. It is not following the contour of the lower lip. So whenever these patients we treat, so we try to get into a pattern in which the upper incisal edges from the anterior social 6 should follow the lower lip. So whenever we are talking about the smile arc, it can be a curved arc, right, following the lower lip. It can be a plain or a straight, which is absolutely straight. The incisal edges are absolutely level. Whenever we see some patients normally and we take some records, because sometimes what happens when we are trying to assess a patient, we take a cast and we see that all the teeth are aligned, and we say that this is okay, this is very good, this is beautiful. But no, the arc should be seen, and that can only be evaluated when we are taking some smile photographs. So a flat arc, which is it is not contouring to the lower lip, but it is a straight, all the teeth are in at straight level. And then there is a inverted or reverse when the arch is not contouring with the lower lip. So the more the arc the incisor contour the anterior posterior teeth, the younger the smile looks. Whereas the more the flat, the older it looks. So whenever we are planning any kind of treatment for a young adults, young patients, so we should always consider this thing. So now these are important findings when we are planning. So that is the aesthetic restoration. We are doing any complete denture fabrication. So if you are giving a more arc kind of thing to a patient in a denture cases, so that is not advisable, because it will not match to the age of the patient. So definitely when we are doing an orthodontic treatment, I'm an orthodontist, so I'll be talking little more, little bit biased about this topic towards the orthodontic treatment. So whenever we are planning any kind of orthodontic treatment, we always consider this, how we are going to move the incisors. So sometimes, when a patient is having a deep bite, definitely we are trying to intrude the anteriors. But in cases of open bite, so we have to see how much the exposure and how the arch is contoured. So vertical position of the incisor should be considered when we are planning to move these teeth. So when we are planning, so when we want to have a contour which is following the lower lip, so there is a little, the positioning of the incisors and the canine should be considered. That is, the incisors, centrals and the lateral should be 0.5 mm little up to the incisors, and the same level or a little 0.5 mm up of the canine. So there should be a step ladder kind of thing, so that the smile is little contoured as per the lower lip. So convex smiles are more suitable for the women, whereas the convex or a flat arcs are little acceptable for the males. So when we talk about the summary of this first commandment, they are the vertical positioning we have to see, incisal edges of the maxillary central incisors and the lateral incisors, and there should be a step between the central, lateral and the canine. The second commandments, so it is basically regarding the ratio and the symmetry of the central incisor. So ratio means when we are talking about a particular tooth, particular incisor, so the width and the height ratio of that incisor. So whenever we are doing some kind of aesthetic restoration, we are planning prosthetic rehabilitation and all, so that height and the width ratio should always be considered. So we should measure the width and the height. Suppose we are doing for one incisor and we are replacing one incisor, the other incisor is there, so we should consider that symmetry as well as the ratios. So it should not be like a incisor is little squarish in shapes and it is more wider as compared to the height. So that should be taken care of. 75% to 85% ratios are considered more aesthetics. So values towards 75% will have a longer pattern widely accepted for females. Females, we can keep it little longer. And whereas the values towards 85%, central incisor will have a wider pattern and accepted by males. So ideal ratios between 75 to 85%, right? And if it is less than 75%, then we'll be having little, longer teeth. And if it is less than 80, it is more than 85%, so we have a wider teeth. So sometimes, we have a little altered width to horizontal ratio, height ratio, and also sometimes we suppose a case comes to us and there is a missing both the central incisor. So there are some formulas regarding that by Berries and all. So what you can do is you can measure a bizygomatic width and you can divide it by 16, so you'll get the ideal width of the central incisor. The same way height can be measured with the height of the face, you can divide by 16 and you can get a ideal height of that particular incisor. So if there is an altered ratio, the first step is to determine whether one of the central incisor has a proper ratio or not. Accordingly, we can plan for the other one. Few situations like both the central incisors are missing, so we can utilize that formula. Aesthetic central incisors usually have a 9.5 to 11 mm of the height in the crowns. So the demand for symmetry between the central incisor is based on the clinical assumptions, that is nearer the midline, the greater is the need for the symmetry. Farther from the midline, the higher the number of slight asymmetrics are clinically acceptable. So when we are planning, so if we are planning something for the central incisor, it is more critical as compared to the lateral incisor. Any discrepancy in the central incisor between the ratios can be easily perceived by the layman as compared to the laterals and the canines. So a slight 0.5 mm of the maxillary central incisor asymmetry is identified as anesthetic and by orthodontist and the layman. On the other hand, slight asymmetries on the side of the incisors, like that is the canine and the lateral incisor, may go unnoticed. So if we see, so if we are talking about the central incisor, it is 0.5 mm acceptable. For the lateral, it is 1, and for the canine, it is further 2 mm of any discrepancy between the height and the width ratios can be acceptable. So the summary for the second commandment is take a note on the width and the height, aesthetic proportion, that is 75 to 85%, and symmetry between the incisal edges is the most important aspect. Then comes to the third commandment, that is the proportion between the anterior superior teeth. Now the proportions are, there are so many proportions like golden proportion, red proportion. So what is this? This is what we see, when a patient is smiling, we see it from the front. That is how the lateral incisor, how much proportion of the lateral incisor is visible as per to the central incisor, and likewise the canine. So when we are planning, so the golden proportion says that 62% of the central incisor should be the visibility of the lateral incisor, and likewise 62% further of the canine. But sometimes, you know, these are little unacceptable, because if we talk about this, if we do in this manner, so sometimes almost the 50% of the zone, that is from the canine and canine to canine, will be occupied by the central incisor only. So recently published research compared several different proportions, like from 57%, 67%, 70%, and 72. The result revealed the greater proportion, that is 67 and the 70%, have been highlighted as being more aesthetic, thereby revealing that there seems to exist a strong preference for wider instead of narrower incisors. So asymmetrical proportion between the anterior posterior teeth, as you can see. So we can prepare a grid kind of thing, and on the photographs, or we can do an analysis on the photographs, so that we can see that which particular tooth is not falling into a proportion, and we can have a little, you know, we can do some cosmetic buildups and all for that particular tooth, and it can be corrected. So too narrow lateral incisor are anesthetic. We know that there are sometimes there are pag laterals and all, so we need to keep in mind that how much, you know, in some cases we do in direct bonding, in some case direct veneers, in some cases we do, you know, the crowns and all. So that should be considered. Like in our cases, when we are treating these kind of cases with peg laterals. So what we do is we generally create a space for the crown, which is to be placed at the end. Suppose there is a unilateral peg lateral, so we take, you know, the other lateral incisor into consideration, and the smile pattern, whether that lateral incisor is in a proper proportion or not, and likewise we create space for the lateral incisor, which is a peg lateral, so that a proper restoration can be done on that. The fourth commandment is the presence of anterior superior spaces. Definitely, whenever there are some spaces that needs to be closed, right? But according to the literature, small midline diastemas not greater than 2 mm might go unnoticed by layman. This finding may somehow explain why some famous artists, we in a normal scenario we see that there are some celebrities and all having a midline diastema. So they are, you know, they are not so much noticeable. So anything which is, you know, midline diastema up to 2 mm can be are usually acceptable, and they remain unnoticed, right? Although aesthetics are highly subjective, the fourth commandment asserts that all midline diastema must be closed either by orthodontic or multidisciplinary treatment. So orthodontics is correct if we are, you know, closing a midline diastema, we are moving the teeth together and we are closing it. There are a lot of consideration to be done, like deep bite and all. We just need to clear the bites and everything. But sometimes, you know, a dentist usually they prefer or they advise us to patient that okay, these can be covered with the aesthetic restoration. But then your second commandment and third commandment should be followed, so that whenever you are doing something, a direct composite or a restoration, you should not alter the width, you should not alter the ratios. So that is very, very important. So midline diastema can be seen and it can be closed by any of the methods until unless we are not encroaching to the second and the third commandment. So the greater the diastema, the near the midline, the more anesthetic the smile is. The only exception is for 0.5 mm diastema in the distal surface of lateral incisor, which are not identified by the layman. So whenever we are seeing a smile, so whenever we have a diastema distal to the lateral incisor, sometimes it is, you know, unnoticed by the layman. So the summary for the fourth commandment is the diastemas in the hibernate. Anyone can come from the control room to see this. from fifth command onwards, now it comes the role of, what we call that red zone or a pink zone. So the term pink aesthetics and the rest aesthetics have been used to describe ideal gingival contour at smiling. So some dental textbooks recommend that canine gingival margin must coincide with the central incisor gingival margin, whereas lateral incisor gingival margin must be slightly below this line. So whenever we do a teeth setting also, what we do is we try to keep the gingival margin of the canine and the central incisor at the same level, and the lateral is slightly 0.5 mm below that level. So whenever we are trying to do that, what happens that we usually get a flat smile when we are just trying to level the marginal gingival level of the canine and the central incisor. So we usually get a flat smile kind of this. So canines and central incisor are equal in length, and the central and the incisors incisal edge at the same level above the above the canine will lead to a flat smile, or sometimes an inverted smile also. Now which aesthetic parameter is important? Because in the starting we talked about in the first commandment that it should follow the contour as of the lower lip. So now if you are trying to follow it, and as I told you that the central incisor should be 0.5 mm to 1 mm below the incisal edge of the lateral, and the canine should be at the level of the lateral incisor or 0.5 mm above the lateral incisor. So if we are doing like this, so and the same time if we are trying to level the marginal gingivas, so these two things are contradicting. So which thing should be followed? There have been researches in which they have established a relationship between the aesthetic perception and the incisal edge smile line, as well as the gingival marginal smile line. So there are two lines, that incisal edge and the gingival margin. So result revealed that incisal smile design is most important factor of dental aesthetics. So we should consider incisal smile line more as compared to the gingival line. Thus, in addition to what is recommended in the first commandment, one may opt for a modified gingival design in which the gingival margin of the central and the laterals are slightly below as compared to the canine, or the gingival margin of the central is below the canine and the gingival margin of the lateral is below the central incisor, but the canine and the central incisor gingival margin should not be at the same plane, right? So this is the classic one where the margins are at a same level, and the modified one where the margin of the canine is up as compared to the central and the lateral. So you can have a smile arch. It is clear that extrusion of the central incisor must be conducted according to the patient's lower lip contour and the sex, respecting the recommendation of the greater extrusion of the incisors for females. As I told you that female should have a little 0.5 to 1 mm, that the difference between the central incisor and the lateral incisor edge, whereas in males it should be 0.5. Another aesthetic parameter widely divulged is the positioning of the gingival apexes, that is the zenith. As most apical points of the gingival contour, frontal analysis of the teeth in the aesthetic zone reveal that gingival apexes are located in the center of the crown or slightly distally. So if that gingival zenith, sometimes it is on the mesial aspect of the crown, so that should be modified. That should be corrected either by a laser or a periodontal surgery. So that should be corrected. On the other hand, based on the limits of the acceptable smile symmetry, changes in the gingival apex hardly affects one smile negatively. So as I mentioned, that gingival apexes are not that much noticed, but it should be corrected. So if we have a gingival asymmetry, that is the levels of the gingiva, according to the literature, gingival asymmetry not greater than 1.5 to 2 mm between the central incisor as well as the canine go unnoticed by lay people. These findings highlights once again that the white aesthetic is more important than the pink aesthetic. So if we are talking about the D zones, so any asymmetry of 1.5 to 2 mm is not generally acceptable. It is usually acceptable by the lay people, and 1.5 to 2 mm is acceptable in the canine region. So if that asymmetry is there, you can keep it, you can leave it as such also. There is, these things are not usually appreciated by the layman. So the gingival smile displays greater asymmetry and for this reason must be corrected. Nevertheless, little gingival display at smiling does not require any correction. So if it is a little more gingival display and the things are more evident, then you can go for correction. Gingival display is again, a matter of concern, because as we, age, there is, the lip falls. So what we people are doing right now, if a patient is around, a young adult patient is having a little gingival display of more than 2 or 3 millimeter, something around 3 to 4 millimeter even. So we are not trying to correct that, because with the age, whenever, young adult will, the smile line will go down. So, and the patient will look little more older. So 3 to 4 mm in a young patient, if the exposure is there, it is acceptable and there is no need to correct that. So the summary for the fifth commandment says that gingival margin of the central incisor must be level and slightly below 0.5 to 1 mm as compared to the canine. Gingival margin of the lateral incisor must be level and slightly below 0.5 mm, and multidisciplinary treatment is necessary for ideal gingival design and treatment. Sixth commandment is the gingival exposure, as I mentioned just now. Assessing the amount of the teeth in the gingival tissue, exposure is of paramount importance for the smile aesthetic. And Zanatol also recommend that gingival exposure is determined by the smile line, that is, when we are smiling, the contour which is the level of the upper lip. So if the upper lip is, elevating and we are seeing the gingival exposure is there along with the clinical crown, so this is a high smile. Medium smile when there are some marginal gingivas which are visible, and low smile when there is no, not even the marginal gingiva and not even the full crown is visible. That is a low smile. Now, complete exposure of the incisor and the little gingival exposure at smiling are aesthetic and characteristics of joviality. They also represent the youth. As I just mentioned, that in young patients we don't correct too much, but in, yes, definitely in a, on an older patient, if that there is too much of gingival exposure, we try to correct that. Based on these findings and considering the different types of smiles, the sixth commandment suggests that the high smile with a minimal gingival exposure is more aesthetic, followed by a medium and low smile. Though in males, a lesser gingival exposure is still, preferred. A very common clinical mistake consists in including maxillary incisor so as to minimize gingival exposure in cases of a normal smile arc. In these cases, loss of ideal incisal smile contour might be more deleterious than gingival tissue exposure. Sometimes what we see is we see a little gingival exposure on smile, but the smile arc, that is the first commandment, is perfect, and we try to intrude the incisor and lateral incisor, and what we end up with the flatter smile. So that is not to be done. Any other things, like sometimes, we can have a second commandment or the third commandment that says the ratios are not leveling. So we can have a we can increase the little length of the incisors by doing some gingivectomy. So gingival exposure up to 3 mm is not always anesthetic. Intrusion of maxillary incisor, especially central incisor, should be avoided or should be done by considering the first commandment. Gingival smile treatment should be guided by its etiology. So whatever the etiology is, sometimes, there is an exposure and there is a gingival enlargement and the height and the width ratio is not normal. So we can go for gingivectomy, and that is a crown landing procedure. So the next commandment says that it is regarding the buccal corridors. Buccal corridor is a bilateral space between the vestibular surface of the visible maxillary posterior teeth when we are taking a photograph and the lip commissure. So these two yellow zones are known as buccal corridor. So definitely when a patient is having a narrow arch, there will be a increased buccal corridor as compared to the wider arch. So in a buccal corridor is wide in cases of a narrow arches. On an average arch, it is intermediate, and on a very wider arches, it is very narrow, or sometimes it is obliterated also. Now, which one is aesthetic? So either it is wide, intermediate, or narrow. There is no perfect consensus regarding that, but definitely whenever we are seeing a narrow arches, so we should do a little expansion so that a corridor can be corrected. Wide corridor can be corrected. Nascimento et al. Says that intermediate buccal corridors are more aesthetic in comparison to wide and narrow buccal corridors, whereas Martin et al. In 2007 says that narrow buccal corridors are more aesthetic. So there is no perfect consensus regarding that, but whenever we see narrow arches, we should expand. So in spite of that, the seventh commandment suggests that intermediate buccal corridors are ideal, followed by narrow and non-existing ones. Thus, a case of wide buccal corridor requires rapid maxillary expansion or a dental expansion so as to enhance smile aesthetics. So buccal corridor is not critical in smile aesthetics. Intermediate buccal corridor is more attractive. Maxillary expansion should be indicated whenever necessary, and wide buccal corridor should be avoided. Then comes the eighth commandment, that is a midline and tooth angulation. So similar to the buccal corridor, midline deviation plays a controversial role in smile aesthetics, because we see routinely in a day-to-day life that people with a midline deviation is there. Whenever we try to focus on their smile, then we just notice that there is a midline deviation, otherwise they remain unnoticed. According to the literature, midline deviation not greater than 3 to 4 mm are not identified by layman. This explains why even some of the famous artists and the models have severe midline deviations. They are still considered as a role model of the beauty. We have a classical example, and we know that there is a drastic midline shift. So while midline deviations are hardly noticed by layman, changes in the tooth angulation in the aesthetic zone are extremely deleterious to one's smile. So there is one midline, and the other thing is the angulation of the front teeth. So according to the literature, minimal changes of 2 mm in the angulation of the anterior teeth in the frontal view are considered unaesthetic by the layman. So there is a midline, but along with that there is an angulation also. If the teeth are too angulated, they are not for like if we talk about central incisor, they should be slightly measly angulated. This is how we whatever the brackets we are placing, so everything is being incorporated in that bracket, predefined that this much tip should be there, so that ultimately at the end you will be achieving a proper angulation. So that should be considered, right? If in this case you see this angulation is distally inclined as compared to this tooth, so this should be corrected. Correction of the angular discrepancy must be based on the classic aesthetic literature guidance. That is, the incisal edge line of the central incisor must be parallel to the interpupillary line. So the summary for the 8th commandment, midline deviation is less relevant than changes in the tooth angulation in the aesthetic zones. Midline deviation equal to or greater than 2 mm, and any degree of changes in the tooth angulation must be corrected. Then the 9th commandment, that says regarding the tooth color and the anatomical shape. The 9th commandment basically determines 3 procedures which aid in the aesthetic refinement, that is dental bleaching, adjustment of the contacts, and the reshaping of the incisal edge in the aesthetic zone. I think the last one, most of us, we do whenever we see some, irregularities between the incisal edge of the one tooth and the other tooth, we try to level it. But most of the times we don't consider about the second commandment, which says about the height to width ratio. So whenever we are doing this, the papilla must fill interdental spaces up to the contact, so that 50% it should be filled by the papilla and 50% that contact. So, however, when the contacts are inappropriate, interdental spaces might remain. So, papilla contact area relationship in the central incisor is 1:1. So, whenever we have a incisal embrasure open, so we need to finish, or we need to do some IPR so that the contact can be brought into the middle, and after that 50% can be filled by the papilla and the 50% remains space. Thus, interproximal reduction should be carried out to position the contact in the mid portion of the clinical crowns, thereby favoring closing the black triangles. So there are two things. One is the incisal embrasure and the other one is the black triangle. So if we are maintaining or achieving a contact in the middle, so we'll be removing these two. Sometimes, whenever we try to level, there is a highly positioned canine. So what we do is, whenever the canine is highly positioned, so you must have seen that the canine is more conical, most of the times, because it is it is still not in occlusion. So when we put a braces over it, we level the canine. So what happens? The contact of the canine with the lateral incisor is not in the middle. It is too cervical. So whenever that is there, so patient will still complain to you at the end of the treatment that there is a space. So what the patient will be talking about is the embrasure, which is still open because of the high contact of the canine with the lateral incisor. So in those particular cases, it is recommended to just finish the canine before placing a bracket. So we can just, we can finish the canine tip. We can take the canine tip little up, so that when we are leveling the canine, within the arch, so that contact can be brought to the middle, so that there will be no big incisor embrasure between the lateral incisor and the canine. So with a view to enhancing incisal edges contour, slight reduction can also be carried out to minimize incisal embrasure, thus improving aesthetic and giving a smile of a younger with a younger look. So that is what I told you about the canine. So we can finish the canine, the tip of the canine, so that we can bring the contact between the lateral incisor and canine in the middle. So the summary for the 9th commandment: dental breaching may be indicated, that is a separate thing. Contact adjustments are necessary to correct the potential black spaces. Enameloplasty by means of enamel reduction to enhance incisal design aesthetics. But again, 2nd commandment, which says about the width and height ratio, should be considered. Then comes the last, that is the 10th commandment, which says about the lip volume. The last commandment is related to the structure that frames the smile, that is the lips. The current standard of the beauty comprises not only only a beautiful smile, but also the voluminous lip. Teeth retraction must be carefully considered, since lip volume may decrease and thereby resulting in thinner, unaesthetic lips. So whenever we plan for a patient, we plan a treatment for a patient, most of the times, a patient comes with a little prominence of the incisors. So whenever we are planning that we need to correct that incisor position, the lip volume must be considered. So what happens? Suppose there is a little proclination, little forward positioning of the incisor, and we go straight forward for the all 4 extraction. So what happens when we are retracting the incisors? So the lip also falls. So the ratio is somewhat around 1:3. So if suppose, let's say we are doing a premolar extraction, we are taking the lip, we are taking the incisor back by 7 millimeter. So correspondingly, 3 part, that is somewhat around 2 millimeter, the lip will also fall. So sometimes the lip is voluminous. So there is, the musculature of the lip is good enough. There are some strains in the lip, so that the lip will take care. But in cases when the lip volume is very low, the lips are thin, so the lip will gradually fall. And if patient nasolabial angle is, on an average side, so you will end up with a little older adult appearance. like a flat kind of lip. So that should be taken care, and accordingly we should plan whether we need an extraction or we can avoid extraction, or we have to avoid extraction by considering other means of gaining spaces like expansion and all. So that is, orthodontists may also recommend dermatological procedures carried out by means of filling with hyaluronic acid, which may yield satisfactory result with pleasant smile and a greater lip volume. So voluminous lips are current standard of beauty. Care should be taken when performing retraction of the anterior teeth so as to prevent negative impact on the lip volume. Multidisciplinary treatment associated dentistry and the dermatology is necessary for lip filling when needed. So all these commandments, they help us in, doing a treatment planning for a patient. So whenever patient steps in, when we try to, evaluate the lip and everything, all these things should be considered. Just for an example, like this patient. So this patient is typically what you call is like diff 2 patient. So the lateral incisors are out, the angulation of the lateral incisor is not correct, the angulation of the central incisor are also not correct, and if you see the smile line, it is not following, smile arc is not correct. So you can see that smile arc is also not following, the incisors are in, lateral are out, and the most important, that is the microaesthetic. If you see the canines, see that lateral is above as compared to the central. There is a disparity between the centrals. If you see the smile arc, the centrals are okay, the laterals are too up. There is a difference of almost more than 2 to 2.5 millimeter. Again, the canines are down. Here, the canine is also down. So we analyze each and everything, and then we plan a perfect treatment. Nowadays, we are doing some Invisalign. We do everything beforehand. Before starting, we plan each and everything for the patient. Like if you see, we plan each and everything, how we want to move the incisors, intrusion, depending, because we have to follow the smile arc, the canines, intrusion, the lateral little extrusion, and the correction of the arch, everything. So if you see the bite and everything has been corrected according to the patient requirement. Like we need to level the margins, we need to level the incisal edges, how the incisal edges should be leveled following the first commandment and everything. So everything is been planned, and then we deliver it. And if you see the results, so this is the result after 8 months of the treatment. So the level, you can see the smile arc, you can see the gingival levels, you can see the laterals, incisors, everything, and you can see that central incisors are little 1.5, because this is, we are planning for a female, so it is somewhat around 1 mm difference, and it is canine are at the same level, you can see, and likewise you can see the gingival levels and the central incisor level. So everything can be planned beforehand, because it is, most of the times nowadays patients are coming for especially for the aesthetic treatment. So the final consideration and conclusion, that aesthetic is an important target to achieve a proper aesthetic. Special attention should be given to first 4 commandments, because they are, for an incisal dominance. And lastly, the interdisciplinary treatment, that is a teamwork, is a vital to yield ideal aesthetic outcomes. Thank you.
Thank you, sir, for your lecture on 10 commandments of smile aesthetics. It was indeed a very guiding lecture. Thank you, sir. It's time to move on to our next guest lecture of the day, and that is Dr. Rajiv Kumar sir. A brief introduction about Dr. Rajiv Kumar sir is that Dr. Rajiv Kumar Gupta completed his masters in prosthodontics in the year 2009 from Sri Ramachandra Dental College, Porur, Chennai, under the able guidance of Dr. T.V. Padmanabhan. Attended more than 80 conferences and workshops till date. He has represented India in ITI conferences in 2010 held at Geneva, Switzerland, presented more than 30 papers and posters, and has received 5 Best Paper Awards at various national and international level conferences. Having numerous publications, out of which 7 are PubMed indexed, he has taken 3 keynote lectures and conducted 5 conference courses for postgraduate students in various Indian Prosthodontic Society conferences. Sir has completed his senior residency in Maulana Azad Institute of Dental Sciences. Earlier, he has worked as an assistant professor in Safdarjung Hospital, New Delhi. He is the former head of the Department of Prosthodontics, IDST Modinagar, and he has also served as head IDST Implant Center. Presently, he is working in the capacity of the professor, Department of Prosthodontics and Implantology in Santosh Dental College, Ghaziabad. Today, sir is going to give the lecture on the topic predictable implant placements in severely narrow ridges. We welcome you for the lecture, sir.
Thank you very much. Am I audible? Anyways, very few people is there. I don't know what is the situation which we are holding people here. So I understand post-lunch session, AC hall. So I'll try my level best to keep you awake during my lecture. I'll not take much time. I'll go a bit faster. Myself, Dr. Rajiv Gupta. I'm professor in Santosh University. First of all, I would like to thank organizing and the scientific committee for giving me this opportunity to share my views with august audience. So I think everybody sitting in this hall will accept the fact that implantology has established itself as a most promising and the well-established treatment modality what we can offer to our patients, whether it is a partially or a completely edentulous patient. But situations do come where we see very narrow bone, where we get confused whether the treatment for the implant will be the right choice for this patient, whether I should go for placement of implant in such kind of a patient or not. That is why I have opted for the topic for today, that is the predictable implant placement in severely narrow ridges. So I'll be talking only the deficiency in the width. I'm not talking about deficiency in the vertical area. We are just talking about the deficiency in the horizontal side. So why we are discussing so? Because if we have not planned our cases thoroughly, especially in a narrow ridge cases, what situation we can encounter is that either our threads will be exposed, there will be a kind of a dehiscence, there will be early chances of the failure of the implant. So, and why we are discussing so is because it has been proved by many authors over a period of time that minimum 1 to 1.5 millimeter of the bone is required all around the implant for a predictable and successful results. But that is the best if we have a native bone all around instead of having a grafted bone. So if we see the literature, n number of the surgical protocols has been suggested. We can go for a bone graft, block graft, we can go for a dissection osteogenesis, we can go for a particular graft with a titanium mesh or a membrane. So n number of the surgical modalities has been introduced to counteract this severely narrow ridges. So we tend to get confused which particular modality suits my situation the best. So if we see the best of all, that wrist-split expansion, I'm not saying that one particular technique is better over another. Every technique has their own contraindications or their own indications. So, but what I'm trying to tell is the ridge expansion is the only surgical procedure indicated in a narrow ridge bone which suggests to place implant on the very same day. So that is why I always say to make a beautiful music, it is not, the challenge is not to press a key, but to understand what key to press when. So I'm not against any specific technique or I'm not promoting any specific technique. I'm just saying that we need to understand what clinical situations indicates the ridge expansion procedure. So what are the disadvantages of various surgical technique over ridge expansion? The most common is the long treatment time, because we are putting a graft, there is a chances that your graft is get exposed, it get infected, it get resorbed. So all those complications, sometimes if we are taking an autogenous graft, there will be a donor site morbidity. So all those complications will not be with a wrist split procedure. So it has been introduced by Hill Totem in 1986 and which was later popularized by Summer in 1994. So just to understand what narrow ridge means is that we have a deficiency in the width, there is no deficiency in the height. So either we can treat it with a bone graft or we can do a ridge expansion procedure. So to understand ridge expansion, we are reflecting the flap, whatever bone is there, we are cutting. That is known as the corticotomy of the bone. We are slitting the bone and then we are trying to expand the bone and create a space or the osteotomy in which your implants can be placed. So this is the clinical case in which you do understand what exactly we mean. So we have a narrow ridge, the slit is been given and then we are expanding it so that we can place the implant and we create a space for the implant. So what is the rationale behind your ridge split technique is we are creating a green stick fracture. So what we assume is when we are creating a green stick fracture, we are not compromising on the vascularity of the bone. So we are creating a green stick fracture and then we are creating a space for the implants and then it heals faster because of the vascularity like any fracture heals. So indications, they are ridge split is more indicated in maxilla as compared to mandible because we are expanding the bone. So more dense the bone, lesser the possibility for it to expand. So we need to have a more flexible bones. That is why it is more indicated in maxilla as compared to mandible. Then the ridge width deficiency only means we can only treat the deficiency in the width. We can't treat the deficiency in the vertical section. Then we have to have minimum 3 millimeter of the available width. We should have minimum 10 millimeter of the available height. Why 10 millimeter? Because we are not increasing the available bone height. So minimum 10 millimeter is required for placing the implant to get the predictable outcome. Then we can't treat any kind of the vertical ridge defect with this. So why we need 3 to 4 millimeter of the bone? We need to understand this. So what happens is if we have 3 to 4 millimeter bone, we have 1 millimeter of the cortical bone and then 1 to 2 millimeter of the cancellous bone in between. So it is indicated whenever we are planning for a ridge split case, we need to have cancellous bone because we can't expand only cortical bone. If you have only cortical bone, D1 quality of the bone like in a mandibular anterior region, it is very difficult to expand the cortical bone. There will be a fracture of the labial plate. So we need to have a cancellous bone. So once we create a corticotomy or a slit, then we can expand the bone and create a space for the implant placement. So advantages, simultaneous implant placement is possible. So we are reducing the cost of the graft or the membrane, reducing the treatment time. So all these are the advantages over the other surgical protocol. We do have a limitations also. As I said, it can only treat the bone width. It cannot treat the bone height compensation for the loss in bone height. Also, because of the resorption pattern of the maxilla, most of the time we are able to place implant at the angle only. So that has to be compensated with the help of the angulated abutments. So as we say, advantages, immediately implant can be placed. We can little bit enhance the hard and the soft tissue profile. We can improve the density of the bone. Since we are expanding, we are not removing any bone. So ultimately we are able to increase the density of the bone and also we are able to place a proper diameter of the implant without having any kind of the comorbidity. Disadvantages, if we are not patient enough when we are performing the surgery, there is a high possibility that we tend to fracture the labial cortical plate. So we have to be extra patient when we are expanding the bone. Contraindication, as I said, when we don't have a cancellous bone, we cannot go for a ridge split procedure. We have to think in the terms of the block graft. So whenever we don't have cancellous bone, whenever we have any severe undercut, whenever we have a too narrow ridge, means lesser than 3 millimeter means we don't have a cancellous bone. And if any one of the cortical plate is compromised or extremely dense, we should avoid your ridge split procedure because that ultimately lead to the failure by having a fracture in the labial cortical plate. So if we see the evidence, again, there is n number of the articles published which supports the success of the ridge split technique from 98 to 100%. So we have enough literature support which supports this particular treatment modality. So coming to the planning, we need to evaluate the anatomy of the bone. So we can have a bone mapping or a bone palpation, but best is the CPCT. If we have a CPCT, we can definitely evaluate what is the quantity of the bone we have. And then for the ridge expansion procedure, we have to have a good case. We have to have in any untoward incidents happen, so we have to keep a backup of the bone graft and the membrane. We have to have a suture, long straight fissure burr. We have to have a disc to section it, and then we have to have the expanders. So earlier, initially when they have introduced this technique, they were using a hand chisel and mallet. But later on, with progress, we have modified the instruments, and we have a motorized ridge expanders, and recently the piezo electric devices has been used to expand the bone. So these are few examples of the chisel and mallet which has been used in the older times for expanding the bone. And nowadays we have a motor or a hand-driven bone expanders which are more predictable and less traumatic to the patient. These are the different saw which has been used to do the corticotomies. And these are the various tips of the piezo which can be used to first do the corticotomy and later expanding the bone to get the desired thickness. So to plan, we need to understand which soft tissue biotype we are working with, what tissue incision design we are planning, what is the mesiodistal width available, what is the buccolingual width available, what is the height. So all those parameters need to be evaluated thoroughly, because if we have not evaluated or planned the case properly, we might end up into the failure. So we have to be extra cautious because we are working in a danger zone. Most of the time we forget this. Whenever we are working in the maxillary anterior region, this kind of the hourglass anatomy is very common. So if we have this hourglass kind of anatomy, we have to abort the procedure of the ridge split, because there is a high possibility once we are trying to expand the bone at this narrow end, your labial plate will fracture. So that is why I always say we have to plan before executing. Otherwise, we ultimately blame a particular technique. So what I always say, that probably what is being understood to be a limitation of the technique, probably it is a limitation of a planning. So if you have not done planning properly, the case fails. Ultimately, we don't blame our planning, we blame the particular technique. So ridge split can be done in 2 stages. One is the single stage procedure. Single stage means on the same day we are doing the corticotomy, we are expanding the bone and we are placing the implant. And another is your second stage. So one stage is single stage means the same day corticotomy is done. I'll be showing you a clinical cases with which we'll be able to understand better. So the corticotomy has been done, bone is been expanded with the expanders, space is created for the implant. If required, particular graft can be done and the primary closure is achieved. But coming to the 2-stage procedure, in the 2-stage procedure, whenever we are working with a D1 or D2 quality of the bone, where there is a possibility that we can fracture the bone. So in that, we are performing the surgery in 2 steps. In the first go, we are just doing the corticotomies. We are not expanding the bone on the same day. We are doing it after 2-3 weeks. So what basically we are doing is, we are creating a fracture in the bone and we are letting it to heal. So once healing is happening in 2 to 3 weeks, there will be a formation of the callus. So once callus is getting formed, it is much easier to expand the callus as compared to the D1 quality of the bone. So that is how we are doing the 2-stage procedure. I'll be showing you a clinical cases with which we'll able to understand these 2-step better. Coming to the complication, there is only one extra complication for the ridge split technique. If we are not patient enough or if we have not done the planning properly, we might lead to fracture of the labial particle plate. Otherwise, rest all complications are same as for any implant surgery, which can be during surgery or even the late complications. Coming to the clinical cases. So here, patient's center and the lateral incisors were missing. There was a history of trauma. So this is the patient's OPG. So we can appreciate there is very thin bone. So in this particular case, we have used Mr. Curate, that is the South Korean company. So they provide us with a different saw and the spreader. So in this particular case, we have used Mr. Curate's spreaders. So full thickness flap was raised with the disc. The horizontal as well as vertical corticotomies was done, and then the spreader was fixed into the position, and gradually, slowly with the spreader, we are expanding the bone. So once you have done the corticotomy, once you have entered the calcareous bone, not in the cortical bone. If you try to expand the cortical bone, there will be fracture of the labial plate. So once you enter the calcareous bone, you fix your spreader, and then gradually with a half turn at a time, you try to expand the bone slowly. So that particular treatment needs patience. So once you have achieved the desired expansion, you can place the implant. So this is implant in position. This is the OPG immediately after placing the implants, after healing, and the final process. So this is a stage 1, type 1 ridge split, in which we are placing the implant on the same day. That is mostly indicated in your maxillary arch, because we are working with a softer bone. So same day, without fracturing the cortical plate, there is more predictable option of expanding the bone. Now coming to the case 2, again the maxillary anterior region, a young female, lateral incisor missing. We can very well appreciate that deficiency of the bone. So we have taken a CPCT of this particular area. So if you this particular slice, all factors which I have told you to see during planning. So we have 3 to 4 millimeter width, we have 1 mm of the good cortical bone, and there is 1 to 2 millimeter of the calcareous bone, and there is no hourglass anatomy. So ideal case for to go for a ridge expansion. In this particular case, we have used Densham split kit. In this, we have a saw. Then we have a ridge expanders of a sequential increasing sizes, and this is a bone chisel. So after raising a full thickness flap, corticotomy was done, and with the help of the bone chisel, you spread the cortical plates. Once you got the cortical plates separated, then starting with the pilot drill, and then gradually expanding the bone. So by sequential drilling, as we say in the sequential drilling for implants, sequentially you have to expand the bone as well. So gradually we are increasing. So every 2 turns, you have to wait for 20-25 seconds for bone to expand. If you do it in one go, there is high possibility we'll fracture the labial cortical plate. So once we got the desired expansion, implant is in position, cover screw in place. So we can see that there is little more jumping distance in that particular area. So we have opted for little particulate bone graft, no membrane, nothing, just particulate bone graft in that particular area, and then primary closure. So this is the OPG, this is the RBG immediately after surgery, this is the OPG, and immediately after surgery we have taken a CBCT also, just to make sure that whether our implant is, so see the beauty of the technique, that all around the implant, in spite of having such a narrow ridge, we are having the native bone all around. Both on the labial and the palatal side, there is native bone all around the implant. Coming to the third case, so these earlier 2 cases we have done with a single stage procedure. Now coming to the mandibular anterior region. So this is a young patient who has to go for a interview for army, so he wanted only fixed prosthesis, and there was only 1 tooth missing, space for 2 teeth, but space for only 1 implant. So we explained him all possible options. He opted for implants. So when we went for CBCT, so again we found a very narrow bone and very dense cortical plates with good amount of the calcareous bone. So again a good case for bone expansion, but considering the D1 quality of the bone, so we have opted for a 2-stage procedure. So on the day 1, what we have to do, we have to raise the flap. With like a conventional method, we have to do the corticotomies. So horizontal corticotomy is done with a saw, then 2 vertical corticotomy is done, like we are doing it in a stage 1 procedure. In stage 1 procedure, after this we normally expand the bone. But in the stage 2, what we have to do, we have to do 1 extra corticotomy. We have to do, so we have to complete this rectangle. We have to complete this rectangle, and then without expanding, we just close it back. So what we are doing is basically we are creating a fracture in the bone, and we are leaving it for 2 to 3 weeks for the callus to get formed. Because if we try to expand the bone today, it is possible that it will fracture. But once we open it after 2-3 weeks, I'll show you. So this corticotomy is completed and primary closure is achieved. So for patient after 2 to 3 weeks, as per the age of the patient, younger the patient, earlier you can call. So once we have opened the flap, you can see the callus formation all around the corticotomy what we have done. So directly with the help of the chisel, just separate the 2 cortical plates and then gradually expand it to get to the desired width, whatever implant you want to place. So we have done got the desired expansion. So implant is been placed. In this particular case, Densham implant is been placed, and there was no jumping distance, no much of the jumping distance, so no bone graft has been planned for this particular case. So you go for a primary closure again. So this is the OPG and this is the CBCT. So we can very well appreciate that all around the implant, the native bone is intact. So once healing is done, impressions were made, and because since there was space for 2 crowns, so 2 splinted crowns were given when on single implant. So to conclude, I would like to say that it looks fancy that we are doing all this stuff, but because without having proper knowledge and planning for the subject, ultimately can lead to the failure. So wrist split technique is considered to be the minimally invasive kind of a procedure as compared to the other surgical procedure which has been recommended in the literature. So to conclude, I would like to say if we try to face tomorrow's challenge with the yesterday's method, we tend to face today's problem. So we need to keep upgrading ourselves. So I love to tell this story. In our time, the first crow, that is, all of us heard about thirsty crow story. So in our time, this crow was considered to be very intelligent because he managed to bring so many stones and put it in a vessel and bring water to a drinkable level. But now I believe we have a smarter, the pro students. So, they don't need this time wastage, and we have access to upgrade ourselves to a different medium, so they can have a straw and then they can drink the water faster. But now time is not for even ultra. I think it's ultra pro students we need. So now we have found a ultra pro. So he doesn't need any vessel. He's not waiting for any stone pellets to be collected. He's not waiting for any straw. He has learned the skill of drinking water himself. So that is what I want to convey, that we have to keep upgrading ourselves. We need to understand what new technologies, what new techniques are available, and then we keep accepting those techniques and learning those philosophies. So these are my references. And I would like to thank my mentor, Dr. Padmanabhan, Dr. Verma, Dr. Bhargava, for giving me all the knowledge because of which I am standing here. So I always consider myself lucky, not because I am lucky, because I believe luck means labor under correct knowledge. Thank you.
Thank you, sir, for the guiding lecture. So this was Dr. Rajiv Gupta, sir, who had just given the lecture on predictable implant placement in severely narrow ridges. Thank you once again, sir. So now it's time to welcome the next speaker for the day, and that is Dr. Abhinav Sharma, sir. And sir is going to deliver the lecture on lasers, a hope of ray in orofacial pain and preventive oral oncology. But before sir starts the lecture, I would like to give a brief intro of sir. Dr. Abhinav Sharma, sir, has completed his MDS in oral medicine and radiology in 2017. He is a postgraduate diploma in hospital and health management thereafter. He is currently working as assistant professor in Subharti Dental College and Hospital. He has several research publications in various national and international Scopus and PubMed indexed journals. He has done several advanced skill enhancement courses and conducted value-added courses on lasers, botulinum, toxin, and radiological diagnosis. He is fellow of the Academy of General Education, Manipal, and is in the executive committee of IDA Meerut Cant as representative to community health. He is the General Secretary for NABH Accreditation of Radiology Department of Subharti Dental College and Hospital, and he is actively involved in clinical practice as well as specialized oral medicine practice. We welcome you, sir, on stage and eagerly wait for your lecture. Please welcome, sir, with a round of applause.
Thank you so much. Yes. Jai Hind, everyone. Myself, Dr. Abhinav Sharma from Subharti Dental College. So this is my place where I work, and all because of our support and guide, Dr. Nikhil Srivastava sir, and my department, my HOD sir, my colleagues, so all are there. So my topic is laser, a hope of ray in orofacial pain and preventive oral oncology. Before starting the topic, I want to discuss something that, like, we work in dental clinics, we work in dental hospitals, and we daily encounter with few patients, like with chief complaint of burning sensation. They complain of burning sensation. Sometimes they they feel they're having a red patch or white patch in the left or right side of the buccal mucosa. Sometimes they also complains of few ulcerations due to trauma or, restricted mouth opening. While having food, they feel burning sensation, as well as they not be able to open their mouth completely, and few swellings also, like over the lower lip. As well as we have a huge discussion about this topic today, like for like 5 minutes we heard that, but I want to highlight something. We also face such kind of patients, like pain and clicking sort of pains in the TMJ, right? So what we do, we diagnose these cases and treat them with the different modalities we are having. Like we have surgical methods, we have non-surgical methods, and we do therapy, we do counselings also. But like we do, I just want to highlight something, like if we do the patients with the help of non-surgical method, what we do, we give corticosteroids. You are all aware of that, in the form of topical ones, in the form of injections, in the form of like systemic. So we consider it as like it is a Ramban ilaj of everything, right? So we also prescribe antioxidants that contains beta carotene, that contains like vitamin E therapy for, such lesions and conditions. In few ulcers, in OSMF cases to reduce the burning sensation, few analgesics, few OSMF gels also are there. And lastly, after the like non-surgical, there is a surgical process. We use scalpel. So at the end, what is the conclusion? Like everything, if it is we use, everything is having a adverse effect, right? So I have a literature, I have a data to show, like if we use antioxidants, like for the prolonged use, if we use, like this article from National Center for Complementary and Integrative Health, and there are a few more articles which suggest that this vitamin E, if we use for prolonged period of time, or beta carotene, like for beta carotene, if we use for prolonged period of time, it cause cancer for the like smokers. And like vitamin E therapy, it is known for the prostate cancer if we use for a very prolonged time. Literature is there. We are all aware of adverse effects of corticosteroids if we use topically or we take systemically. Post-op effects of like treatment through scalpel, like hemostasis, and it is a very invasive procedure, so blood is involved. So there are, you know, different treatment modalities. We treat these lesions and conditions with the help of TENS, with the help of phonophoresis, and we do counselings also. But there is a one thing, like a treatment modality which we are not using in, you know, we are just stick to the like depigmentation or, you know, for removal of stains and all, but we are not using it on the lesions. So that is, I'm introducing this lasers in, you know, lesions. So laser is, we are all aware, light, L for light, A for amplification, S for stimulation, and E emission, radiation, R for radiation. So we are aware of this term. But you know what I feel laser is? L for less invasive, A for advanced, S for specific, E for efficient, and R for refined. And as my topic is array of hope for the like orofacial pain and for the lesions, right? So I'll take 2 minutes. एक छोटी सी कहानी है, like history is important. अगर हम कोई चीज़ पढ़ रहे हैं तो उसका history जानना is important. लेज़र की अगर हम बात करते हैं तो सबसे पहले in 1951 by Charles H. Towns he introduced masers. लेज़र से पहले masers आया. So what is it? Masers is microwave amplification, stimulation, emission, radiation, right? So this idea is taken by Theodore Mayman in 1960s, and he introduced this laser, that is light amplification. Okay. So this was the first instrument in 1960, Theodore Mayman introduced. In 1969, Leon Goldman, he is known for the father of laser medicine, used laser clinically on enamel and dentine. But you know, when he introduced this machine, what happened, like the cases are reported, like there was thermal burn and, you know, dentinal burn, and, you know, cases were reported. So first dental laser of 3 watt by Terry and Bill Mears in 1989, that is neodymium doped yttrium aluminum gourmet. So it is introduced in 1989 for especially for the soft tissues. So basically classification is on the basis of different wavelengths. Hard tissue, according to the delivery system, we use like tips, fiber optics, according to the type of active medium and type of lasing medium, according to the bumping scheme, according to the operation. So we have a different classifications of lasers. But you know, how do laser works? So how it works, you know, L for light. Light is in this, there are two distance between these two wavelengths. Distance between these two wavelengths is defines the concept of laser. That beam, it is form of electromagnetic energy in the form of waves. So it is a like in this we can see the visible light. A is amplification, and that contains 3 things, the 3 components. That is, first is active, and second is pump source, and third is resonator. So I'll not be going into the depth, but I am telling you superficially what are the components. So active consists of solid, liquid, gas, and pump source, it includes flash lamp and arc lamp. And resonator, they are 2 parallel mirrors which is responsible for that coherent beam. Okay. So stimulated and emission and radiation. Radiation is not that harmful one. And if a stimulation is there, like in stimulation, there is 2 things: the power energy applied over the electrons. So what happened with the electrons? They disintegrates into like 2, and then again they, you know, form this straight beam. So the most important part is this laser tissue interaction. So what happens? There are 2 things, diode and erbium. So when the diode is known for the soft tissues. So like we are seeing this chart, and this we can see there is a involvement. If water, this hemoglobin and melanin, when it passes through this is well absorbed in hemoglobin and melanin. So that is known as the soft tissue, that is diode laser. When it absorbs in the water in hydroxyapatite, then it is known as erbium, that is for the hard tissue ones. So there are different photothermal effects of laser at various temperature. So what we use in lesions, that is 100 degree. So what we do ablation and vaporization. So these are the different photothermal effects of laser at various temperatures. And like I've told you, if we use at 100 degrees Celsius, so that fume, the smoke plume is formed. So, and along with that, when we do this ablation, that vaporization occurs. So it's going into the parts of a laser machine. There are a control panel, a optic fiber spool, and touch screen for the parameters we have to set. The machines are available with the pre-settings also, and there is a laser tip. So this one is the like in the first one, this is the that is screen where we have to set the, if we want to go for the dental or derma. And the second, this picture shows there is a cutter for the tip, okay, if we want to just require the finish. And there is this magical wand that is for the optic fiber. There is a foot control and needle that is to be inserted at the front. And then this one is optical fiber, that pill is 3 meters of optical fiber is used, and protective gears for the patient as well as for the dentist. It is very mandatory. So these touch screen for parameters, like recommended settings for different ones, like we can use it for endodontics, periodontics and surgeries. And indications like diagnosis for the pulp vitality, hard tissue, like other from the lesions, we have different indications of lesions. In hard tissue applications, soft tissue applications, I have told you, in the lesions and conditions, and as well as in the gingiva and depigmentation also. And laser induced analgesia also, if we use it from the above 1 mm above from the soft tissue, that it produce mild analgesia effect also. And other is laser activation, in especially in ortho, the people are using it. So types of laser used in dentistry, I have told you earlier also, in soft tissue and hard tissue, the diode one and the erbium one. So before starting, I'll show you the cases, the laser safety is very important. So use of protective optical eyewear is mandatory, and cleaning of the fiber tip with the gauze wetted with normal saline is indicated. Use of warning signs posted outside the nominal hazard zone, and use of non-reflective surfaces. High volume suction is required, as I've told you, the fumes are there, so that is injurious for the health if we continuously inhale it. So high volume suction is required, and plume control and sharps, availability of fire extinguishers is mandatory in that area. So, okay, so I just want to just tell you that this is how we can use our protective measures. So coming on to case reports, like first case is oral submucous fibrosis. The patient came to our department with the chief complaint of difficulty in opening of the mouth. So there is a reduced mouth opening, and as well as the burning sensation is associated. So we asked in the case history. In case history, we have extracted the information related to tobacco. So we came to know he's consuming tobacco from last around 5 or 6 years. So we, on the basis of history and our clinical, diagnosis, we have given the diagnosis, provisional diagnosis, OSMF. So like we have done this clinical examination, pre-treatment mouth opening with the help of a scale. We have measured that is 32 mm before that. And we, on visual analog scale, the, sensitivity that, is 7. So, and we have done the cheek flexibility test also. With this help, we have drawn a line from this tragus to this corner of the mouth, and then with the help of the scale, we have measured this cheek flexibility also. We ask the patient to, blow. Then post treatment, after using the, like, we know that OSMF, it always start from posterior to anteriorly, right? So the facial pillars are involved, as well as the tongue protrusion is also get involved, and shrunken uvula, as well as the mouth opening gets restricted. So what we have done, we have just cut it down those, like, if we palpate those bands, we feel it like a guitar strings. Okay, so what we have done with the help of lasers, we have cut it down those the strings over there, the bands which you have felt. So after post treatment, mouth opening was, there is a huge difference, like 2 mm. So 39 was the mouth opening, and after follow up of 10 days, the visual analog scale, that was 7 at that time. Now you can see the 3. So cheek flexibility we have also measured, that is 47 And there is another case, second case of oral leukoplakia. Patient came to us with a chief complaint of, like, there was a white patch over the right side and left side of the buccal mucosa. Again, in this case, the most important etiological factor was associated is the BD smoking. The maximum number of the cases you will see in BD smokers is cigarette smoking is also there, but maximum number of cases is that unfiltered smoking. So pre-treatment, you can see there the white patch at the occlusal level, and after the post-treatment, with the help of lasers, with the help of ablation, what we have done, we have removed that patch, as well as not to forget, we have counseled the patient also. Like, chances of recurrence is there. I agree. Chances of recurrence is there. We have asked the patient to stop the habit also. So with the help of combination of both the things, we have done this treatment. After 1 week and after 2 weeks to follow up the patient, there is a complete healing. Like previously, we have, what is the choice of treatment in these cases? Anyone knows? That retinol A, we usually prescribe in cases of leukoplakia, but results comparatively, faster in cases of lasers. I'm just introducing a new treatment modality. I'm not denying that medications are bad or laser is good. I'm not promoting any company over here. I'm just telling you there is another treatment modality is there. Why not to use it? Another case is oral lichen planus. So again, stress was the factor associated, hormonal changes was there. We have taken the history and female patient. So on a visual analog scale, that is rate is 7 and sizes, the lesion size is 2.5 into 1.5 centimeter in diameter. And with the help of laser, like we have adjusted it to 2.5 watt, the energy supply to 2.5 watt. And the post treatment, you can see the completely healed lesion was there. Sorry, not lesion was there. So case 4, over the lateral border of the tongue, you can see there is a squamous papilloma is there, right? So we have diagnosed it over there. There was a patient complaints of growth over the lateral border of the tongue. We have diagnosed it. But this diagnosis, after that, we have sent it to the oral pathology department after we have done the biopsy with the help of lasers, and you can see after the 3 weeks, the follow-up, the lesion is healed. Another, maximum number of the cases, especially in the young adults, we see this mucocele. A 37-year-old female patient reported with the chief complaint of swelling on the lower lip since 1 month. So in intraoral examination, we have seen the solitary shaped swelling with mild bluish tinge and present on lower lip that was approximately 1 into 1.5 centimeter in diameter. And on palpation, that was soft in consistency, fluctuant, non-tender on palpation, and no bleeding and pus discharge was there. So we have made a diagnosis that is mucocele, and we have given the treatment with the help of, earlier we were using the scalpel, but in scalpel what I have seen that there is too much blood is there, while extracting that mucocele, we have to extract the minor salivary gland also beneath, which is present beneath the mucocele. So with the help of this lasers, have removed the mucocele as well as the minor salivary gland also. So after 1 month follow-up, you can see that there was a complete healing. Another case of aphthous stomatitis, and number of cases is there. What we have to do is just place it 1 mm above the that aphthous ulcer, and patient will feel mild analgesia, and just do it 3-4 cycles for 3 days, and that complete healing is after 3 days. And the last case is that is TMJ disorder. So in this, maximum number of the patient came and they complains of difficulty or mild deviation as well as clicking sound while opening and closing of mouth. Maybe we made diagnosis on the basis of clicking sound, like this displacement with the reduction or without reduction. After making these diagnoses, we treat them with the different treatment modalities, like we have TENS machine also, we have phonophoresis also, but this time we have used low level laser therapy in this case. So low level laser therapy is like, again we have to 1 mm above the joint, we in the circular motion we have to give this therapy, and we have to recall the patients for at least 4 weeks. Along with this, the home care instructions is required, like not to chew any hard bite, and if patient is like doing any, is patient, maximum number of cases are associated with the loco pilots, they have to उनको चीखना ज़्यादा पड़ता है, इंजन में आवाज़ ज़्यादा होती है, तो उस केस में we have asked the patient to please take care of these things for few days, and the results are very impressive with the help of low level laser therapy. So I want to conclude my presentation that I just want to say I'm not against of these medicines. I'm just introducing new treatment modalities in the cases of, especially in the cases of lesions and pre-malignant conditions. So thank you so much.
Thank you so much, sir. Sir has just given the lecture on lasers, a hope of ray in orofacial pain and preventive oral oncology. And that was Dr. Abhinav Sharma, sir. Thank you so much, sir. It was a very inspiring and guiding lecture. We all thoroughly enjoyed it. So after the lecture, it's time for the felicitation of the guest speakers. I would request Dr. Anmol Bagaria ma'am and Dr. Ashish Chandra sir to come on stage for the felicitation of the speakers. I would also request Dr. Nitin Garg sir to come on stage. Dr. Nitin Bhagat sir to come on stage and continue with the felicitation. I would also request Dr. Sumit Goyal sir to come on the stage and felicitate the guest speakers for the day. Now I would like to call upon Dr. Rajiv Gupta sir, who has given a lecture on predictable implant placement in severely narrow ridges. Thank you, sir. It was a very guiding lecture. Please welcome sir with a round of applause. Thank you, sir. The next speaker is the speaker who had just spoken about lasers, and that is none other than Dr. Abhinav Sharma, sir. The lecture was not only guiding but also fun, sir. Thank you so much, sir. Please give a round of applause for sir. Next is Dr. Harsimran Kaur ma'am. She is yet to give the lecture, but we would like to felicitate you, ma'am. She is going to give lecture on predictable complete denture impressions for predictable outcomes. Please give a round of applause for ma'am. Dr. Harsimran Kaur ma'am. Thank you, respected dignitaries on the stage. Now I would like to call upon Drishti, my fellow from Sharda University, to continue with the ceremony. Thank you, everyone. Nitin sir, can you please come on stage once?
Our next speaker is Dr. Nitin Garg, who is a dedicated maxillofacial prosthodontist and certified implantologist practicing in New Delhi. He completed his graduation, that is BDS, from MCODS Mangalore. He was a gold medalist during his graduation days. Sir, we welcome you on the stage.
Hello. Good afternoon, everyone. I think it's a post-lunch session, so I hope you all are not asleep. So, topic for today's session will be impression for implants. So, before starting for the presentation, I would like to show where I did my UG and PG. I did my graduation from the Manipal College of Dental Sciences, Mangalore, that is Mahi University. And after that, I went ahead to Cots, Davangere for my post-graduation in the field of prosthodontist. And right now, I'm practicing in Max Hospital as a visiting consultant in New Delhi. So basically, acute and accurate impression is very mandatory to establish a three-dimensional spatial position of an implant and transfer or reproduce back it to the cast. So a good implant impression records a three-dimensional position of an implant in the oral cavity. So before starting, I would like to tell what is a dental implant basically. It is a substance that is placed into the jaw bone to support a fixed or a removable partial prosthesis. What is an impression? Impression is a negative likeness or a copy in reverse of the surface of an object or an imprint of teeth and adjacent structures for the use in dentistry. So before you start for the prosthetic phase of the implant, what are the things that you will be needing at your practice? These includes RVG unit, a tissue punch or a BP blade, a periodontal probe, healing abutments. Healing abutments can be of different diameters, different heights that you have to decide according to your implant size. Then is the implant hex drivers, implant analogs, abutments. Next will be impression post. Impression post will be decided on the basis of what kind of impression you want to record. Either you wanted a closed tray impression, abutment level impression, implant level impression, direct, indirect, open or a closed tray. Then you will be needing healing abutments, multi-units, impression trays, impression materials. Desired are the polysilicon impression materials, a floss, pattern resin, tray adhesive, handpiece and burrs. So coming on to the techniques, what are the various techniques to record implant impressions? They are majorly classified as implant level impressions, abutment level impressions and digital impressions. Coming on to implant level impressions, they are open tray impressions and closed tray impressions. And when we talk about abutment level impressions, they are either direct technique or an indirect technique. So how do you need to prepare a patient before starting the impression of the implant? You have to make sure your implant is seen. You have a good profile or an emergence or a gingival profile before you start for the implant impressions or a prosthetic phase of an implant. For that, what you need to do either with a punching burr or with a BP blade, give an incision, expose the implant that you have placed, remove the cover screw, select the appropriate healing abutment and fix the healing abutment, screw the healing abutment to the implant in the oral cavity. Then advise to leave it for 2 weeks to have a good emergence profile so that your gingival soft tissue also looks natural when you give a prosthesis over your placed implant. So talking about to the implant level impressions, there are two techniques. One is open tray and other one is closed tray. There are different copings, impression copings that are used for both the different types of impression. Make sure you don't use the closed tray coping for an open tray impression or an open tray coping for a closed impression. So when we talk about open tray impressions, impression copings are removed along with the impression when we take. Usually custom trays are required and these are more accurate. While talking about the closed tray impressions, in this impression coping is retained inside the mouth at the time of removal of impression material, and usually there is no custom trays required. So when we talk about a closed tray impression technique for the implant level impression, you have to remove the healing screw that you have placed for a good emergence profile. Then this is what exactly a closed tray coping, impression copings look like, that you have to fix into the internal hex of the implant that you have placed, and take a radiograph to confirm whether it has exactly fitted into the internal hex that of the implant. So first picture where a cross is depicted, this is that the impression coping is not exactly fitted into the implant. So what will happen if you take an impression of such a kind, there a 3D dimension of the implant won't be recorded and your prosthesis again will fail. So then once the impression coping has been screwed to the implant, you have to block the screw and take a closed tray impression with a light, with any silicone material, be it a PVS or a polyether. Then again, remove the closed tray impression, place back the healing abutment, and last picture will be how your impression will be looking like. And there will be indentations that are present on the closed tray coping. You have to fix it back into the same indentations. So there are basically two concepts for the closed tray copings. One is strawman that gives the OT caps. Other one is a biohorizon concept that comes without the OT caps. So what happens in strawman is these OT caps for the impression copings get transferred to the impression that you have taken. So once you are placing back the closed tray copings, they have to just fit it back into the copings. Whereas for the biohorizon system, what you have to do is just follow the indentations, a click sound will come. That means it has been fitted properly into the impression material to go ahead with the pouring of the cast. So this is one of the clinical cases where healing abutment has been removed, a closed tray coping has been fixed, light body is injected around the closed tray coping, and a good impression has been made. Now you can see it is a biohorizon type of closed tray coping where is no OT caps. So as appreciated in figure 5, there are indentations that are present for the closed tray copings. So in the same indentations, you have to fix back the closed tray copings that will be removing from the oral cavity. So another such case for completely edentulous cases is for the overdentures. Usually we advise a closed tray impressions. Same manner, a closed tray overdenture copings will be present, that you have to take a border molding has to be done, and then for the impression you will take a over pickup impression and attach the implant analogs, and this is how your final prosthesis will be for removable overdentures. Now coming on to the indications for closed tray impressions are for the cases where there is limited mouth opening, reduced interocclusal space, patient have a high gag reflex, it's difficult to access the posterior region where implants have been placed, but it is not advised for non-parallel implants and deeply seated implants. When we talk about the next technique for the implant level impressions, the most commonly used is open tray impression techniques. In open tray impression techniques, once you have removed the healing abutment, you will attach a open impression coping and take a impression, and your coping will come out along with the impression. So for example, if we talk about the single tooth impressions, you have attached a one second. So in this, you have attached open impression coping inside the patient mouth, and with, you have verified the position whether it has seated properly into the implant socket with the radiograph, and then make sure you have enough clearance with your impression tray that you are taking. Inject the light body around, and with the help of putty, you take a two-step single stage impression. Now next step what will be modified here is you have to again open up the open tray copings that will get transferred onto your impression, as you can see here. And then over that you will attach your implant analogs and pour the cast. Your final cast will be looking something like this. Over this your abutment will be attached at the later stage. For the same technique, when we talk about completely edentulous or partially edentulous status where multiple implants have been placed, same has to be done. You have to place multiple each open tray copings, how much amount of implants you have placed. Make sure your tray is cleared enough for the open tray copings, for the copings height spaces. You take a nice impression, open up the impression copings, and your impression copings are seated into the impression material once it is removed. Now to verify whether our impression that has been taken, there is no movement while removing in the impression copings, is it 3D accurate or not? There are two methods. One is the use of verification jig or a jig trial that a lab will give you in the next setting, and you have to see whether the seat it or screw it back into the implants and see whether it is sitting properly, there is no rocking or there is no movements that are happening. If there are no movements happening, that means you had a perfect impression that was made, and you can go ahead with your next steps. The other method that you can try is a splinting method. You can tie up all the impression copings with a floss and a pattern resin and make an impression, so that while removing the impression, there is no micro movements or no movements that are happening in the impression copings that might make you cause an inaccurate impression. So in a case of multi-unit, there are multi-units first that are, so these are the implants that have been placed. These are the multi-units that are placed over the implants, and these are the impression copings for implant, the cylindrical copings that are placed inside the oral cavity. As we were talking about splinting, I'll describe this technique in this case. So first of all, you have to tie all the impression coping with the help of a floss and attach them, give a rigid structure to it with a pattern resin, then check for the tray clearance for your copings. This is how your tray will be looking like once you have made enough spaces for your impression coping where they can pop out while making an impression. Then a one-stage or a two-stage impression can be used with the silicone impressions. Once the impression material has been set, unscrew your impression copings so that they can be removed along with the impression where you're trying to remove. This is basically how your impression will look like once you have removed it from the oral cavity. Then you will select the desired implant analogs and fix it or screw it back to the impression that has been made to obtain a nice cast that will be exact replica of what is happening inside the oral cavity of patient's mouth. Now coming on to the second classification, that was abutment level impressions. In abutment level, in implant level impressions, you are taking the impressions of the implant that you have placed in the oral cavity. In abutment level impressions, we will take impressions of the abutment that has been attached to the implant, and then we are taking the impressions. So talking about abutment level impressions, there are two types, either direct or indirect. Direct abutment level impression technique is nothing but as grossly we can tell, it's a normal single crown impressions or FPD impressions that you took. Here you have to just attach a abutment inside the oral cavity, trim it according to the needs, according to the interocclusal clearance, or prepare it like a tooth preparation you do, and then a normal impression you can take up and pour the cast, and your cast over that your lab technician will fabricate a processes. In this case, we have taken a triple tray impressions. In triple tray impressions, you can register upper arch lower arch, and a bite registration all in a one step. So you can see this is the impression of the abutment that was placed inside the oral cavity, and directly you can pour the cast, and you will have a mounted cast. Over that you can fabricate your prosthesis. So coming on to the another indirect abutment level impression technique. Here you will place the abutment inside the patient mouth, trim it according to your needs for the prosthesis, and then over that you will place OT caps and then take a nice impression. That OT cap will get transferred into the implant, as you can see here. Over that you attach an abutment analog and then pour the cast. So now coming on to another type, that is how to record a emergence profile that you have already obtained by giving a temporary prosthesis or immediate loading, or while giving a temporary prosthesis at the time of implant placement. In this one of the case, we have taken a natural extracted tooth of the patient mouth and given the same prosthesis on the temporary abutment. So we placed the implant, left it for 3-4 months, and then patient was called back. We unscrewed the temporary prosthesis, and this is how the temporary prosthesis was looking like in all the profiles with a temporary abutment in this. Then what we did was this implant analog was screwed back into the prosthesis, and an impression of the cervical part as well as the implant level was made into the putty, so that we can obtain a putty index of this. You can appreciate this implant analog is there, and this is the soft tissue or a gingival profile that had been reproduced in the putty. Now we will screw the open tray coping into this implant analog, and the remaining space was filled by the composite. So this is what, once the composite curing is done and you unscrew your impression coping, this is how it will look like. This is then placed inside the patient mouth and verified radiographically that it fits properly into your implant socket. And the normal procedure continues. You take an impression, you pour the cast and fabricate a prosthesis. Now your prosthesis will be exactly have a same gingival profile that was obtained over the period of 3 months. Now talking about the fully edentulous cases of immediate loading, where you give a temporary prosthesis to a patient is completely edentulous. He wants a teeth in a single day or in a day or 3 within 72 hours. You give do a immediate loading, give a temporary prosthesis to the patient. Now patient comes back for a definitive prosthesis. How to convert a temporary prosthesis for the use of impression and give it back for the time being your final prosthesis is being delivered. So this is how your final temporary interim or the temporary hybrid prosthesis will look like. This is inside the patient mouth. Either you can attach the cylindrical impression copings or just leave it like that, block your screws, and then inject the light body wherever there is space between where there is space between the hybrid prosthesis and a soft tissue, and then surrounded around by the putty, the whole area remaining so that around with the putty. So basically what you are doing here is, instead of a custom tray or an open tray with a space for the impression post, you are using your temporary dentures or a hybrid prosthesis that you have given to act as a tray, and you are making an impression. So once your impression material gets set, you have to unscrew the multi-unit screws or the impression cylindrical copings if you have used, and this is how your final prosthesis will look like. One thing I need to remind you guys here, that take a registration bite here. This technique will make sure your 3 steps, 3 appointments for the patients are done in single step. Patient is getting temporary prosthesis back till his final prosthesis is being fabricated. His JR is done and impression is done. So if you have taken a bite registration before and impression is made, so this is the denture, and over this final pickup or a final impression is made. You pour the cast upper and lower. Then once your cast has been, you obtained a nice master cast with the help of bite registration that you have taken bite. You can mount it back into the same sitting, and once you are done with the mounting and the cast, you can unscrew, nicely clean the processes and give the temporary back to the patient. and send that mounting to the lab for the fabrication of the prosthesis. This is how your final prosthesis will look like later stages. So in the last, I would like to thank CynoDent, Almighty God, my parents, teachers, to give all the knowledges that have been acquired over the past 9 years to me. If any doubts, any questions, you are free to contact later stages also, right now also. Thank you.
Our next speaker is Dr. Harsimran Kaur, who has completed her graduation from Baba Farid University of Health Sciences and post-graduation from Government Dental College and Hospital, Amritsar in 2011. She's a university topper and a gold medalist. Currently, she's working as an associate professor at Manav Rachna Dental College, Haryana. We welcome you, ma'am.
Good afternoon, everyone. Thank you so much for the kind words and introduction. Greetings from the institute where I work, Manav Rachna Dental College, Faridabad. And today I want to utilize this opportunity to talk about the upgradation of complete dentures in a manner that we give predictable outcomes to our patient in the form of good complete dentures. So since this is a post-lunch session and everyone is, I feel, little sleepy, let's have the aroma of the virtual coffee, and please bear with me for another 20 minutes. I'll not be monotonous during my presentation. All right, let me start with a very common, embarrassing encounters we see at times in our clinics, the non-retentive dentures. And they sometimes, give us sleepless nights. And what exactly are complete dentures? They are the mechanical devices, and they should be placed in a mouth in such a manner that the muscles around it, they hold it, and they do not displace the denture from their place. It should be something like a mother carrying a baby. So to avoid these kind of embarrassing movements, we should work in a manner that we give some predictable outcomes. Recently, these two rock stars, they've managed RRR very well. And now is the time that we also pull up our socks and manage the residual ridge resorption in a manner that we give good complete dentures to our patients. So the contents of my presentation would be the dentures and changing demographics. The first right step, that is the impression making. Then I'll be talking a little bit about the enigma of the resorbed ridges. And then one upgraded method, that is utilizing TENS. So what is happening is that because of the changing demographics, it is imposing different needs of patients in front of practitioners. Though the number of edentulous cases are getting reduced, but the expectancy of the life, which is increasing, is coming up or putting an imperative pressure on the practitioner that we deliver good. The quality work, if it is not being delivered to the patient, then the patient feels that the treatment has been compromised and their life is actually compromised. So the first right step, I would say, is the impression making, which is very important in complete dentures. And if we take the first right step, then the journey of 1,000 miles can be, taken care of by very easily. So I would say that well begun is half done. But the most difficult step is also impression making in complete dentures. And it leaves many researchers, clinicians, and, experienced practitioners baffled. Because many a times it is because of the unpredictable outcomes, it remains an enigma for the practitioners. A simple looking procedure may sometime impose an intimidating terrain. And in fact, a failure in this procedure may make it seem all uphill. But what is the exact problem? What are the solutions we already have in our literature? And what are the limitations of these solutions that need to be overcome by upgrading our techniques in order to provide surer outcomes? So the resorbed ridges, they impose great challenges on the practitioner. And due to increased resorption, there is an apparent displacement of the denture. So for instance, if the there are highly resorbed ridges, there are chances that the floor of the mouth might get raised. The vestibules might get obliterated with due course of time because of resorption. So what happens? The patient always feels that the denture is not seating properly in the mouth. So because of that, what happens? Patients will come to you with common problems like these. They'll say that they have loose lower dentures. They are feeling that mastication is not proper. They are not satisfied when they are eating food. Because of the continuous displacement of the denture, there is no proper aesthetics. Then swallowing, speaking, both things are compromised. And you'll see that your patients will be carrying bag full of dentures. They will be, made up by several dentists over a period of time, and still the patient is not satisfied. And you'll actually see that the digestion problems the patients will present with. And he'll say that he's not able to, cope up with the GI problems, and also the health is getting compromised. So struggle is tremendous and is constant, and this is the time that we combat it. So as the residual ridges, they resorb, the tissue becomes unsupported and displaceable. There are various impression techniques which have been already put forth in the previous literature, and this dilemma has been addressed many a times in the past. For example, we talk about the cliche conventional impression making technique, followed by the technique which is given by McCords and Tyson, then the all green concept, then functional impression technique by Winkler. Then there's another technique called as cocktail technique. But what are the problems with these techniques? Are there any issues? Yes, sometimes there are few issues, though these modifications, they help us in bringing out good results, but the predictability is the reproducibility is the major question. Why reproducibility is the question. For instance, when we are utilizing cocktail impression making technique. The biting force which patient is going to apply, it is different in different patients. And the operator's manipulation of the tissues is again different. If the manipulation of the tissues is done vigorously, then you might land up in getting over-shortened impressions, right? And so muscle manipulation can give unpredictable results. Also, this can add on to the multiple visits of the patient. Another option these days, the previous speaker very nicely explained about the techniques of impression making in implants. So that implant impressions and I would say the implant as a treatment per se is also is going to give you a predictable outcome. But what is the major problem, especially with our country? One is economic burden. The other is the patients at that particular age, they are not very well prepared for the surgery at times. And the third thing can be the age, that is specifically if you talk about the geriatric patients, the systemic conditions related to the surgery can be such that you cannot actually go ahead with any kind of surgeries on those patients. So what do? We have to give some kind of solution to them. So let's demystify the enigma. Perhaps the need of the hour is that we change our method, and which require the reducing the operator's variability and imparting consistency to the procedure. So this presentation is going to put forth the alternative vector to provide predictable solution, and it is using the transcutaneous electric nerve stimulation. It is a solution which is ergonomic, practical, and provide feasible solution. Let's talk about this upgraded technique. So transcutaneous electric nerve stimulation, that is TENS. It basically utilizes the electric current which is produced by a device to stimulate the nerves, basically for therapeutic purposes. So TENS is nothing new. We are utilizing this for impression making dentistry now, but TENS is something which has been used for a very long period now, and it is there in medical stream for many years. So why they use it? Mainly you must have seen this particular thing used by physiotherapists, mainly for the lower backache, right? So they do some kind of electric nerve stimulation which stimulates the underlying nerves and relieves the pain. So that is the whole the mechanics behind it. But how exactly we are going to utilize it, I'm going to tell you that. So a TENS unit is a device that transmits small square electrical pulses to the electrodes, and they further gets transferred to the underlying nerves. And the fundamental component of this TENS machine is electrodes, the highly advanced computer chip. You can see the electrodes here, and then computer chip and a source of battery, electrical source of battery. Then a small amount of electricity is transmitted through the computer component, then to the electrodes, which finally goes in the waveform to the underlying nerves. A typical battery operated TENS unit is able to modulate three important things. One is frequency, the other is intensity, and the third one is the width, the pulse width. So pulse frequency and the pulse intensity are the ones which can be majorly adjusted on the TENS unit. So how exactly or what a TENS unit is going to modulate? First is, if we talk about the pulse frequency, so we get two frequencies in TENS units. One is sensory intensity, which is high frequency, that is more than 50 Hertz. And the other one is motor intensity, that is low frequency, less than 10 Hertz. So one which is low frequency, that is motor intensity, is the, I want to emphasize on that this is the one which we are going to utilize for impression making. The other one, which is sensory intensity, is generally to take care of the pain management, especially by the physiotherapist people. And if you talk about the pulse width, it is the duration or the measurement between wavelengths, and it is measured by time, and it is the difference between the two wavelengths, right? Then coming on to TENS patterns. So we get two different modes in TENS unit. One is burst mode, the other one is continuous mode or the modulation mode. So burst mode makes a series of 5 to 10 quick pulses followed by a resting period, and this cycle repeats itself 2 times every second. And if you talk about the continuous mode, it makes a series of pulses depending upon the preset value. And again, the emphasis is that continuous mode is the one which we are going to utilize for making our impressions. So these are the final settings with which we'll be operating the TENS unit. The low intensity, as we have already discussed, it should be less than 10 Hertz. The time required to stimulate the muscles, or when the visible muscle twitching is there on patient's face, is generally 10 to 15 minutes. Then pulse width is going to be 250 micrometers, and we must establish a precise balance between right and left side. So let's begin with the operation, or operating exactly the TENS unit. So we have two channels in the TENS unit, channel 1 and channel 2, shown here in different colors. So channel 1 is basically to stimulate the preauricular region and of both left and right side, and channel 2 is for the posterior triangle of the neck. So why exactly we are emphasizing on these two regions only? Let's see the physiology behind the mandibular impression making. So if we see the muscles which are colored in blue, they are all supplied by facial nerve, or you can say 7th cranial nerve. So let me begin with the labial frenum here, which is actually depressor labii inferioris, supplied by 7th. Then labial vestibule, made up of orbicularis oris and mentalis. If we move further, corner of the mouth, modulus, supplied by 7th. Then buccal frenum, depressor anguli oris and orbicularis oris, again 7th nerve, and buccal vestibule, which is buccinator, 7th nerve. If you see the yellow boxes, we have mesenteric notch, which is supplied by mesenteric nerve, which is the branch of trigeminal, 5th nerve. And if you see here on the other side, yellow box, it is mylohyoid, again supplied by 5th nerve. If you talk about the violet color here, which is palatoglossus, it is supplied by vagus and accessory. The superior constrictor, again by vagus. And pterygomandibular raphe, since it is made up of buccinator, superior constrictor, it is supplied by 7th and 10th. Just remember this red box here, that is genioglossus, that is supplied by 12th nerve. I'm not here to tell you about this right now. We'll discuss it later in future slides. And coming on to the maxillary muscles, again, 3 blue boxes which you are seeing here are supplied by 7th. Then there is a green box which is showing palatoglossus, palatopharyngeus, levator, vellae, palatini. They are all supplied by vagus. Further, if you go posteriorly, there is tensor vellae palatini, again supplied by 5th nerve. Why do we talk about this? So much of physiology, so much of muscles and nerves and everything. What is the relevance? So relevance of determining the location of attachment of the electrode will be correlating the action of muscles that electrode is going to stimulate. So now, if we talk about the preauricular region, where we exactly are going to put the electrode, one of the electrodes, it is going to stimulate the facial nerve and the mandibular nerve. So maximum muscles which we have seen, they are getting stimulated either by the 7th cranial nerve or the 5th cranial nerve. So orbicularis oris, depressor anguli oris, buccinator, masseter, and mylohyoid, they are all present there in the preauricular region. I mean the nerve which is going to stimulate them. And if you talk about the posterior triangle of neck, there we have spinal accessory nerve, and it is going to stimulate the palatoglossus. In addition to this increased parasympathetic activity with vagus nerve, the relaxation or the calming effect will be there, because there is a deep-seated vagus in that region also. But as I mentioned in the earlier slide, that I'm not going to tell you about the red box there, but now I'm going to tell it here. Why genioglossus is important? Because hypoglossal is the nerve which supplies that muscle, and it is not covered by TENS. So how exactly do we stimulate that? We ask the patient to swallow, right? So let me begin with the description of the TENS unit here. This is the TENS unit. Quadratens is the unit which we use. So here if you see, there are 3 buttons. The first one is to switch it on or switch it off. Then the middle one is for continuous mode. The third one is for burst mode. And as we all know, continuous mode is the one which we prefer. The one which there are 3 switches which are corresponding to these gray switches. They actually will tell you what mode you are operating the TENS machine on. Then these are inferior knobs here. This is to adjust the intensity. Intensity, it goes from 1 to 10. And then we have superior knobs, which is to establish right and left balance. And let me begin with the placement of the electrodes on the patient's face. So this is the preauricular area which you will determine, and then you identify the posterior triangle of the neck. How to determine the posterior triangle of the neck? You ask the patient to turn his head or her head on the opposite direction, and then there'll be prominent belly of sternocleidomastoid. The posterior part of the sternocleidomastoid is going to make the anterior part of the posterior triangle of neck. And that is the area which is actually your posterior triangle of neck. Then the adhesive pads are applied onto these identified areas. All right. And then the electrodes are attached to these adhesive pads. So like this, we put the adhesive pads in the preauricular and posterior triangle neck area, and the electrodes are attached. All right, so these are the electrodes which you connect to the adhesive pads. So if you see, these are red in color, and 2 are red in color and 2 are black in color. So it is always preferred that red electrodes will go on to the right side. R is red, R is right, which is, you know, easy to identify. And then just clean this area, wipe this area, attach the adhesive pads. It's just the repetition of the video. Got some interruption in between. So the electrodes, they are attached to the adhesive pads, and then now is the time you adjust the TENS unit machine. Adjust it on the continuous mode. First you switch it on, then adjust it on the continuous mode, and then you start increasing the intensity till the time patient is able to tolerate the intensity, right? And that is going to be visible in a very probable manner, and patient, you will see the twitching happening on the patient's face like this. So after 10 to 15 minutes, you'll see the patient is twitching like this. And now is the time that you load your impression tray. And normally the material which is utilized is heavy body polyether, or you can use silicone also. This is already adjusted tray, and it is only 1 millimeter short of the vestibular depth. And now just observe, we are not making any kind of muscular movements for this patient. This is the physiological recording which is happening, and this is happening because of the activation of the muscles, because of the nerve stimulation which we are doing through TENS, right? So this is all happening itself. So it is going to give you predictable results because there is no operator manipulation being done. Only thing which is missed is hypoglossal action, that is genioglossus. For that, you have to ask the patient to swallow. And this is the kind of impression you get at the end. For maxilla also, again, mainly the nerves which are involved are cranial, 7th cranial and the 5th cranial nerve. So that can also be taken care by TENS machine. So the biometric denture space is the space that exists in each individual where the denture is designed to function in harmony with oral musculature. So the chemiosurface recording is very important, and it influences the stability. So it is in continuation to the neutral zone. recording of the neutral zone. You can record the polished surface of the denture also. See how exactly we can do that. After the try-in stage, just remove a little bit of wax, put adhesive onto the record basis, and apply light body or the medium body onto the polished surface area. Then you place it in patient's mouth and ask the patient to perform various movements. O's, E's, and swallowing movements are generally done to record the polished surfaces. So like this is for the maxillary denture. See the recorded surface, and same can be done with the mandibular denture as well. So for the in this particular case, both the labial and the lingual surfaces are coated with light body or the medium body, and again the patient is asked to perform all the movements. So as soon as you take these things, both the recorded surfaces of chemio surfaces of upper and lower dentures, you can directly go ahead with the investment. And this is how the final chemio surface recording gives you a denture which is going to be highly stable in the patient's mouth. So this is the outcome which you get from a patient who has got highly resorbed ridges. So what are the advantages? The advantages are that it overcomes the limitation of manual molding like over-shortening or overextension. Operator procedure and patient compliance are highly reduced, and it is a single-step procedure. Multiple step water molding is not there. Then there is consistency of result with increased reproducibility and improved patient satisfaction. It is a pressureless impression making technique. So the ridges which are highly resorbed and also which are inflamed or flabby, this particular technique can be easily utilized. And it also gives a relaxing ambience to the patient, so patients become more compliant to the treatment. Then limitations are that there is a dependency on the machine and it does not stimulate the hypoglossal nerve, but that can be managed, that is not a problem. And the caution is that in few select areas you cannot use it. Let's discuss what are the few areas where you cannot or you should not use TENS machine for your impression making. One is broken skin or areas of wounds. The other is tumor or malignant areas if you have in these particular areas like preauricular and posterior triangle of neck. Why? Because few of the in vitro studies have shown that the electric impulses, they can actually promote the growth of the cells in that area. So we don't want that. And in front of the neck area, because of the carotid sinus, and which can lead to the vasovagal reflex for the patient, which is again not required. And patients with pacemakers, you cannot use TENS machine. And in pregnant females, though there are no contraindications, reported in the literatures, but there is no evidence, so it is better to avoid such conditions in such usage in pregnant females. Then skin with reduced sensation, because it may cause skin irritation due to inability to perceive high currents. And over areas where infection is there, it can cause the contamination of the adjacent areas. This is the supporting literature for utilizing TENS as a method for impression making. Eventually, we need to shift to this embarrassing situation to a predictable outcome where patient is more satisfied and happy. So when the wind does not blow to favor us, we should adjust our sails. That is, we must find an alternate way to find a solution to our problems, and resorbed bridges are one of them. Homage to Dr. APJ Abdul Kalam. To conclude, there's a commercial which says that we need to upgrade.
Sorry, I'm late. Let's get to work.
If we'll not upgrade, people will think that we belong to some ancient era. So this is the time to upgrade.
It's this curious device. It's an ultra convertible.
Is it powered by the sun?
No, it's powered by Intel. What? Jerry. Suddenly everything
seems old-fashioned. A laptop when you need it, a tablet when you want it. The Ultrabook Convertible, powered by Intel.
Let us upgrade our dentures also. My sincere acknowledgements to CynoDent and organizing committee of this conference. Thank you so much for your patient listening.
Thank you so much, ma'am. So now we are done with the lectures. Within 5 minutes, we'll start the valedictory function. So I request all of you to please gather everyone here. Within 5 minutes, we'll start with the valedictory functions. Okay?
I would request everyone who is present in the Audi and within the campus ground to please join us for the valedictory function. I would request the volunteers of Sharda to call upon the people from outside for the valedictory function. Everyone, please come to the Audi for the valedictory function. Once again, a very good evening to all the ones present here. Warm greetings to all. We welcome all our respected dignitaries, all our eminent speakers, and our dear physical and digital delegates to the valedictory function of the 7th World Dental Sciences and Oral Health Conference, organized by CynoDent International and Indian Society of Dentistry in collaboration with School of Dental Sciences, Sharda University, and International College of Dentists, ICD. The theme of the conference has always been to bring in the future of dentistry now and beyond, and to the reach of all concerned with the fraternity. 30th March and 31st March, we had pre-conference courses along with online and offline scientific presentations. 1st April and today as well, that is 2nd, we had our keynote lectures, offline and digital scientific paper and poster presentations, followed by awards night and cultural program in the evening, and it ended with a blast, that is a DJ night by Cynophoria, CynoDent International. And in the evening today, we all are here for the valedictory function. Tomorrow, that is 3rd of April, we have post-conference courses that will mark the end of our conference by CynoDent International and Indian Society of Dentistry in collaboration with School of Dental Sciences, Sharda University, and International College of Dentists, ICD. Now, to start with the valedictory function, I would like to invite Dr. M. Siddharth sir, Dr. Anmol Bagaria ma'am, and Dr. Ashish Chandra sir on stage. Please give a round of applause for them. So first, we would like to appreciate all the efforts done by the head of the committees who are the faculties of School of Dental Sciences, Sharda University. I would call upon the names one by one, and I would request you to please come and get felicitated. First is Dr. Nitin Bhagat, sir. Dr. Anurag Hasti, sir. Anurag, please give a round of applause for sir. He is responsible for handling the registration committee of CynoDent and Sharda University, and his entire team as well. Thank you, sir. The next one is Dr. Rohit Sharma, sir. These three people are the head of registration committee and they have handled the registration very well. Thank you to all the three sirs. Please give a round of applause for all the three faculty members from Sharda University. Thank you once again, sir. Now from CynoDent team, we have Dr. Sumit, sir. Dr. Sumit, sir. Dr. Sumit Goyal, sir. Thank you, sir, for heading the committee and helping us out. Thank you, sir. Sir has also given an amazing lecture on how to control stress and anxiety. Next is Dr. Yash Sharma from CynoDent committee. Dr. Yash Sharma. Dr. Lakshmi Pandey ma'am, who is a part of CynoDent as well as Sharda University. Ma'am handled everything so well being a part of Sharda University. A big round of applause for ma'am, please. Thank you, ma'am. Dr. Nitin Garg, sir. Sir was also one of the invited guest speaker for the day. Dr. MD Noman Sheikh. He was handling the registration main desk. Dr. MD Noman Sheikh. Dr. Rana Sachin. Dr. The applaud should not stop, please. This is the valedictory function and we are ending this on a very good note. I would appreciate it if we all appreciate it well. Dr. Riddhi. Dr. Riddhi, she is from Indraprasth, Delhi itself. CynoDent committee member, Dr. Riddhi. Aditya Rajbahar. Committee member from CynoDent, Aditya Rajbahar. They all were handling the backstage thing. And thank you for handling it so well. Anshuman Parashar. Next is Anshuman Parashar. Thank you, Anshuman, for handling the backstage memento distribution and everything. Shubham Bharti. Next one is Shubham Bharti. Thank you, Shubham. Next one is Khushi. Thank you, Khushi. Then Dr. Devansh Bhatnagar. Dr. Devansh Bhatnagar. Dr. Devansh Bhatnagar. They are the volunteers from Subharti, the CR from Subharti. And Shivendra Kumar. Shivendra Kumar. Thank you. The CynoDent team, thank you. Now, before starting and moving on to the next category, I would like to invite Jayati. She is the one who handled the lectures and everything, and she was very hardworking. Please give a round of applause for Jayati. She single-handedly handled all the lectures and everything since the past 2 days. Please give a round of applause for Jayati. Now moving on to
a big round of applause for Dr. Anam Siddiqui.
Thank you. So moving forward, we have the students who worked very hard for the success of this conference, and I would like to invite them one by one. First is Dr. Nitika Bansal. Dr. Nitika Bansal. Then Dr. Meha Rai. Is it Meha or Neha? Meha? Dr. Meha Rai. Then we have Dr. Vanshika Singh. Dr. Vanshika Singh. Then Dr. Chanchal Tyagi. Please come on stage one by one. Dr. Rajvi. Dr. Rajvi after Dr. Fiza Alam. Fiza Alam. Anushri Srivastav. Disha Sarangi. Drishti Sarangi. The twin duo, Disha and Drishti Sarangi. A special thanks from Team CynoDent. Not only to Disha and Drishti, but to everyone who worked very hard. Thank you. Kamran Khan. Nishant Upadhyay. Shivangi, Swati Shreya, Sarakshi Patnaik, so here we have Disha, Drishti and Swati. And Shivangi also. Please give a round of applause for them. Sarakshi Patnaik, Amresh Kumar, Adya Baranwal and Kritika Gupta. Sarakshi, Amresh, Adya and Kritika. Sara, once again, I would like to repeat the names. Dr. Nitika, Dr. Meha, Dr. Vanshika, Dr. Chanchal, Dr. Rajvi, Fiza, Anushri, Disha, Drishti, Kamran, Nishant, Shivangi, Swati, Sarakshi, Amresh, Adya, Kritika and Sara. Now moving forward, there is Simple, Sushmita, Dr. Himanshu Bhardwaj, Dr. Pranjalika. Anyone is present here? Dr. Shrish Thakur, Dr. Samir Khan, Pallav Prakash, Shivangi Varshne, Srishti Jain, Janvi Khattar, Nishu Thakur and Jyoti Rai. Then we have Deepanshu Bhati, Gautam Kumar, Ashish, Saurabh Agarwal, Ansh Verma, Gurjeet Singh, Jayati, Dr. Shashank Mathe, Dr. Jyotsna, Dr. Samiksha Gupta, Jagriti, Dr. Akansha Singh, Dr. Arhat, Himanshu Jain, Akshat Nigam, Ajit Kumar, Ananya Gupta, Dr. Ankit Mahajan, Dr. Upasna, Dr. Farha, Dr. Rahul, Dr. Mala Swamthangi, Aman, Farheen, Prajwal Goyal, Paridhi, Sushant, Vipin, Aruj, and Muhammad Asad. Give a round of applause for all the students who work day in and day night for the successful conference. Now it's time for the pre-conference courses. Uddipana Hazarika, Shambhavi Khanna, Uddipana Hazarika, Shambhavi Khanna, Riya Murthy, Bhumika Rajput, Nishu Jayati and Dr. Anjali. I would like all of you to come on stage and collect your certificates, please. For the cultural events, one thing, as everyone has wonderfully and exceptionally performed, Team CynoDent is giving certificates to all, and that is the prize for them, and we highly appreciate your efforts. It was wonderfully and exceptionally done. So thank you and give yourself a round of applause, everyone. All are winners for Team CynoDent and literally, genuinely all are winners. Congratulations to all the participants who handled the cultural very well. Thank you once again. I would then also take name from each committee. You all can come and collect your certificates. From the dance committee, I would like to invite Adya Baranwal, Shruti Yadav, Tia Chaudhary, Diksha Divakar, Khushi Jain, Ishika Gupta, Isha Goswami, Swagata Sarma, Bebichana Guru, Diksha Karmakar, Shreya Mishra, Udipana Hazarika, Shambhavi Khanna and Aman Kumar. Please give a round of applause for the dance committee, for the culturals. You all performed exceptionally, wonderfully well. Thank you so much. Thank you once again, the dance committee for the culturals. Now moving on to the next one is singing. Akriti Kaushal, Disha Sarangi, Drishti Sarangi and Shubhangi. Next we have for essay writing, Varisha Akram, Aina Sultan, Ishika Gupta and Khyati Jadon. Essay writing, Varisha Akram, Aina Sultan, Ishika Gupta and Khyati Jadon. Please give a round of applause for them. Essay writing. Next one is slogan writing and Sushantika Dagar, Swati Shreya. Shushantika Dagar and Swati Shreya. Slogan writing. Then we have for Rangoli, next we have for Rangoli, Bebichana Gurung, Khushi Jain, Ananya Gupta, Anshika Saini and Akshat Nigam. Please give a round of applause. Rangoli. Then we have for face painting, face painting again Bebichana Gurung, Varish Akram, Ishika Gupta, again Bebichana Gurung, Varish Akram, Ishika Gupta, Anshika Saini, Khushi Jain and Anushree Srivastav. For face painting, thank you for the message from your face painting and your art was reflected through it. Then for soap carving, we have Anushree Srivastav, Aina Sultan, Ishika Gupta, Khyati Jadon, and once again, Bebichana Guru. Okay, so she was a part of 3 committees. Rangoli, face painting and soap carving. Bebichana Gurung, Anushree Srivastav, Aina Sultan, Ishika Gupta and Khyati Jadon. And the last one is for poem and shairi, that is a single person, Nishant Kumar. Congratulations to all the winners for culturals. Now I would like to request Dr. Lakshmi ma'am to come on stage and announce the scientific winners, scientific session winners, poster and paper presentation, digital and offline. Thank you, everyone.
Thank you so much, Anam. Good evening, everyone. So in the end, the most awaited thing, the results for the scientific presentations. So first, the table clinic. In interns category, the first prize goes to Dr. Shivam Gupta, Dr. Sakshi Varsne, Dr. Achintya, Dr. Devansh. The second prize goes to Dr. Nishant and Dr. Paridhi. For UG category, the prize goes to Jaya, Kshitij, Samriddhi, and Kanishka. For post-graduation category, the first prize goes to Rashi, Ayushi, and Khadija from our own Sharda University. I request someone from Prostate department to please collect. Next, the offline poster presentation. The first prize goes to Nandini Mehta and Asta Sikka. There's a tie. Another, the first prize goes to Swati Chaudhary. The second prize goes to Yaduveer Singh and Rishabh Sangwan. Dr. Amanpreet Kaur, Dr. Elma Sultan and Stuti Gupta. The third prize goes to Khyati Jordan, Aina Sultan, and Vriti Arora and Mohit Kumar. For next lot, the first prize goes to Asmeet Kaur, Anukriti Kaur, and Anushka Makkar. The second prize goes to Harkirat Kaur Chaudhary, Harman Malhotra, Isha Nautiyal, and Akansha Dangwal. The third prize goes to Shraddha Rawat, Ahana, and Sanjul Kalra. For post-graduation category, the first prize goes to Dr. Upasna, Dr. S. Balaji, and the co-authors Dr. Neha Avasti and Dr. Narasimha Nirarkar. And the first goes to Dr. Vanshika and Dr. Ekta. For the next lot, the first prize goes to Shrishti Jain, Farheen, the second prize goes to Aarti Chauhan. For postgraduate, the first prize goes to Dr. Avinash, Dr. Sakshi Sehgal, Saiba Hassan. Second prize goes to Jia and Harsh. For the on-spot paper, the first prize goes to Manav and Paridhi Chauhan and Nishant Thakur. The second prize goes to Vivek Prakash Singh. The third prize goes to Ashmit Agarwal and Mohit Gupta, Siddharth Kathuria. For the next slot on-spot poster, the first prize goes to Shivam and Devansh. The second prize goes to Kanishka and Kshitij, and Ankita and Jivirya. The third prize goes to Sakshi and Achintya, Vishesh and Anushika. These were for the poster presentation. Now I'll announce the paper presentation. The first goes to Aina Sultan, Khyati Jordan. Because a lot of people are not present here, there's some problem there's a mismatch. So I request all of you who didn't get, please collect it from the reception desk. So I'll just announce all the winners first. First, for the paper presentation, I have already announced. The first presentation goes to Aina Sultan, Khyati Jordan, Ritika Sharma. The next prize goes to Nibha Mohammed, Komalpreet Kaur, Prabmeher Kaur, Dr. Ramandeep Singh, and Dr. Akansha Dangwal and Isha Nautiyal. No, they can. Whoever I'm announcing, if you are present here, please come on the stage. For the next slot, the first prize goes to Aman Kumar and Kratika Gupta, and Jasmine Kaur. The next prize goes to Meher Malhotra, Harkirat Kaur, Mehak Gupta, Simran Kaur, Nishant Thakur, and Paridhi Chauhan. For the next slot, the first prize goes to Dr. Tamanna and Dr. Deeja. The next prize goes to Dr. Pranjalika Phukan, Dr. Himanshu Bhardwaj. For let's move forward for these second day spot presentations. The first prize goes to Dr. Ruksar and Dr. Swati Mishra, Dr. Anam and Dr. Zubira. Dr. Lubna, sorry. The second prize goes to Dr. Gitanjali and Dr. Bazila. On-spot paper presentation. There's a tie. There's three people. The first prize goes to Samriddhi, Dr. Disha, Dr. Shivam, Divansh and Shivam, and Anushika and Vishesh. Second day on-spot goes to Anshika Pandey. The second prize goes to Jaya and Kanishka. The next prize goes to Shivendra, Saman and Jaspreet, Mansi, Manvi and Manav, Simran and Amanpreet, Khushi and Shubham. With this, we are done with the results of the scientific presentations. I request all of you who didn't get, please collect it from the reception desk. Thank you so much. It was a very nice and informative session, scientific sessions. Thank you.
Okay, so there was a mistake with the pronunciation of a name. I would like Dr. Ritik Sharma to come on stage to collect his first prize for scientific paper presentation. Please give a round of applause for him. Scientific paper presentation, first prize, Dr. Ritik Sharma. Those who didn't get the certificate, or if there was a confusion, you can get it sorted from the registration desk. So this was all about the ceremony of distributing the certificates and the award and everything. So now we'll move on to the ending of the ceremony, and I would like to invite Dr. M. Siddharth Sir, Dean, SDS SU, for the ending note.
Good afternoon, everyone. After a wonderful session of the 7th World Dental Sciences and Oral Health Conference, I would like to propose a vote of thanks. I would like to thank our patrons, our Honorable Chancellor Shri P.K. Gupta ji, Honorable Pro-Chancellor Shri Y.K. Gupta, Honorable Vice Chancellor Professor Sibaram Khara, Registrar Mr. Vivek Gupta, the Chief Guest of the function, Dr. Pavitra Rastogi, President UP State Dental Council, the guest of eminence, Dr. D.N. Kapoor, Regent ICD. And I would like to thank the team from CynoDent, Dr. Anmol Bagaria, the CEO, Dr. Ashish Chandra from CynoDent, then International College of Dentists. And I would like to thank Dr. Sukhdeep Singh, Chief Organizing Secretary from SDS, Dr. Nitin Bhagat, the Co-Organizing Secretary from SDS, the registration team from SDS, Dr. Anurag Hasti, Dr. Rohit Sharma, Dr. Siddharth Rawat, then the scientific team from SDS, Dr. Deepak Bhargav, Dr. Dinesh Kumar Bagga, Dr. Ekta Chaudhary, Dr. Ashish Chaudhary, Dr. Hemant Sani, Dr. Swati Sharma, Dr. Rohit Punga, Dr. Mahinder Singh, Dr. Dheerja, Dr. Lakshmi Pandey, the team from pre-conference course from SDS, Dr. Radhika Gupta, Dr. Ankita Pal, then the marketing team from SDS, Dr. Jayant, the reception team from SDS, Dr. Vidya, then the transport and accommodation team from SDS, our assistant registrar, Mr. Vivek Chaudhary, also he played a big role in organizing arranging all the venues. So big round of applause for Mr. Vivek Chaudhary. Then Dr. Rahul Sharan from again transport and accommodation. Then from hospitality, Dr. Mithilesh Mishra and Dr. Neha Avasti. Then from transport department, Mr. Avdesh Tomar, big thanks to him. Then security, we would like to thank our Chief Security Officer, Dr. Colonel Rakesh Arora. We would like to thank the Public Relations Officer and the department from Sharda University, Dr. Ajit Kumar and his team. Then the Estate Department, Mr. Indapal, for providing us this wonderful auditorium. Then from IT, I would like to thank Mr. Bunty, Mr. Vipin Chauhan. Then the gala event yesterday of the cultural committee team organized by Dr. Pallavi and Pallav, and all the participants who took part in the cultural event yesterday. A very big thanks and applause to them. They did a wonderful performance. Then I would like to thank the MC, the Master of Ceremony, Dr. Ainam Siddiqui, who did a wonderful job, Dr. Jayati, then Dr. Shivangi Gaur, and I would like to thank all the UG, PG students, volunteers, all the participants from various dental colleges, from all the dental colleges who have come, all the participants, and all the participants and members from Team SDS and CynoDent. A big thank you.
Thank you, sir. Now I would like to invite Dr. Anmol Bagaria ma'am, CEO CynoDent, for vote of thanks.
Good evening, everyone. I would firstly like to thank our audience, the online delegates as well as the offline delegates who have traveled from various colleges, various states, and made it possible here. Thank you for joining us. I would like to thank all the faculty members of School of Dental Sciences, Sharda University. Here we have 3 people who were the backbones. Dr. Anurag sir, Dr. Nitin Bhagat sir, Dr. Rohit, and it was under the leadership of Dr. Siddharth sir, the Dean of School of Dental Sciences, Sharda University. Thank you, sir, for your tremendous support. Thanks to all the faculty members, UG students, PG students, all the head of the departments who have actually helped us. And thank you for the students who are still here and helping us out. Thank you very much. I would thank Team CynoDent members, Dr. Yash Sharma, Dr. Lakshmi Pandey, Dr. Nitin Garg, Dr. Anam Siddiqui, Dr. Noman, Dr. Rana Sachin, Dr. Kansha Sinha, Dr. Riddhi, Dr. Aditya, Dr. Anshuman, Dr. Shubham, Dr. Misbah, Dr. Ankit, Mr. Kushwardhan Singh, and all the team members who are still supporting us, working from the, as we have online delegates also, so we have online team also who is still supporting us. And I would also thank all our patrons, Dr. Stephen Cohen, Dr. James Gutman, Dr. D.N. Kapoor, and I would also thank and I would pay my gratitude to Honorable Dr. Pavitra Rastogi sir, who was the chief guest for the for our event. He's the UP DCI president, and I would lastly again I would thank all the audience who have joined us in the online mode and who are present here in the offline mode. And also a big thank you to Dr. Sumit Goyal sir for always supporting us. Thank you, everyone. And I would just say that every ending is a new beginning. So it's not just an end, it's a new beginning. And also, we are having tomorrow the post-conference course. So be there for that and have a happy day tomorrow also. Thank you.
Thank you, ma'am. Now I would invite Drishti, Disha, and Akriti, and I would like you all to stand up for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविण उत्कल बंग विंध्य हिमाचल यमुना गंगा उच्छल जलधि तरंग तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you, Drishti, Disha, and Akriti. I would request Dr. Ashish Chandra sir, a senior fellow from International College of Dentists, to pay his regards to the audience.
Thanks a lot, everyone, for coming here and making this event a grand success. Thank you. Thank you, everyone.
Thank you, sir. Once again, thank you, everyone, for making this conference a successful one. This is me, Dr. Anam Siddiqui, signing off, and I would request you all to proceed for the high tea. And if there is any confusion or if there is any problem with the certificate or name or anything, you can all come to the registration desk and get it sorted. Thank you. All the registered delegates with food and hospitality, please proceed to the high tea. Please proceed for the high tea.